he finished surgery late, but he will be attending shortly before he starts his lecture today. So I hope the others will be part, because this is actually as the first webinar, and I'd like to have everybody say hi and meet everyone, meet everybody.
Hey, Lucas.
Oh, Lucas.
Oh, Lucas.
Hi, Lucas.
Hello.
Hey, hello. Hi, hello, hi.
Good to have you.
Glad to see all of you.
Thank you.
Lucas, sorry, Mike.
Hi.
Is Sanjeeva with us as well? I thought he would be coming as well to this webinar.
Pablo, your face is very serious.
Whose face?
I think his image is blocked.
Oh, yeah.
So I think for the sake of time, I'm going to start this first webinar. I'd like to welcome all of you, the honorary board members and the executive members and all the active members and their functionality. Actually, I hope that everybody will join at some stage. And this is actually the inauguration of our first webinar, the International Academy of Neurosurgical Anatomy. And I thought this is give a combination of a science and a clinical practice. That's why we selected this name. And of course, we have to find some name that is not duplicated for other agriculture or commercial events. And this will be registered hopefully in Dubai. And I have submitted the paper and the bylaws. And I'm hoping that during the meeting at the World Federation meeting in Bogota next March, that we will have on side some short meeting that we can interact and have some communication recommendation. And if somebody want to improvise on this bylaws, I'm open. I'm just submitted for the sake of moving on. I have communicated our intention with the World Federation, with Professor Zico Nelson, so there won't be any contradictory. If anything, I want to announce it on this podium that we are embracing all society, association, centers, academic centers, groups to collaborate with, and we are open-minded and we want to work together toward one event, which is education of young trainees and young neurosurgeons without boundaries and free of charge. It's a charitable academy or science. And unfortunately, I cannot start this webinar without giving a 1 minute of silence in tribute for our dearest lost Fred Gentili. And we are dedicating our next webinar in April purely for the aggregation of Fred Gentili and his lifetime achievement. It will be a tribute for him. So we defer it for the April. I have submitted something on the internet for him, and it was distributed. And unfortunately, he passed away on the 15th of January, embraced by his family, his wife, Gina, and the 2 children, David and Michael. And from this podium, on behalf of all of you, we will extend again our sorrow and condolences to them. We have on the other, so we'll stay 1 minute, please, of silence for Fred. Thank you. The only one who was not silent were the birds, and I think this is from the paradise where Fred is laid off. I can hear some birds in the background of one of you. I would like to welcome Luciano, he just joined, and Giovanni as well. And we have a great events for today. And again, it's an overdue, is the recognition and lifetime achievement of the great work of Professor Yoko Kato. I know Professor Yoko for more than 20 years. Professor Yoko did her MD from Aichi University in Japan, and then she moved to Fujita, where she got her training and promotion to associate professor, and then she became professor, I think in 2006. And she initiated many events that support education around the world, especially for less privileged countries. I was with her on several webinars and hands-on courses, and all of you, I'm sure, we were everywhere with her, and she is the lady that cannot sit. She is always on the move and always proactive toward education of young generation. She has contributed. She was a great advocate for women in neurosurgery and for her right and correct. And she initiated in the 90s the association of, or the Society for Women in Neurosurgery, first in Japan and later on in the Asian country. My residents, they love someone who called Yoko Kato, and they follow all her records and tracks. She is an expert in the field of minimally invasive and vascular surgery, especially in aneurysm and AVM. And I think she has several awards. She is Medal of Honor holder from the World Federation in 2019. She was granted this award, and she was granted another award from the American Association for her lifetime achievement. And I think that's why I said overdue. We are giving her the recognition for her lifetime achievement. I think without further ado, that first session will start, and this sessions will be chaired by, let me see, I am part of it, so I will be starting, and I have to see the program.
Vladimir and Perez.
Vladimir, okay. All right, so we will start with the first lecture of Professor Yoko Kato about training and education. Yoko, the podium is yours.
Thank you very much, Matt Cannon. So my congratulations of your inauguration about International Academy of the Neurosurgical Anatomy. Maybe we can call Yana. Is okay?
Yeah.
Yeah, Yana. Yes, it's fine.
Yana.
I think, yeah. I'm very honored to be accepted. The first webinar speakers. I was asked by Matt Cannon that maybe 2-3 months before. So you should be first speaker of the inaugurated session. I was very embarrassed because I thought I am a bit younger than everybody, so maybe I'm getting old, I think, because Ramesh is my student, of course. Now he is a great neurosurgeon in England. So anyway, I congratulate. I think this society, the premium society, will develop the more and more with more people, and especially you can involve the more younger people. So I want to share my slides because.
Yes, please go ahead.
So something wrong.
Yes, we have it.
Oh, thanks. So because I will use the many slides which you have shown already. I think today's my talk is about training and education in aneurysm surgery. So before my start, so I'm very happy because I have so many senior teachers, which who are almost involving of this society, I think. So this is one of the face-to-face conference which was held in Zimbabwe. Professor Kalangu was host. And always besides me, there's so many teachers, such like Imat Cannon, also Vladimir Benich. So I think we had so many sessions, and also we include the awareness session. I think exchange of the awareness, the opinion is very, very important. After some teaching, we moved to the hospital. Maybe some of you are very well remember, and so we brought the pentero microscope, and this is huge meningioma cases. And also, there's so many awareness was the first time to see the pentero microscope. They were so happy to see and touch the microscope. I think the face-to-face education is has a lot of meaning. It's not only see each other, but also they can learn and discussion and talk senior professor. And also they can see the surgery from the beginning to the end, and how to hold the instrument. Everything is included in this kind of live teaching course. So this is a YNS session. Yeah, the second day we had again the session in the room. So this is Imat Cannon is doing the surgery, pituitary surgery. I remember. So I think one more. So this is the Imat Cannon is the sitting beside me, and this is Uzbekistan, and the simultaneous translation, and they can and followed by the surgical demonstration. And also this kind of the dinner time was very, very nice. And at the time we had an exchange of the MOU, and also I attended of the some thesis presentation. Even I cannot understand the language, I think it was a very nice experience for all of us. So today I just share with you is what is the role of the open surgery. Of course, the space occupying ICH more than 5 millimeter, and MC and the pericallosal aneurysm location, and the blister type of the aneurysm, and also the failed endovascular treatment, and also the retreatment after coil aneurysm, and also the young age and good clinical grading. So this is one slide from the paper from the Korea. So even Korea is already 2012. Already the coil is almost excess the clipping, because we have so many fantastic instruments in the endovascular field, the day by day. So this is many times I showed So even the hybrid neurosurgeon is getting popular in everywhere. I think in Japan, of course, because we have more than 10,000 neurosurgeons, and also the half of them has both board certificate, so they can decide themselves. So how what is the indication and what is the best the treatment for the one case. And also the giant aneurysm with the partially thrombus. This is still, it's a very difficult, tough case, I think. Even flow diverter is getting popular now. So of course the bypass surgery, so on. So this is a totally different from the usual large type or giant type of the aneurysm, because it has the huge edema and also the mass effect, and also the inside of the aneurysm layer by layer. So this is behavior is totally different. So this is some mechanism. So extrinsic factor and also intrinsic factor, and also the mural hematoma. So this is come to the fusiform aneurysm and also partial thrombus, and also come to the direct of the subarachnoid hemorrhage. So we should learn or know the mechanism. And this is the one case of the patient, younger, the female, came to us with infarction. So, but it looks like a usual, the small, the large type of the aneurysm, peculiar case. The patient onset was infarction, and the patient has infarction and basal ganglia. So for this case, so we did, we made a plan to put one STMC bypass, and so the first we harvest of the STA and peel the muscle and cut the dura, and also we should be careful the which side we can dissect the vein, severe vein. Now we can see already the aneurysm. So partially thrombus, then wall is very yellow. And here is a 3 branch. This is an amila 3D image before the surgery. So we cannot see clearly because it's very thick wall of the aneurysm. So maybe the thrombus is inside. So for this case, we made a plan. One branch should be can be sacrificed and puts low flow bypass. So this is one role of the open surgery, even the endovascular era, I think. So this type of the bypass, everybody, especially the young doctors, can master. So this is the rear side and the superficial side. Also, we put the 12 stitches. So here is the stitches part. Then we cut the branch from the aneurysm. So here is the cartoon showing the STA, and this part we sacrifice and cut. And then we reconstruct of the aneurysm. So here you can see this branch is almost the thrombus with the thrombus. So how you can reconstruct of the aneurysm? You can think about when you see the aneurysm. So this is partially we cut the aneurysm, and almost 80% is thrombus inside. We can see. So this is one of the role of the open surgery, and this is a partial thrombus of the after embolization of the cavernous sinus giant aneurysm. So before surgery, we always make such CFD. So this is a pressure and wall shear stress. And this is a vector. So there are some pattern. So then we can understand which part is the scene and the thick wall. And this is a usual IC bypass and IC ligation. So this is very first it was clipped, but already the clip has gone from the aneurysm. And the second step, the aneurysm was embolized, but again recanalization. So the radial artery is harvesting, and then we can put the radial artery come to the M2. So usually we preparing about 17 centimeters for high flow bypass. And this through the tunnel, we the radial artery come to the M2 part. And the bypass has almost the finish. And this is a cervical part is connecting. So I think, of course, flow diversion is one of the way, but still we don't have a 100% of the proof with flow diversion stent. So that is another option for open surgery. So the CFD is very, very interesting and important for us. And this is just this the recent technology. And this is parameters, 4 parameters: velocity, pressure, streamline, and vectors. Then with combination, we can understand which part is very thin. So this is a high pressure, and also the streamline is like this, and also this is a vector. This is some burst. And recently we published a paper. This is parent artery radiation sign, so-called PARS. So this is the usual aneurysm, but just adjacent part is a very thin part. So this is, of course, we can treatment by endovascular, but this, when we find such a PARS part, then this is another the role of the open surgery, because this is the aneurysm, and this case is very adjacent of the original the aneurysm, but sometimes this part is something like here, here. So this is very high pressure, and also this is very divergent. So this type of the aneurysm, this is just adjacent of the original aneurysm. So the aneurysmal investigation is very interesting for me. So this is the giant both side of the cavernous sinus, and the patient has Ehlers-Danlos syndrome. So that we send it to the pathologist, and this is a pathology. So decrease the collagen in the vessel wall of the EC, which we took during the surgery. And this is again the wall pathogenesis of the giant or large type of the aneurysm, the vasovasorum. So this is the corresponding of the enhanced MRI part of the aneurysm. And this is which I always use this slice. This is a partial thrombus of the posterior fossa the giant aneurysm. And this patient came to us. Then finally, we trap and open the surgery. So this is vasovasorum. This is one of the cause of the aneurysm growing. The small networks of the blood vessels which supply the wall of the large vessels. So this is a vasovasorum. And this is another small one. Is on the tip of the sac with yellow wall set for analysis. And again, this part is a very thick and a fibrous thickening of the intima, and also this is a thickness accumulating of the fibrous the part of the membrane. So when we investigate of that and also the step of the growing of the aneurysm, the histopathological findings suggest that this part of the aneurysm wall was completely stabilized due to remodeling. So this is the aneurysm formation. So this is the initial part, but this can be the remodeling, the stabilized. Then comes to the next wall is a new bleb, the development. So this is our mechanism, how aneurysm grows. The one is the thrombus, the progression intraluminally, and also macrophage infiltration of the neovascularization and the microbleeds and the thrombus in wall, and also the mural degeneration. So this is the almost which I talked. So from here, just I want to tell my life. So this is my hospital, just 8 minutes from the Nagoya station, the Shinkansen station, and this is the main the hospital. And this is the fourth hospital, which was created a few years back. And my life is, of course, vascular, the cerebral vascular surgeon. And my work is improving a patient's quality of life. Maybe this is the same as all we, I think, my philosophy. Career is a good collaboration with other organizations and societies, and the contribution of the opportunity to the young blood neurosurgeon. Teach them the knowledge and the surgical skill, and support YNS and women neurosurgery to improve their current and future work. So the helping improve the patient outcome, especially the developing countries, just volunteer work. So the late Professor Kano, that he started something like the same work, because I just succeed his spirit. So he is doing the surgery, and many of the foreign guests, students, fellows, watching his surgery. And not only the doctors, but also the nurses. And also this is which I succeeded from the late Professor Kano, SNS, KK12, and maybe some of you is sitting. This is Nigeria, the meeting, and the right side is Elizabeth someone. And also, this is not Myanmar, Cambodia. So the young doctors are very, very, very focusing on their talks. I think that these the teaching for the YNS is very important from very basic things. So one teacher arrives in the morning and back to in the evening, something like this. So this is, and also the how we can teach of the era of the pandemic type. Of course, it's very restricted to travel. And the virtual reality, the simulator, maybe the Broadtree will talk the virtual surgery later on, and also the such kind of the webinars, and also alumni activity. Also, they have once a month the webinar, and also the as a SNS we have collaboration with Africa, such as Moody Krish, such kind of foundation is in this summer seminar or the winter seminar or resident webinar. So many webinars we carrying on. And besides that, the Asian Journal, we are migration of the some company to the CIMA very soon. But I think this is there's also the late Professor Kano. He studied the open eye for the young doctors, especially from the developing countries, to have a habit to write papers, even the case report. And this is a winter seminar, and also this is alumni. This is one alumni society which was created in India, and also this is alumni once a month the webinar, and also Dr. Brogy and also the blood lead we created. It means that this is founder. It was founded in Italy, so this is the founding members. I think Brogy is standing here, and so many members, maybe you know. So this is I went to the Florence so many times, and Professor Passo, and this is a husband of the Lincoln, and we created the nice society. It's a time to minimally invasive. This is an inauguration which was held in Florence. So many people, and also the Vladimir Medish was sitting somewhere, I think. And also, of course, the women neurosurgery is very, very important because it's increasing of the number, especially the women in neurosurgery of the Japanese is 700 now, but still the less than 10%, very small numbers. So this is a paper, the Abida Shah from the Mumbai, she wrote for me. And also I focus on not only the resident, but also the future important person is, of course, medical student. This is the medical student which I went to the Nepal. So many medical students was attended at the time. And also it's very nice gathering. And this one more thing is this is a nurse, and the nurse is another very important because a nurse practitioner maybe every country has, I think. So we must educate them, and we must increase them, that they can help us a lot, I think. And also the donation, the instruments, and also especially this is a very primitive microscope, the Pico. I think it's very important. We donate some instruments, then we visit that countries, and we do the surgery together with those instruments. And finally, just the small talk, empowering the quality in the human prior to be the neurosession. So deepening self-awareness and leading with honesty and improving coaching skill and good influencer, and also the intention, how we can manage your intentions. So the 7 ethical issue of the which neurosurgeon must be aware. So those 7 things is very, very important. And this is almost a final slide. Is the top 10 things patients is looking for in the neurosurgeon. So I think lifelong learner and willingness to discuss alternative approaches, and honesty, and personalized approach, and unrushed the manner. Those things is very. So Finally, just we had the webinar and also the John Cello was the chair. Do no harm, stories of life, death, and brain surgery. The Henry Marsh, everybody knows, I think he's from England. He is the father of the ethical dilemma issue and provides the concept of the do no harm in such case of the hopeless care in Neurosession. And also one more thing is this is charity, or everybody knows. So regardless you like him or not, but he had an experience of that 24 years pianist with a brain tumor, like given 6 weeks to live life. But after the tail surgery, 12 hours, the long hours, the surgery, the days later, he was back at the piano. And I think the skill and the humanity and many things is very, very important for the good neurosurgeon, but we should be the good, the human. So this is my talk summary. So you can read. I think longevity and the sustainability of the neurosurgery in providing education to the next generation. So I think the challenge is my like the word. Thank you for your attention.
Thank you, Yoko, for this comprehensive coverage. For your you deserve this recognition for your achievement in education and teaching. There are two questions from Dr. Harshad Barak from Mumbai. Heparin for bypass. Do you use heparin? Dr. Yoko?
Yes, please. Once again.
The question is, do you use heparin for the bypass procedure?
Yes, just irrigation.
Irrigation, just with saline.
Just the irrigation of the vessels.
With the
not
saline. Oh,
yes.
heparin local only.
Yes, local.
Okay. What about Doppler to check flow after the bypass?
Yes, after bypass, Doppler and ICG.
Okay. Any from the panelists would like to have one question or comment, please? Well, okay, seems none. You cover all the aspects of that subject. And before I move to the next speaker, I would like to welcome Vladimir. He was busy. He just joined us. Hi, Vladimir.
Hi, Klimat. Hi, everyone. I'm sorry for being late.
Don't worry. But before
Hi, Vladimir.
Hi, Kazadi.
How are you? Congratulations, Vladimir. You are current president.
Before I commence to the next speaker, which is Giovanni, I'd like to give the podium for 1 minute for Vladimir. He was planning to speak at you as a president of this academy. Vladimir?
Oh, yeah. Hello, everyone. Good morning, good evening, whatever you are. I would like to share the screen. The interaction of the International Academy, I suppose that Professor Kanan already told that this is the successor of the Neuroanatomy Committee, which belonged to WFNS and which started in 2014. And over the years, we were happy to collect or get together really good people, good friends, extremely creative colleagues. And I believe that under the auspices of the academy, we shall continue to spread the further knowledge about the neuroanatomy. What is it about? There are three aspects. That's the knowledge, which is real basics, and which means learning. We need to learn, everyone needs to learn, and we hope that we shall help by teaching. The next step is the trade. It is the profession. You must know your profession and have some dexterity before you really start being a neurosurgeon. That's for residents. It's practice, practice, and practice, and the courses. And only then comes the art of neurosurgery. And neurosurgery is an art, definitely. It's such an exclusive discipline that it's cannot be approached like, let's say, just a curative form of medicine. And it's how to perform. And I would like to show you that it's the same really in arts with my favorite painter, Salvador Dali. You see the drawing. He must draw before he can really paint a big things. So that's the trait which everyone needs to learn. And we hope that we shall be able to teach and we shall be able to give some knowledge. Only then you can go to real art and you must know your anatomy. You see the hands, they are perfect in its anatomy, but you must really start with the basic normal anatomy. And let's say that this picture is like aneurysm, when all the structures are at its place, are not moved, and they are precise. But only then, after, you really go to big art, and it's distorted anatomy in our hands. It's distorted by the tumor, distorted by any mass lesion. And then real arts come. And I believe that we all in academy will strive to reach this level of, let's say, teaching, this level of performing, and this level of enjoying all the neuroanatomy and all the friendships and all the courses and all the webinars together. Thank you, Imad, for giving me this space.
Thank you, Vladimir. We'll move to the next speaker, Professor Giovanni Broggi. He will talk about visual surgery as a training to young and active neurosurgeon. Professor Broggi kindly accepted to be a vice president of this academy. Go ahead, Giovanni. Unmute yourself, please. Unmute yourself, Giovanni. Or is it freezing in Milano? That's why perhaps the sound is not reaching. Okay.
Okay, I will. Do you hear me? Yes? Okay. So let's go with this presentation. First of all, I would like to thank Vladimir and Imad to give me the privilege to be part of this wonderful faculty, and that will be improved during the time, but to be the first one that is giving tribute to Professor Kato. Yoko Kato, in this lecture that she showed, was really covering all the aspects of vascular surgery and what are the meaning of the teaching. I try to improve this. Did you see the slides?
I cannot see them yet.
Not yet?
No.
Okay, let's go back. Let's share the now?
Not yet?
No.
I need to take away this. Okay. Sorry to be. Okay, I try to share again.
Yeah, it's coming up.
It's
Coming now?
Yeah, it's only part of it. We don't see it fully. Yeah.
You see now?
Yes. You can maximize it now.
Yes, I will. Okay, finally. So after what Yoko Kato showed us about the training for vascular neurosurgery, our contribution from the Best Institute is the virtual surgery program. And that is something that we would like to share with you and to eventually discuss with you. So great honor to Yoko because of what she did for many years in the training of neurosurgery, spreading the the message to worldwide community. So the question is how to become a good neurosurgeon, and the second one is how to remain a good neurosurgeon, and what is the possibility to share the planning for the tomorrow morning case, and the virtual simulation may be the answer. And we think that is the answer. So how we can become a good neurosurgeon? First of all, neurosurgery is something that is a job that you can steal from your master. Neurologists can visit, 10 neurologists can visit the same patient. We can operate only one patient. Each of us, with our assistant, is I have the responsibility to do the surgery. So first of all, this is very important. Second is the shape of the learning. We start as a student, we become a resident, we become the board, and after we increase our ability till the certain level, and we try to remain there. But there is one big problem about all the surgery, but neurosurgery in particular, and is the malpractice problem. So complication is part of the surgery. As Bernard Shaw was saying, no omelets without breaking the eggs. We know that every simple gest of surgery may have complication. And how to decrease the complication rate? First was proposed for some years ago the technology of stimulation, and we have to learn from the aviation experience. You know, from when the aviation flight simulator are introduced in the training and in maintaining the training of the pilots, the number of accidents decrease, and in a very sharp way. And we try to apply the aviation model to the neurosurgical scenario, and that's we reported that in Neurosurgical for some years ago. Third issue, from reality, from theory to reality, from the books to the patient. Of course, as Professor Cato showed, cadaveric dissection is a wonderful training, but again, is very complicated. It's in a way expensive in terms of items that each of the students can use, and that is the limit. But that is the path, a step that every one of us had, and maybe is still doing. So the NeuroSTEAM Center will propose a kind of not alternative, but complementary work on that. What is the goal of virtual surgery? The advised selection of the resident. When a residents come, when young students come to you and say, I would like to become a neurosurgeon, you have to teach him, give him advice. Many years ago, I knew Osepian, that was the chairman of the in New York, and he was selecting the residents, giving a orange knife and fork, and said, peel it. And that is to check the manuality of the residents. The second point is training the surgical skill. For young and not so young neurosurgeon, as a dinosaur like myself, I have to check if my ability to do surgery is still good enough to perform it, or to just say, okay, that's it, stop. The other things is, as Yoko was saying, planning the tomorrow morning case, discuss with the team, have opinion, share the opinion with the other, confront with this. And it's good training for the resident, for any case that will be operated on in your center. And with this system that we have, we can control in the interoperative what the planning was done the day before. And the third, but last but not less important, is the real informal consensus that you can give to the patient, why you can show what you plan to do with the patient itself and for the family. So that's another big problem, at least in the Western world and in IFRI in particular. And that is the informal consensus is just giving a good way to reduce legal problems. So let's show you some example. That is something that you can do taken away in a lab without going to the surgical part with all these instruments that we have. In Besta, we have different type of system. One is manual Dystricity. I show you what does it mean, manual Dystricity. So this gentleman in normal street jacket may check his ability, as you will see later on, to prepare for a bypass. And that is very important because each of us can go to and get chicken wing to try to do bypass, resident, not resident, all the neurosurgeon. But if you have to check if you are able enough to do it. You see here is very simple, but you have to have the ability to coagulate, to clip, and to cut the vessel. Again, for manual Dystricity, we have another possibility. You see here, you have the case, you can put the case inside, and you can actually operate the case with this instrument. You will see that the hands of this gentleman, of this neurosurgeon, that is trying to do the surgery of a case that was operated on some days ago. And again, very simple things. Ventricular drainage. And young residents have to learn and before going to the operating room and to perform it. And this is a very simple with this system. Sorry. You see, this is a simple training for doing. And of course, you can make the hole. And you can insert the catheter, and in this model and with this system, you can check where the catheter is going, where you place the catheter, and that is quite important for a very young neurosurgeon that the first time that they have to do ventricular drainage. Third ventricular endoscopic ventriculostomy. With this system, this model, you can use the endoscope. Of course, that is handled by the system, but you can use it and try to do the intraventricular navigation. This is one of the cases that you can introduce in the system, and of course, the patient can be safe if the surgeon is able to do this kind of performance. Very simple, but very important one. Frameless biopsy. And again, you have the possibility to check where you are going to perform the system. With TNS approach is another possibility. You can have a surgical case and introduce this case into the system. So The surgeon can perform the case. The resident of the young neurosurgeon can operate the similar case, the same case, but making his own experience on this. And again, for tumors, is the same things. You can plan the craniotomy. You have the relationship with the vessel, with the tumor itself, and it can be, let's say, virtually operated without any problem. Very simple case, convexity meningioma, where to do the flap, what are the relationship with the vessel, with the venous drainage, and so. So this is another way. And immersive touch is just to understand the feeling of the elasticity of the brain during this modeling. That's very fast because Yoko showed very good things. But again, this is a case of vascular aneurysm you see here. And of course, from the outside, you can have all the advantage to see the relationship with the vessel and to plan the clipping and maybe to choose the clip himself, like in this particular case. Again, is a similar case. This the middle artery aneurysm with all the perforator aside, and of course you can perform the craniotomy, open the dura, and at the end clip the aneurysm. And this can be done 1, 10, 100 times till you are able to do it in a very perfect, or let's say secure way. Again, for a question of time, we shift this one. And you see here again that you can imply all the imaging that you have in your planning of the case. This is this AVM, and you can teach the resident and decide yourself what is the best approach, what is the best closing, and what is the best strategy to take away the MAV. And for the this tumor, skull-based tumor, is the procedure test. The advantage is that with this case that you discussed with the team, you can check during the surgery okay. You can check what the chief surgeon is doing, and the resident can learn how to do it. Also, if they have the possibility to look into the microscope, because microscope is only for one. With the aesoscope, it will be easier, but I think that teaching is quite important in this way. Another tool that can be used is the intraoperative ultrasound. Intraoperative ultrasound are quite important because when you can check in any moment, and the best the Macon Perrin showed this possibility not only to have the image and to learn how to learn the images, but to have the possibility with the simple app in your mobile phone to train yourself to see the images of different cases and to learn how to read these images that are quite different of the MRI that we are accustomed of, and so. So as you say before, what is the virtual surgery? Selection of resident, but also training for young and not so young neurosurgeon. You can choose different system, the neurotouch, immersive neurotouch, the ultrasound navigation, just to single case and to teach to each of your resident and young neurosurgeon, and as I say again, not so young neurosurgeon. So this is the methodology: from OR to lab, simulation, lab and come back again, and to have the control in OR of what is your planning. This type of virtual surgery training was proposed to the ENS in a different situation. So I'm asking the International Academy of Neuroanatomy if it's not worth to have a session running every month or every 2 months for all the people that would like to use this type of approach. Because the meaning could be, as for the aviation, all the pilots are worldwide certified. And I think that also neurosurgeons should be worldwide certified in a certain moment. I don't know when, but this, the virtual way and to do perform and to discuss the case may be one stop. This is the team, as you see, different university. And I thank you for your attention and I thank you again for the privilege to pay a tribute to Yoko Kato. Thank you.
Thank you, Giovanni, for this very illuminating, not only futurist, now it's a contemporary presentation. That's true. Any comment from the panelists or any short comments?
Can I ask a question, Imad?
Oh, of course.
Giovanni, really interesting talk. Sorry, my video is not working. It's Sanjeev from Oxford. We're doing something similar using virtual reality because we can't run our cadaveric courses in Oxford at the moment, fallout from COVID and things. But I have a question. I was very impressed by your tactile simulators. And when I tried them or seen other people try them in the past, I've seen, so I think the virtual reality is excellent, but I've seen very experienced surgeons do very badly with these simulators. And I'm just wondering, for various reasons, I'm sure there's a lot of confounding and bias, but I was wondering, how do you correct for that when you're assessing, you know, whether someone is competent or for a procedure and things like that?
Well, I think the only way is like in any sportive training. Do again, do again, do again. As it's true, young are better than old. When I'm using this tool, I'm using 10% of the tool. My nephew of 10 years old are much better than me. But you have to train. I agree with you that virtual surgery is not so easy, but it is a way to train yourself and to check yourself and mainly discuss the case that you have to operate tomorrow with the resident, with your colleague.
Francesco?
No,
May I say, Giovanni, of course, I know very well the great activity of the best institute on simulation, and I congratulate Giovanni for this presentation. My question is, I know that you evaluate also how much the residents learn from a simulation course. And probably for reasons of time, you only mentioned very briefly this aspect, which is very important in my opinion.
I completely agree, Franco. I think that you can follow the training of some residents, and sometimes you have to say to a resident, listen, go back to do neurology. Your hands are not so good for many reasons. I cannot play piano. There is the pianist that's fantastic, but not all are the same. So it's exactly, and it's a way to check your training and check your team. I completely agree with you.
Vladimir?
Giovanni, do you see some difference in residents who were grown up on this PlayStation and those who didn't?
Yes.
In video games.
Yes, absolutely. Our generation never played with video game. And we have to learn to use endoscope. And we have to use exoscope. Young neurosurgeon that was training from when they was 5 years old to play with the video games, and that's better, and they learn easier. So I think that is very important. And I'm not pushing the residents to go back to video games, but I push the residents to go and try to use this tool. It's available. I mean, you can play once a day, but you can play 10 a day till you are getting good. I completely agree with you. There is difference.
Giovanni, you have to send us to the PlayStation back. Do the genetic explantation.
Yes.
All right, a wonderful presentation. Move to the next speaker. It's a very interesting terminology, clipology, the art of aneurysm clipping, and will be given by our colleague from Argentina, Professor Matthias Baldoccini. Matthias?
Thank you very much, Imad and Vladimir. Congratulations for this first webinar of IANA, and happy to be here in this webinar dedicated to the lifetime achievement of Professor Yoko Kato. And it's a huge pleasure to me to talk about this topic because we have learned a lot from Yoko Kato, from her books, chapters that she wrote during these years of such successful career. Clipology is a new name that had been introduced into the neurosurgical terminology, and it refers that you need to know our armamentarium of the different clips, and it is important to study previously each single patient, because there are many different kind of aneurysms, because we have simple aneurysms like these saccular aneurysms, but sometimes we have complex aneurysms that should be reconstructed using different in tandem clips, or you need to make a reconstruction. If we need to say in other words, really the clipping technique or clipology is really an art form, and sometimes we can have a plan A before to the surgery, but you need to be versatile during the surgery, because sometimes once we expose the aneurysm, we need to change our plan E to our plan B, C, D, or different kind of strategies for clipping. Sometimes we have a simple clip and a simple aneurysm, a saccular aneurysm that could be solved with a simple clipping technique, but sometimes we need to reconstruct the aneurysms with multiple clipping techniques, with overstacked clipping, in tandem clipping, and different kind of clipping techniques, as in this case that I am showing a complex giant carotid ophthalmic aneurysm that had been clipped using 5 different clips. It is in close relation with the shape of our aneurysm. Sometimes we have these saccular aneurysms, but sometimes we have huge or giant aneurysms with a lot of calcium and cholesterol plaques in the wall of the aneurysm, or some thrombos inside of the aneurysmal sac, and the resolution with clipping techniques sometimes could be more complex. These are the different techniques for solve different kind of aneurysms. This is a simple clipping, multiple clipping with stacked clip, multiple clipping in intersecting clips, in tandem clips with these fenestrated angle clips. In other words, we need to know the whole clipping clips armamentarium that we have in our operative room to solve our problem. Sometimes the first option every time is the best. If we can clip our aneurysm with a simple single clip, is the better option, but sometimes it is not possible. And different type of aneurysm, this contour clipping with angle fenestrating clip, different kind of clipping technique described in this beautiful book from Professor Michael Lawton. And sometimes for some fusiform aneurysm, we cannot reconstruct with the direct clipping of the aneurysm, and we need to perform a wrapping technique using different kind of elements. And sometimes we can reconstruct the aneurysm using fenestrated straight clips in tandem, one in the side of the other, and reconstruct the lumen of the vessel again. Using these different kind of techniques, sometimes we need to trap the aneurysms and use the suction decompress of the sac in order to reduce the force of the aneurysmal sac due to the blood entering in the neck of the aneurysm. This is a case. This is an in tandem aneurysm, carotid ophthalmic aneurysm. It isn't a kissing aneurysm because it isn't in contact between these two aneurysms. We can observe here a complex aneurysm, the proximal aneurysm, the distal aneurysm that should be that had been clipped using different in tandem aneurysm. The proximal aneurysm, I use 3 clips for solve the problem, and the distal aneurysm, I use 2 clips to solve the problem. Sometimes we have these hard walls of our aneurysms, and when we put the clip, the walls didn't collapse totally, and sometimes we have positive Doppler control, but we need to add another clip to fix this problem. This is the postoperative angiography and the patient and the postoperative period. Here it is an interesting case because in this CT preoperative scan we can observe a carotid bifurcation aneurysm, a posterior communicating aneurysm located in the left side, and here we can observe like a circular aneurysm located in the anterior communicating arteries. This patient have a huge AVM located near to the motor cortex in the left side and near to the Broca's areas. And following the phrase of Professor Yoko Kato and Henry March, first, do not harm. And we perform in this patient only the solution of the aneurysms due to this AVM have 3 important drainage veins, and we suspect that the patient will not have a bleeding in the future from this giant AVM. Here we can observe this carotid bifurcation aneurysm, ACOM aneurysm, and this is the PCOM aneurysm. This is the surgery. Well, the carotid bifurcation aneurysm is clipped, the posterior communicating aneurysm is clipped too, and the last step of the surgery was the exposure of the anterior communicating aneurysm. We found this dysmorphic anterior communicating aneurysm with 1 aneurysm, 2 aneurysm, and the shape of these anterior communicating aneurysms, it not seems to be a normal vessel. And at this point, we decided to dissect the anterior communicating artery with these small aneurysms. We found the A1 and A2 bilaterally, and it was a difficult decision because the AVM fills with a lot of blood using this anterior communicating aneurysms from the right carotid artery. And when we were in this operating room, this is one of our preoccupations. And we decided to perform a trapping of the whole anterior communicating aneurysm with this angulated permanent clip, first in the left side of the anterior communicating aneurysms, in the anterior communicating artery, sorry, performing a trapping and leaving between two clips this deadly anterior communicating artery, performing a Doppler control after the trapping in the A1 contralateral and homolateral and A2 contralateral and homolateral. And we decided to exclude the anterior communicating artery in this patient. This is the angio-CT of control, and this is the angiography of control. We can observe that the AVM doesn't feel using the anterior communicating artery anymore because this artery is trapped. And the patient well good with the transient aphasia during 1 week that we suppose that it was related to the AVM that suffered minor flux after the surgery. This is another case we can observe in this CT. This is a regular CT scan. We can observe a giant mass in the paraclinoid region in the right side with certain points of calcified structures surrounding this circumferential lesion. And in this 3D reconstruction of the angiography, we can observe a giant paraclinoid aneurysms. This is the video of the surgery we performed, and first of all, we performed the carotid exposure at the cervical level and identification of the internal carotid artery in order to have it exposed if we need to perform a proximal control. First of all, we need to perform a suction decompression of the giant aneurysm. First of all, we performed the terminal craniotomy, a Transylvian approach, and we decided to, this is the optic nerve. This patient suffered some campimetric disturbances in the visual field exam in the preoperative studies. We performed the drilling of the roof of the optic canal, and we removed intradurally the anterior clinoid process. For patients that we are operating with aneurysms, we try, or we prefer to perform the anterior clinoidectomy intradurally. And for patients with tumors, we perform the anterior clinoidectomy extradurally in order to have more control in this patient. Here we can observe the optic nerve that is compressed in the lateral side with this giant paraclinoid aneurysm. The neck of the aneurysm was dissected and exposed after the anterior clinoidectomy, and we performed the first, we put here the first curved clip in the base of the aneurysm, but when we performed the echo Doppler, the aneurysm was still filling, and we decided to put the second overstack clip in close relation with the first. We put a third clip in this sector, and we decided to perform this in tandem overstack clipping for this aneurysm. This aneurysm was really huge. We punctured the aneurysm, and we resect this deadly sac because in order to diminish the compression effect of this clipped deadly sac. We have here a lot of calcified plaques and cholesterol plaques inside of the wall of these giant aneurysms. It was not necessary to perform a cervical control of the artery because we clipped this aneurysm without cervical clipping. And finally, we put this fenestrated angle clip and this straight clip in order to make more secure the final clipping of this aneurysm. This is the angiography postoperative control and the patient in the postoperative period of control. This is the last case that I want to show. I will try to show you fast in order to accomplish with the minutes that I have. This is a patient who have two aneurysms, a posterior communicating aneurysm and anterior choroidal aneurysm. And the posterior communicating aneurysm was partially coiled 5 years after before our surgery, and the aneurysm was partially coiled. Here we have our surgery. We perform a left pterional approach. We dissected using this transsylvial corridor, using this technique with 2 microforceps in order to opening this easy sylvian fissure to expose the internal carotid artery and the optic nerve in order to clip and to solve the problem for this patient. We can observe here the internal carotid artery, the anterior choroidal aneurysm. It was a small aneurysm located in the anterior choroidal segment. We clipped the posterior communicating aneurysm and we tried to remove some coils inside of the aneurysmal sac because the patient suffered a third cranial nerve palsy. With this curved mini clip, we solved the problem in the anterior choroidal artery. We check the correct pattern of flux in the anterior choroidal artery in the posterior communicating artery, and we use this interesting clip. This clip is an interesting clip that the name is a booster clip, and we use this clip for giving more force to the clipping closure of the first clip. And we avoid with this, with the use of this clip, the use of multiple in tandem clips, because the aneurysm was not totally closed, at least in our Doppler control with the patient. Here is the postoperative angio-CT and the patient in the postoperative period. I am on time.
Thank you, Matthias. A wonderful presentation, nice videos, and a very logic approach. There are a few questions. There are 3 questions on the cases you showed. I start with one I have noticed. The trapping of the anterior communicating artery aneurysm in this multiple aneurysm case, where the anterior communicating was not very clear. I realized that you put the trapping with the permanent clip before you do evaluation of the Doppler. Was a rehearsal happened with the temporary clip before that?
No, we didn't use the temporary clipping before that.
Oh, okay. Now, in retrospect, what's your justification? Well, not available, or you decided to do it one go and finished?
Yes. We decided to trap the anterior communicating aneurysm because in the surgical room we observed that the whole anterior communicating aneurysm have different small sacs in this fenestrated anterior communicating aneurysm. It was difficult for us because the patient have this left ABM, and this ABM feels from the right carotid artery, and the patient suffered during 1 week a transient aphasia, and we thought that it was related with the trapping of the anterior communicating artery. Fortunately, the patient is perfect today, 6 months after surgery.
The other question came from Dr. Mercy from Egypt. He said you were using the blunt ball dissector. Are you using usually blunt dissection around such an aneurysm, the anterior communicating? This is his question.
We try to use blunt dissection, yes.
Okay. Now the third question, endoscopy intraoperatively to evaluate control of the clipping. Do you use how frequent and how often do you use it?
No, we didn't use frequently endoscopy for control. We try to use the microscope, angulating in different angles in order to check. Okay. And we use an interesting tool that is the with the Doppler. We try to use a decibelimeter. Yes, this is a simple machine that the people who work with sound use, and we can control the level of the sound prior and post-operative and post-clipping of our aneurysm. Yes.
Any other questions or comment from the panelist?
I just want to make one comment, Matthew, if that's all right.
Go ahead, Mamish.
It's just about that same case. I think in that case, because the AVM you thought was reasonably very low risk given the excellent venous drainage, you didn't want to touch it. But in general, I think it's a dictum when you have an AVM with feeder aneurysms. I think the dictum is to, if it is treatable and treat the AVM, then eventually the feeder aneurysm probably likely to get better. Is that right?
Yes, it was a difficult decision for us, Ramesh, because the patient actually had 36 years old. He's mother of two children, and we really thought that we really think that if we operate this AVM, the patient for sure will have some motor and difficulty with the pronunciations, because the patient prior to the surgery suffered some transient events of dysphagia. We prefer not touch the AVM.
I think it's okay. It satisfies an answer for you, Ramesh.
Yes. It was not a question, so I just want to make a general rule about AVMs. Thank you.
I just move the moderation to Vladimir to take care of the next presentation introduction. Vladimir.
Hey. Matt, thank you very much. And it's myself whom I should introduce. So I'm extremely happy to see Yoko Kato with us. And Yoko, hello, and thanks for everything. I believe that you are the most dedicated neurosurgeon, and there is no one else like you who is so dedicated to all the education and who is giving so much time and activity to all the courses. And it's really always a pleasure to meet you. And I hope that we shall be soon seeing each other much more frequently than we did in the past 2 years, because we were not traveling at all. Since this seminar is dedicated to Yoko, I have to talk on aneurysms. It's a must. And I have chosen only a very small fraction, unlike Matthias, who has given aneurysms in general. I shall talk only on surgically treated ophthalmic aneurysms. Obviously, I have nothing to declare. Over the past 20 years, we have had 172 ophthalmic aneurysm in a whole series of 2,000 cases. And only 55 of them, let's say 30% of these aneurysms were surgically. What about the proximal control, which is probably the first question always? We have used none in 50 cases. We have used internal carotid dissection in the neck in 1 case, and it ruptured. That was the large aneurysm. And then we have used balloon in 4 cases, and again 1 ruptured. Again, these were large aneurysms. And when the aneurysm ruptured, we have inflated the balloon, and the bleeding only enhanced because the balloon was in the opposite side carotid artery. So it was really rather dramatic even, but ended well. So what we do frontal or perioneal in the fast approach. No clinoid drilling in 22 cases out of these 55 cases treated surgically. Only dura coagulation, and which gives you some 1-2 millimeter of extra space of sufficient in another 6 cases. In 8 cases, we did whole clinoidectomy, as Matthias has shown just a few minutes ago, and those were for large and giant aneurysms. In 1 case, we failed completely and we converted to endo procedure. And in the remaining 18 patients, we did something I call targeted minimal drilling from medial side of the optic nerve to lateral side of the internal carotid artery. And I'm going to show you 4 cases how this is done and how much space it actually gives you. We are doing this tiny region, perfectly depicted in Roton's book, optic nerve and carotid artery in very, very close relation. This is our anatomy specimen. We are looking from below. This is the ophthalmic artery entering the optic canal, and the aneurysms mostly are just in this area, hidden by the optic nerve, just where the dural ring is, and where there either is a little flap of arachnoid or no arachnoid at all, as described by some Almefti, that the beginning of the carotid is without arachnoid. That's why the dangerous is meningioma. So again, very tiny space. To determine prior to surgery whether we shall need drilling or not, the CTA reconstruction is usually sufficient, and you see that in this case, the drilling will be definitely necessary. So where we drill and where we produce the flap, exactly as Matthias has shown, from medial to the optic nerve, because this gives you space to move the optic nerve when necessary, to lateral to the carotid artery, a little flap which we left in place until the drilling is finished, because it protects both optic and carotid during the drilling, and only then we resect it. So this is the first case, 47-year-old female, headache, vomiting, no deficit. The aneurysm was occluded completely without any deficit. Here is the video. So first we start with dissecting the carotid artery and the optic nerve in the optochiasmatic region, opening the chiasmatic and carotid cisterns, dissecting free the carotid artery, no proximal control. I was lucky we didn't have P-rope rupture. I do not know if it's my bravery or stupidity. One of these must be true. Now we see the lateral side of the carotid and medial side of the optic. The dura is coagulated in this angular fashion, stripped down, and then only this tiny part of bone is resected. It means optic canal roof, the optical strut, and the base of the clinoid. Nothing else is needed, because then you get the angle of carotid artery, and you can move the optic nerve as soon as the falciform ligament is cut. So this is the falciform ligament. The optic nerve is released, and it may be elevated a bit because the neck of the aneurysm is just here below the nerve, and this is the clipping, and that's done. Obviously, we now shall see the ICG that the carotid is preserved and the aneurysm clipped completely. I shall go ahead. So this is the optic canal roof, which we resect, and the base of the clinoid plus optical strut. This is what we see after that, the dural ring and the falciform ligament, a little elevation of the optic nerve. Here the aneurysm neck is already well seen and it's clipped, and here is the post-op angio. The clipping is done properly, the patient is doing well. The other case is 62-year female, again visual impairment, again with complete occlusion and no neurological deficit. Surprisingly, the vision improved immediately after surgery. Here's the video. In the same dural cut, you see the aneurysm here, protruding from the canal. This flap is left behind as long as the drilling is done. And again, it's only from the medial side of the optic nerve. It's some 3-4 millimeter in depth and 5 millimeter in line. You see the ring and the falciform ligament are cut. Then the neck, the distal neck is perfectly seen. Note how the optic nerve is split on the aneurysm, that it was impossible to dissect it free prior to clipping. Here is the clip placed on the neck of the aneurysm under direct vision. Then the ICG shows the aneurysm is well clipped. You see that the aneurysm is not filling, that the optic nerve vasculature is preserved, carotid artery is perfectly seen, no blood in the aneurysm. So I punctured the aneurysm, and please note and don't believe the ICG that firmly, because see the nice bleeding from the aneurysm, which was dealt with by the other clip, which did the job. And only then the aneurysm was cut away from the optic nerve and the optic nerve was released. And you will see how the optic nerve will white thrombus immediately after surgery, how the optic nerve will get into its normal shape after surgery over here. And really the vision improved until the next day. So let's see the anatomy. Here is the aneurysm, here is the split optic nerve, the arachnoid layer, which was really impossible to dissect free at the beginning. It's over here. Now the aneurysm is clipped, dealt with by 2 clips, and the optic nerve getting its normal shape after the aneurysm was cut transversally behind the second clip. And here the vision improved. This is the post-op angio. The aneurysm is completely occluded. The third patient is 59-year-old, again female. It's incidental finding of the aneurysm, again complete occlusion with no deficit after that. Here is the aneurysm hidden below the bone, so it needs to be drilled away. Again, the same thing of there was first nerve. Here is the aneurysm released from the base of the brain, the carotid artery distal to the aneurysm, which is here. Again, the same dural flap between the optic and the carotid. The same drilling, cutting the distal ring, cutting the falciform ligament, some extra drilling of the optical strut over here to gain more space. Then the ligament is opened. You see the optic nerve lying directly over the aneurysm, and here we shall cut the distal ring. And in this case, I have left this dural flap attached to the aneurysm since I was afraid to kill the aneurysm, so it was clipped along with the dural part attached to that. This is the first clip just to prepare the aneurysm, the one in front, the next one parallel to the first 2, and then the angled clip for the remaining part of the aneurysm, because parallel clip wouldn't do the job because of the attached dural part. ICG after surgery, and let me show you the final image. The occlusion is really complete and the carotid preserved. And the last case is again the female. This is the youngest one, 43. This is the incidental finding of the small aneurysm, but the patient, after being explained what are the dangers, opted for surgery. This will use a video, only images. You see the aneurysm hidden behind the dura, and in this case, no optic nerve decompression was needed, so only very minimal drilling just above the aneurysm, and 2 clips did the job to occlude the aneurysm. This is the control angiography with perfect occlusion. So, in summary, in all the 18 cases, we did this minimal drilling. In all 18 cases, we didn't see any complications. All the patients returned back to to their previous activities, and we really didn't have any problems with them. To conclude, this is, in my mind, minimal invasivity in relation to the lesion. not to the approach, to the lesion, the minimal invasivity as introduced on the lesion, not as the approach. The access is easy, it's frontolateral approach, which is fast and easy. No retraction is needed because you are really going directly to the optochiasmatic retraction. Proximal control, I have mentioned that I didn't use it. We have adenosine at the hand, but say probably I've been lucky. The drilling is really minimal, only the optic roof, base of the clinoid and optical strut. Just be prepared that even for small aneurysms, sometimes multiple clips are needed. Thank you for your attention. Well, I am to share my discussion, Imad.
I have one question from the podium.
Yes.
Or from the chat. It's one question, the common question. Drilling the anterior clinoid, pre-planned or tailored as needed from extradural, intradural, or 50-50?
In large aneurysms, I drill the clinoid extradurally, but I leave the tip behind because I'm really afraid to harm the aneurysm. So the tip, which is already free, is then resected when I open the dura. But in these cases, this is pre-planned minimal approach and no clinoid is resected. Only really the base of the clinoid, nothing else, optical strut and optic canal roof. So the clinoid remains behind and it's pre-planned, of course.
Yes, Giovanni.
Unmute yourself, Giovanni. Giovanni, unmute yourself.
Okay, wonderful presentation. Thank you. What you are dealing when dealing with the optic nerve, so you have to oblige to separate and to manage mechanically. Do you use any irrigation with nemodipine or papaverine or anything else?
Papaverine always after the clipping. It's always papaverine in all the aneurysms. And when I really need to move, to manipulate with the optic nerve, then we still use steroids, high-dose steroids at the beginning of surgery or at the beginning of dissection. And I think that the steroids are for myself, not for the patients, but we are still using them.
Yes, we all do. I think these are the questions. You can go ahead, Vladimir, with the presentations of the others.
Gladly. Thank you, Imad. It's a pleasure for me to invite Henry Schroeder, who always has excellent lectures. Henry, are you with us?
Yes, sure.
Go ahead, please, Henry.
Yes, thank you. First, thank you for the invitation, and thank you, Imad and Vlad, for the initiative to the foundation of the International Academy of Neurosurgical Anatomy. I think this will be a good organization to promote training and knowledge. And Jarko, it's a great pleasure to be here. And I know you for many years. I have first met you in Sibir with Albert, and then many years later also frequently. And I really admire what you are doing. This is really amazing. So that's why I have to choose aneurysms. I don't talk too much about aneurysms, but I want to present to you some unusual cases, at least for me. I hope it's not too boring for you. So this is the first case. There is a lady with aphasia and apraxia, and the MRI revealed.
Can you go to presentation mode?
It's not working?
No.
Not moving.
It's not presentation mode of your lecture.
Oh. But should be now. It's not moving?
No.
No.
It's the first slide. We are seeing the first title slide.
One moment, I do it again. It's interesting. Now?
Yes.
It seems okay.
I think we are on the second slide now.
Yeah, it's moving, sir?
Yeah.
Yeah. Okay.
That's good. So this was a lady presented with aphasia and apraxia, and you see on the diffusion MRI, she had multiple infarctions. And then you see here, there is an MCA aneurysm. And you see it's partially thrombosed. So this is, I think, not a good indication for endovascular treatment, but for surgery. And you watch here, you see, here's a white clot in the vessel. And while we moved it, you see it escaped into the vessel here now. So what we should do, we have to open the aneurysm. There's no chance to clip it because there is the thrombus inside. So we have to incise the aneurysm. And then the content has to be removed, the clot, and it is similar to a carotid endarterectomy because you will see there are some laceration of the endothel. And we have to remove all this material, especially from the bifurcation where the M2 branches go out and where the M1 came in into the aneurysm. So this is, at some point it was very loose to the wall of the aneurysm sac, but sometimes here it was very sticky, and we have to resect all this material to prevent a new thrombus. And when we pulled it out, then we have some rebleeding. So everything is cleaned. And then here's additionally some arteriosclerosis in the vessel. And then after we removed the clot, we could fold it together. But you see here, there is a hole. I made incidentally a hole close to the M2 branch here. So we had to place a stitch to occlude it again. Irrigation with heparin solution. And then we can dissect the aneurysm and we place a clip. I don't go very close to it. When I was too close, then we have no good perfusion in the M2 branches, and this of course should be avoided. Then the M2 branches are released, and finally the M1. And post-op shows a good clipping of the aneurysm. And she's 3 years after surgery, no recurrence, and she get not any other ischemic events. This was a 47-year-old male, and he had a progressive hemiparesis and balance problems. And you see here a lesion compressing the midbrain, and also go to the basal ganglia. And the CT angio, you see an unusual formation here. So a DSA was made, and it makes clear this is just an aneurysm dilation of the A1 segment on one side. So we were thinking, what should we do? We just thought it might be a good idea to just make a proximal occlusion, because the anterior cerebral artery complex was perfused from the other side. So we made a proximal occlusion and awake craniotomy because I was not sure what's happening when we place a clip. You see the large vessel. We placed the clip, and then we waited some time, and then we reduced the blood pressure, and then he became symptomatic with a hemiparesis. And then I removed the clip again, and we finished the surgery. But our first day after surgery, you see, simply because of this temporary clip, there's obviously a complete occlusion with the thrombus formation. We see in the CTA, the A1 segment is not filling. And then we discussed what to do, and 2 months later, we came in again, and then we exposed the vessel again and placed the clip, because I was afraid when we don't place another clip that this thrombus may go away and there's another perfusion of the aneurysm. So just to make sure it remains occluded. But for me, it was surprising that it thrombosed so rapidly just because of temporary clipping for, let's say, half an hour or so. So we have to be careful when we go down here to the bifurcation of the carotid, because there are a lot of perforators. And then we had our orientation with the Doppler and also with, we place the clip and that's it. It's one day after surgery and you see 4 weeks, you see still the thrombus inside, but the space occupying effect is already reduced. And after 3 months, further shrinking of the aneurysm. Then he was completely neurological intact after 3 months, and 14 months after surgery, you see further shrinking of the aneurysm. So no need to make a resection or so. This lady became symptomatic with seizures, and she had an unusual location of an aneurysm, a distally located MCA aneurysm. And when you see the angiography, you see the delayed filling. There's not much flow on it. 2 branches come off from the aneurysm. You see on the other side, she has also unusual formation of multiple aneurysms. So she has a vascular problem, generalized. So we use navigation to find an ideal approach to it. So we open the Savian fissure and go down to the aneurysm. And then the idea was to make also a proximal occlusion of the aneurysm. And then we made ICG angiography. And one branch had a good filling, and one branch was not filling very well. So we place a proximal clip exactly under the proximal to the large aneurysm. And then because the filling of the one branch was so delayed, of this one here, this one was good and this one was delayed, we thought it might be good to make a bypass to have a good perfusion of this branch. So we open the vessel, irrigation with heparin solution as usual. Paparin we also use, especially if you see there is some spasm, and then we make the bypass. First, we place the stitches at the edge of the arteriotomy on both sides. And then so one side is sutured. Of course, we have to be careful that we don't stitch through the vessel. And I usually do interrupted suture. Some people make running. Sometimes I also make running suture, but most of the time just interrupted sutures. Schmiedek, a famous German vascular surgeon, he also said we should make interrupted sutures, and the anastomosis can grow better instead of running, but I don't know whether this is really true. So then we turn it and stitch the other side. Then the clips are removed. You have a little bit of bleeding usually, but this stops if you put some Surgicel on it. This is a proximal clip on the STA, which is removed as a last thing. This is the post-op angio. Shows that the aneurysm is completely occluded. You see here, the bypass seems to be okay. 6 months after surgery, you see thrombosis of the aneurysm. This is 1 year post-op. Aneurysm is not filling. And you see STA has a good filling of this area. So might be it was good to make this. I was not sure whether it's really necessary, but I think we were on the safe side. This was a 70-year-old male. He came with headache, got an MRI, and came with this small aneurysm. I don't know what you think, but I said, yo, you go home, you are 74, we just watch it. And then he comes 1 year later, and you see there's a tremendous progression of this aneurysm. So what should we do with this aneurysm? Made angiography, you see the configuration of the aneurysm, partially thrombosed. So in this case, I thought we have to do something, although he's 74, if you have this growth, we have to do something. So we expose the aneurysm. You see, this is a big aneurysm sac. This is a branch going in. We dissected the A3 or A4 branches in the interhemispheric fissure to prepare for a bypass. But in this case, you have to do a side-to-side bypass. So we close the vessel, one vessel, it's temporary clips. And the other one small branch we had to sacrifice here because I could not save it. This is in the site of the intended anastomosis. So we open it, and then the opening should not be in the surface, but it should be at around 45 degrees in the one vessel and on the other vessel as well, so that the walls are laying ideally together. So we make a long opening to prevent any occlusion. Irrigation with heparinized saline. It's an opening of the other arterial wall. So I made a very long incision into the artery that we have a large opening. Then we place again the stitches at the end of the arteriotomies. And you can check whether the length of both the incisions, the length of the incision in both arteries is the same. Then we suture the first one. And then we have to bring the needle out, of course, because this is the first wall is down. You have to suture first the lower part. We can suture on the other side. And now the suturing of the downside is not so easy because the wall, the anterior wall, is always falling over this incision, and it's hard to see, and it's difficult that you don't take the stitch and puncture the wrong layer of the wall, the wrong side of the wall. So we make another suture, and then we start to suture the wall down, which is the most difficult. The upper one is easy, but here it's very difficult because you always have the upper side of the artery, which you have to push away. And this, of course, is a running stitch because you cannot make a knot that would be inside the lumen. This is, of course, not good. So the downside is sutured. Irrigation with heparin all the time. I can go a little bit forward. So then the first knot is taken, and that should be outside, of course, of the lumen. And then if this part is done, it becomes more easy, because then we have to to stitch the upper side, which is more easy, of course. I cannot forward it, sorry, but I think almost done. So we open it and there was one hole. And then we close it again. Or we make it, no, we just make a suture on it. We remove the distal clips first, of course. Then you see there is some back bleeding. So you make another stitch to close this hole. And then we remove the proximal clips. And the Doppler showed a good flow. And then we make a proximal clip in front of the aneurysm to occlude the A3 branch. And this is the first day post-op. You see the thrombus in the aneurysm. And this is a good filling of both branches of the anterior cerebral artery. Then this was a very interesting case. This was a 22-year-old male, and he had ear pain. And then he went to the ear doctor, and he had some tinnitus, so they gave some perfusion medication. And then after after 2 weeks, he came to neurology because he had total hearing loss, and he developed a facial palsy. And then when you look at the CT scan, you see there's a dilation of the internal auditory canal. And here is a lesion which looks at the first glimpse like a vestibular schwannoma, but you see the intensity is different. And if you look at the MR angio, it looks very strange for a vestibular schwannoma. So I thought, I don't know, it looks not like a vestibular schwannoma, but he's symptomatic. So we have just to look what it is. And then we made a retrosigmoid approach. And you just see that the ICA goes into the canal, what is frequently the case. So we open the canal, like for vestibular schwannoma. We excise the dura, and then we go in between the vestibular nerves, and we found this bluish, shiny thing. So vestibular nerve is anyhow not working, so we just cut it. And then it turned out to be a thrombosed ICA aneurysm intrameatal. So this is pretty rare. You see the broad-based aneurysm. And we made in fluorescent angiography, and there was a very weak flow in the distal branch of the ICA. So again, the question is, what should we do? We cannot clip it, of course. So we open first the aneurysm. And again, we make like an enterectomy to remove the clot from the lumen. And we have good bleeding from the proximal branch, it's okay. And then we went to the distal branch. There was also thrombus inside. So we bring it out, and you see there is also some back bleeding. So in the end, I'm not sure whether it's really necessary to make a reconstruction of this vessel or not. But we make an excision of the aneurysm. And then we make an end-to-end reconstruction of the ICA. I thought we are on the safe side when we make a reconstruction. Again, the first 2 stitches, 180 degrees apart, and then suturing of the anterior wall of the vessel. Then we turn the clips to come to the posterior wall, and we make another few stitches, interrupted. Distal clip is removed, some back bleeding. Then the proximal clip is removed. Doppler shows a good flow, and then ICG angiography confirms that we have a patent anastomosis. So post-op, facial palsy improved, but the hearing loss remained. And you see here is our anastomosis. So it's not the big vessel, so I don't know whether it's really necessary or not. So these were my cases, which I wanted to present to you, and I'm happy to get your questions. Thank you for attention.
Hey, thank you. Those were excellent cases. And what I would like to say is that you clearly demonstrated what I was talking a little earlier about, that you need to know your trade, your craft, and then you can use your imagination and your creativity. Unique cases with unique solutions. Excellent. Thank you. Francesco.
Oh, well, Vladimir, thank you. I appreciate very much your presentation. I have only a comment about end-to-side anastomosis, but also about the last end-to-end anastomosis, because I had some discussions with Schmidek in the past about running sutures. I can assure, in my experience, there is no narrowing of the anastomotic site, and you have a reduced occlusion time for the vessel. So I don't understand why use interrupt stitches instead of continuous suturing.
But he said it can grow, you know, when you have continuous suture, then it's a limitation because the suture has an end. When you have interrupted, he said, this may grow. And you know, sometimes you make STA bypasses. It's very small vessel, and then you make it after 1 year when there is demand. It's tremendous enlargement of the vessel. It's sometimes I'm really astonished how much the brain demands the blood to come in, and the anastomosis is growing. That was his, not that you have a narrowing later on, but you have not the potential of the same growth, he said.
Believe me, I have many cases in which we can demonstrate that the enlargement of the STA and of the anastomotic site is happening also after a continuous suturing of the anastomotic site. So I think that this is not only a technical detail, because you know exactly, because you use also running sutures, that you have a shorter time, and this is very important, I think, when you have a resilient vessel which is occluded for more time. So this is my experience.
Okay.
Okay. Imad?
No, I just want to draw attention. There are 2 questions from the podium, from the chat. One of them is neuroprotective agent used in these anastomosis, Henry?
Yes, of course. We make a very deep anesthesia, some kind like burst suppression. That is what we use. And then, yeah, basically that's it. We make a very deep anastomosis, very deep anesthesia to have a burst. And then we, of course, give 100% oxygen during the time of occlusion. Yeah, that is basically what.
The next question, how long does it take, the suture, for you?
It depends which vessel. So the side to side took, I think, 45 or 50 minutes. When I visited Schmidek, he clipped an ACOM aneurysm, and he put 2 clips on the A1s. And then he dissected, and after 20 minutes, I said, I said, Professor Schmiedek, the clips are 20 minutes. And he said, young man, stay calm. And then it continues to 30 minutes and he did not remove it. And after 40 minutes, he took it off. And I said, okay, next morning she will have bilateral anterior cerebral artery infarction for sure. But nothing happens. Yeah. So I think when you have the anterior cerebral artery, this is more tolerant. With the MCA, you cannot do that. But obviously, there are more anastomosis from this side.
All right, so we have a speed competition, and I'd like to hear from Francisco how long it take you for a running suture.
You can have half time when you compare with interrupted stitches. About half time, very quickly you can, because you have two stitches on the different sides, and then you have a running session. Imad, think about the time you need to have a knot and to cut and so on. Okay, this is.
Yeah, but I'm surprised that Henry is known to have a Harley Davidson motorcycle, and I'm just wondering how he chose that one. Okay.
There is a solution to running and interrupted. You can do one side running and the other interrupted. Then you can believe in Schmiedek's dogma that the anastomosis grows and overcome it. Okay, let's go ahead. Henry, there's one more question for you. It's not a question. Professor Henry, kindly share your email address, please. Deal with it yourself. It may be a beautiful lady, so I will leave it up to you.
Yes,
and he should go to the next lecture, which is again about the bypass surgery. Francesco Tomasello, please, Francesco.
Once Henry decided, we can pass it through the society. But Henry has to make a decision because perhaps he doesn't want to announce a team on the podium. Now, there was a question here from the suture material, and are you taking which layer of the vessel? That's one of the questions, Henry.
All layers? You have to make sure that the...
And what suture, the 8-0, 10-0, or?
10.
10, okay. Sorry, Francisco.
I thank you, Vladimir, and Imad for the great privilege to be involved in this new adventure, the International Academy of Neurosurgical Anatomy, and I thank you so much for this. I am very delighted that this first webinar is dedicated to a great neurosurgeon who is Professor Yoko Kato. I know her since several years, and I can tell you, we met probably the first time in 2007 in Verona, and I am here close to Ghazi Azri and Yoko Kato with the my great friend Albino Bricolo, who passed away. But we met probably every year, Yoko, just going around the world for several meetings, and of course, all recognize the contributions of Yoko to neurosurgery and to education. My topic is history. All we know that the first bypass procedure was performed by Yazergil and Donaghy in Burlington, Vermont in 1967, and then the first bypass was performed by Yazergil in Switzerland in 1972, and there was a case of Moyamoya disease. This is very interesting for what is happening now in recent time. I think, and everybody recognizes that the bypass procedures opened the era of microvascular neurosurgery and probably contributed so much to our knowledge or better knowledge of cerebral circulation, not only, of course, the donor vessels, which are, as we know, the superficial temporal artery mostly, but also occipital artery, and the knowledge of cortical arteries and all branches of main arteries of anterior and posterior circulation. It was a extraordinary contribution to our knowledge, involving not only bypass procedures, but also other vascular neurosurgical procedures. I had the privilege to host Professor Yazergil in Messina, and he was awarded in the birthplace of Francesco Durante with the award Francesco Durante in 2002, and I hosted him for 10 days with the memorable lessons at the University of Messina. At the beginning of the 70s, of course, besides the contribution, the formidable contribution of Yazergil in Switzerland, in many other countries, centers, of course, started with this surgery. I would like to mention only Germany. You see Gratzel and Schmidek, France, Austria, Hungary, and Italy, including my institutions. In 1977, Yazergil published a series of 86 patients and evaluated the follow-up of these patients for stroke and for morbidity and mortality. It was a very, very interesting series. But there were, of course, there were some international symposia on this subject. But in 1977, almost 2,500 procedures were performed around the world. This is the history of the 70s with this surgery. And in Italy, my mentor was the first in Italy performing STA-MCA bypass in 1970. And in 1984, we published our experience on cerebral revascularization, just to have a survey of what we performed in those years. So we went, as I told before, from T-shaped to oblique-shaped anastomosis. And you see that there are almost running tissue, and I can show the growing and the enlargement of the anastomotic site and also of the superficial temporal artery. We evaluated by scanning electron microscope we evaluated and studied what happens inside the anastomotic site. So 45 minutes after the end-side anastomosis, we see a presence of platelets around the stitch, but already 7 days later, we have an initial reendothelialization of the site. At 14 days later, we have a complete healing of the anastomotic site with the complete reendothelialization. Other techniques were also illustrated in that time until the beginning of this century. One of these is the excimer laser assisted non-occlusive anastomosis of Thalligen, which has the advantage to guarantee a high flow and especially a very short time for occlusion of the recipient vessel. And you see here a typical case of our series. You see this is the superficial temporal artery, absolutely enlarged a few weeks later with the anastomotic site and the middle cerebral artery branches filled by this new flow coming from the STA. There was a discussion about the amount of flow coming from the STA, but at this time, with the enlargement of STA, we can have a a flow up to 50 milliliters per minute, as this is very, very important for revascularization of a large cerebral area. At the beginning, of course, there was a large skin flap and isolation of a superficial temporal artery. Then we, of course, changed completely, and it was also shown in this webinar that we have a linear skin incision and a very small craniotomy with prepared for the anastomosis. Unfortunately, in 1985, this is the science. It was the conclusion of ECIC cooperative study published on New England Journal of Medicine. And the conclusion was that bypass surgery is no more effective than aspirin in reducing stroke and of no value in any of the subgroups entered into the study. The conclusion was terrible because it would be malpractice to perform the operation. This is 1985. But there was a great criticism to this study because there were some important biases. And a few years later, not only this is in my case in 1992, but also in other centers, sporadic procedures were performed in spite of the conclusion of the study. And you see here, of course, the superficial temporal artery with the middle cerebral artery branches. One important criticism was that there were no proven methods for selecting patients at high risk for hemodynamic stress. Of course, a few years later, we had other ancillary tests available to assess CBF, and from the diagnostic point of view, MRI, PET, and the simultaneous CO2 challenge and acetazolamide administration are used to test cerebrovascular reserve. So with the PET studies in 1994, Schmidek and Pipigras demonstrated improvement of cerebrovascular reserve capacity by ECIC bypass in patients with vessel occlusion and hemodynamic cerebral ischemia. In 2000, Nussbaum and Rickson attempted to illustrate the indication, the new indication probably for the beginning of this century. Failed maximal medical therapy, poor cerebrovascular reserve as demonstrated by pre-op hemodynamic assessment, symptoms correlate with radiographic findings, and the lesion cannot be managed with endovascular or direct surgical means. These were the hypothetical indications for that time. But there was an evolution on cerebral bypass surgery along 50 years. Of course, the most common bypass is that of first generation, STA, MCA, and side anastomosis, but there was also a second generation of the extracranial and intracranial interpositional bypass with the donor vessel, usually the saphenous vein, but we saw also radial artery and tunnel and this involves a double proximal and distal anastomosis, one in the neck and another intracranially. The third generation, we saw also a case of Henri Schroeder, intracranial reconstruction, reimplantation, and reanastomosis of parent arteries. This is the development, the evolution of the bypass surgery. But there is also, as Lawton and Lang stressed very recently, a fourth generation with some cases, for example, with aneurysm, double reimplantation bypass which is interpositional because two branches are reimplanted and connected to proximal, reimplanted to a graft connected to proximal carotid artery, and three end-to-side anastomosis, rebuilding a new bifurcation and trapping an aneurysm. So there are many variations of this surgery which were performed in recent years. The second generation, the long vein grafts, which were used for planned ICA sacrifice for an aneurysm or neoplasm with insufficient collateral circulation. And in 2000, Spetzler, that while Spetzler illustrated the pros and cons of bypass procedures with the saphenous vein, STA, MSCA. Of course, you see that the augmentation of flow with the saphenous vein is much higher, but the patency rate is almost the same. Of course, the cons of saphenous vein is that the ICA occlusion time is 1 hour and a half. So also in my experience, we used the saphenous vein bypass graft, as you see here, for carotid cavernous aneurysm, and of course the augmentation of flow is of course much higher in this type of bypass. There was a very important hope for the role of STA-MCA bypass surgery with the COS study, carotid occlusion study, with the aim to demonstrate that the bypass can reduce by 40% subsequent or ipsilateral ischemic strokes at 2 years in patients with ICA occlusion and ipsilateral increased oxygen extraction fraction measured by PET. But the causal results indicated revascularization in this study can be beneficial only if perioperative complication could be lowered. This was to some extent a disappointment about the conclusion of the study. I know that there is, we will hear from my friend Jacques Morcos, there is a prospective registry evaluating always the efficacy of bypassing carotid occlusion symptoms refractory to medical therapy and evidence for poor cerebrovascular reserve. There are some friends and outstanding neurosurgeons involved in this study, Jacques Morcos, Fadi Charbel, and Carlos David, principal investigator. The study will expire on December 2022, but I don't know exactly if is going on. Recently, there was the attempt to define what is the state of the art with the bypass procedure around the world. So if you see in Japan, there is the most important indication for bypass is moya moya, and a little bit lower for aneurysm. In China, moya moya, always more for aneurysms. In the United States, you have fewer cases of moya moya and aneurysm, mostly in the series of the United States, and in Europe, moya moya, few cases, steno-occlusive disease, more cases, and this is the situation as was evaluated last year by my friend Luca Regli and his group Esposito and so on. But there is also an important aspect to mention: the number of publications according to continents and according to countries. As you see, Asia has until 2020 the measure the greater number of publication. This is North America, and Europe is a little bit less, because Europe was the biggest contributor, as we saw in the 70s and 80s, but now Japan was found to be the country with the most active bypass research study community. Japanese institutions have published 933 articles, followed by United States with 630 articles, and China with 232 articles. So this is the situation around the world. And you see that the indications, if you see the indication, Moya Moya is really the most important indication for bypass procedures, less with the chronic stent-occlusive disease. And this is the important indication for flow augmentation bypass. But if we see the flow preservation bypass, the measure number is for aneurysm surgery. Is really less for tumors, as was probably at the beginning. And if we see at the cases, you see that there was an increase of cases in this first 15 years of the century, with an important increase for Moya Moya disease, a decrease for occlusive, and a stable situation for aneurysms. If we always, with this survey of the United States published on Neurosurgical Focus 2 years ago, if we look at mortality, the mortality for Moya Moya is decreasing, is vice versa increasing for occlusive disease, and is absolutely stable for aneurysm. So the same for total complications in this kind of surgery. So if we look at the indications now, we know that flow preservation is only for complex aneurysms, not amenable for clipping, coiling, rarely for tumors. Flow augmentation for Moya Moya, either ischemic or either hemorrhagic, and less for stent-occlusive disease, only in selected cases. And there is a recommendation, very important, efforts dedicated to refining surgical technique is required for practicing cerebrovascular neurosurgeon, and adequate training must be provided to neurosurgical trainees to perfect microsurgical anastomosis. This is very important. Otherwise, we risk to lose this skill in this surgery. And I would like to conclude with the words of Michael Lawton and Lang on future of bypass surgery. Complex aneurysms still require open microsurgery, often with bypass techniques. Bypass surgery in there is series more than 600 cases demonstrates that open microsurgery will continue to evolve. The best neurosurgeon will be needed to tackle the complex lesions that cannot be managed with other modalities. And this is a message for young generation. Bypass surgery is a growth area. inspiring innovation and creativity and expressivity. So I think this is important to stress, emphasize the role of this surgery that we have since 50 years, but we need to train other young neurosurgeons for this kind of surgery. I thank you so much.
Francesco, thank you very much. That was great. We have time for a question or remark. This is definitely an important and interesting part of neurosurgery, and the history is really great. With Barnett study killing the procedure effectively, destroying few careers of those dedicated to bypasses only, and then some growth again, which I believe Jack will talk about. If there is nobody to say anything, Victor, are you with us? You are. Victor, please take over the chairing of the session.
Thank you, Dr. Vlad. First of all, I want to thank to you and Dr. Ahmad for this great initiative to create the International Academy of Neurosurgical Anatomy. Now is a successful organization. I feel very proud to be involved in this, whose first session is dedicated to Professor Yoko Kato. Yoko Kato, you are one of the best unknown brain surgeon around the world. Thank you so much. Now I have the honor to introduce Dr. Jake Morcos from United States, who is going to give us the lecture, Bypass Surgery in Moya Moya and Ischemia, Understanding the Physics. Thanks, Dr. Jake Morcos.
Hi, good day, everybody. Wonderful to be with good friends and hungry students, and particularly to honor really one of my favorite people, Yoko Kato, who unfortunately I have not seen you, Yoko, since pre-COVID. Yoko, we can do a whole lecture about what she has done for neurosurgery, but of course we know her as a fantastic person, as a human being. We know her as a fantastic educator. What she has done and continues to do, WFNS and other settings is unequaled, the personal dedication. And last but not least, a spectacular technical cerebrovascular surgeon. So it's very fitting that Imad and Vlad started this fantastic academy, and as an inaugural person to honor would be Yoko Kato. So I'm pleased to be with you all. To continue at this superb theme of bypasses and excellent review that Francesco did, I thought I'll share with you my recent review of bypass for Moya Moya and steno-occlusive disease. I am not including tumors, I'm not including aneurysms. I looked at 162 cases, and these are the fellows and residents and stroke neurologists that work with me. Nick Khan, particularly my last year's fellow, is to be thanked for looking at the data. What is the background and purpose of my study? Well, here is what we know. Adult Moya Moya disease, excuse me, natural history, if untreated, up to 50% progress over 6 years. The annual risk of ischemic stroke is about 13%, annual hemorrhage risk 1.7%, and it's worse if bilateral. The annual risk, if asymptomatic, of ischemic stroke is 3.2%. I mean, these are well done natural history studies. Adult Moya Moya disease, when you talk about direct versus indirect bypass, there was a meta-analysis, there is clearly a higher degree of revascularization with direct versus indirect. It is more effective in reducing recurrent ischemic strokes. Steno-occlusive disease, I don't have the time to go over the cost study. That in itself will take an hour to talk about the intricacies. You can read, if you'd like, our rebuttal of part of the results of the cost study many years ago now, almost 10 years ago. I'm a co-author of a paper with the CV section. But anyway, there are limitations, and there is absolutely, in our belief, a role for bypass for select atherosclerotic cases. But anyway, the role of bypass, this is 2019 paper, shows a lowered incidence of ischemic stroke and cerebrovascular death. And if you use direct is 7% and indirect is 19%. So I use direct bypass exclusively unless I cannot find a recipient artery, and it does, and that happens extremely rarely. I'll show you the numbers. Similar to what Francesco was saying, I really keep it simple. I don't do the combined bypass that our colleagues, some colleagues in China and in Japan do. I'll show you again the technique. So I thought it's worthwhile looking at my results and see if I was doing the right thing for the last several years. So it's a retrospective study. I'm not going to bore you with some of the statistics and so forth. I looked at the obvious outcomes, long-term outcomes, bypass patency, surgical complications, and following the wonderful pioneering work of my good friend Fadi Sherbel at UIC, I too have been using intra-op flow, blood flow measurements. I use the Sherbel transonic flow probe. I have no financial interest in that company. It is so useful in so many ways that in itself takes maybe a 2-hour lecture to show you how you benefit from measuring flow in general in cerebrovascular surgery. Then I compared 3 techniques. I've defined them as follows. 1D, 1R, meaning 1 donor, 1 recipient. 2 donor, 2 recipient, you call that also double barrel. And 1D, 2R, 1 donor, 2 recipient. And that last one has been published a few months ago, and I'll go over some of it too. Of course, I've not operated on asymptomatic patients. I've chosen symptomatic patients. I've always done at least 2 criteria of objective findings, a physiologic finding, physiologic test like a CT perfusion or SPECT with Diamox, and transcranial Doppler vasomotor reactivity study. Our stroke neurologists have a nice technician here who is an expert at this. You do TCD, you make the patient breathe higher CO2, lower CO2, and there's a very simple formula of velocity to imply what the vascular reserve is. I've looked at everything you can think of. Suzuki grade, I've looked at Matsushima grade after the bypass. So this is a typical mature bypass 11 years after surgery. Indeed, these STA calibers enlarge over time. You can see how it started at the top 3 months after bypass, and at the bottom, patient doing perfectly fine 11 years later with a nice big STA. These physiologic studies, they show, by the way, in case you're not familiar with it, a normal TCD VMR should be above 70%. A normal breath holding index should be above 0.69 or 0.7. We've done statistics. So interestingly, you would think that the cost study would have decreased my referral base. On the contrary, because I work with very smart stroke neurologists and a good referral base of neurosurgeons who know that there is still a role for bypass. Look at my numbers. The first 7, well, not the first, I started in 95, but from first 7 years, 99 to 06, the number of 14 cases, the next 7 years, 41, and the third 7 years, 107. So referral is increasing in spite of the criticism of bypass. What are the results? Post-op morbidity at 30-day stroke and or ICH, 3.7%. There is 1 death, and then that death is not an STA-MCA, is a bonnet saphenous vein bypass I don't have time to go into it. I won't have time to give you the rest of the study, but one death, which was unfortunately a significant anesthetic complication of severe uncontrolled hypertension that resulted in hemorrhage remote from the bypass in the posterior fossa. Long term, what happens long term? I followed the patients almost 3 years on average, 2.5% stroke or ICH, much, much better than the natural history. Bypass patency immediately 100%, long term 90%. A TCD VMR, be very careful. You can do the most beautiful bypass, you can have the most happy patient with no symptoms. TCD VMR rarely becomes normal. Don't expect the physiology of the brain of that patient to become normal range. It gets better, but it doesn't get normal. So 29% became 39% post-op. When you measure flow, cc per minute, here are my average ranges. The STA had an average cut flow of 52 cc per minute. When I finished the bypass, on average, I gave the patient 44 cc per minute. That when you divide those two numbers a la Charbel definition, you get cut flow index of 0.86, which is quite good, quite high. Patients got better, and modified Rankin score improved from 1.8 to 1.2 post-op. You won't have time to see those details, but just to show you, I categorize the patient Moya-Moya disease, Moya-Moya syndrome, and steno-occlusive disease, SOD. I've looked at every factor possible, comorbidities, their MRS, and did a univariate and multivariate regression analysis to see what correlates with long-term bypass occlusion. And you will see in a second, it's really not a big deal when the bypass occludes long-term. Interestingly, only 2 factors. Hispanic race, I don't know why, makes no sense to me. Most of my patients here in Miami are Hispanic. I think it could be one of these chance occurrences. But the second very powerful predictor is whether they had complete or incomplete collateralization before surgery on their angiogram. I have not shown you with images what I mean, but when you overlap all the injections of an angiogram, you're looking for an area of poor perfusion. If they had it, then their chances of occluding their bypass in the long term is extremely low. It's only 4%. So here it is, when I categorize complete pre-op collateralization, the chance of the bypass closing off mostly asymptomatically and in a delayed manner is 36% versus 4% if they had incomplete collateralization. Patients got better in general, improved MRS, pre-op, post-op. You can see it graphically, the shift to the closer to the 0 and the 1. And here is comparing 1 donor, 1 recipient, 1 donor, 2 recipient, and 2D2R. You will see, if you look at the numbers carefully, that there is no statistical difference, but you will clearly see a trend of increased patency and increased flow the more anastomosis you do. Now, I was very puzzled because, again, my friend Fadi Charbel had reported on several papers that the cut flow index obtained at surgery, the ratio of bypass flow to STA flow, is an excellent correlate of long-term bypass patency. You can see it in their series of 146 cases 2 years ago. Yet in my series, it did not correlate at all. I was so puzzled. You know, I'm sure there isn't much difference in technique. So I'm showing you a comparison of both series in my attempt to understand why that is the case. Maybe I did a little more 1D2R and 2D2R than they did. But I noticed one thing, Fadi and Sepi Amin Hanjani use concomitant EDAS with their direct bypass 35% of the time. I don't. I keep it simple. I don't put the muscle, I don't put the dura. So if you look here now, their patency rate long-term is 76%. My patency long-term is 91%. When you break down the cut flow index in Fadi's series, you can see exactly of the cut flow index less than 0.5, only 54% of the patient, I'm sorry, 54% of the patients, of his patients occluded long-term. If you look at my numbers, it didn't matter what the CFI was, about 10 or 11% occluded. So it's it gives you a fantastic understanding of the subtleties of the physiology. If you want to know more details, we have 2 publications recently. One is a video and the 1D2R. Very quickly, what is 1D2R? I think I have the largest series now. I published 21 cases, and that's my preferred method nowadays. I only do one branch of the STA. I do the side-to-side anastomosis to the temporal M4 first. Then I do end-to-side to the frontal M4. You can see that in the second panel. I, of course, measure flow numbers at every step of the surgery. And again, I don't have time to go into the physics and physiology of it, but I will show you a little video, and if I go to it too quickly, it is published. I'm gonna go here, you can look it up in detail, but this is a typical 34-year-old with moya moya. Look at how bad his mean transit time is in the left hemisphere. Look at the watershed infarction. This is how we look for area of uncompensated hypoperfusion. We overlap the angiograms on top of each other. Here is the STA. Craniotomy is very simple, 6 centimeters above the external ear canal. Old-fashioned landmarks works very well to get you to the distal Sylvian fissure. We do this. I cut under the microscope. I love to use the Colorado needle. It's quicker to dissect the STA. We saw beautiful videos earlier by Henry. You do a small craniotomy. I do everything under the microscope. It's cleaner and it teaches the residents how to be, precise and so forth. I isolate 2 recipients, one on the temporal side, one on the frontal side. This case that I'm showing you, by the way, here is, I always measure recipient flow. This is 10 cc per minute in the recipient. Clean the STA very well. Now, this case I'm showing you, I did the end-to-side first. This is one of my earlier cases where I was not sure I was going to need a double anastomosis. So I did this case end-to-side, but now I do them side-to-side first because it makes more sense. You don't close the bypass while you are doing the next anastomosis. Yes, I do usually running technique unless I'm teaching a fellow or a resident, then I have them do interrupted technique. And I agree with my good friend, Professor Tomasello. It is quicker. Now, notice I'm measuring the flow after the first anastomosis, and it is 58 cc flow in this per minute. Is now 58 cc per. So now I do a side cut in the STA, and I will do side to side. I don't anchor the 6 o'clock and 12 o'clock. I only anchor the 12 o'clock, and I think I run it on this one. Yes, you see I'm running the back wall, and when I finish, I don't remember if I did interrupted or running on the front wall, but sometimes I mix and match, as Vlad said. Now, notice the flow. the flow now is going to go up.
Technique as well, and that's omitted.
Jack, you should mute your video.
I'm sorry?
Because there is double commentary, your commentary and the video commentary going on.
You're right. I'm sorry. I'm almost finished. I'll shut down the video. Here is ICG, and this is a comparison of the three types: 1D, 1R, 1D, 2R, 2D, 2R. The advantage of 1D, 2R, you don't do an extra dissection for another branch. It's quicker. Now, of course, you need to have some experience, because to do the side to side, if you screw it up, then you screwed up the entire bypass. And some other, I'm going to skip that. This is what it looks like at the end. Two anastomoses, you can see them right here, side to side on your left, end to side on your right. So this is the going back to the final numbers. You get a cut flow of 57, an interim flow of 36. You do the second anastomosis, the cut flow becomes 51. If you read the paper, you will see that we've introduced two new concepts, SARA and SASI. SARA is when you divide the cut flow index final by cut flow index initial, and SASI is when you divide the final flow by of the second anastomosis by the total flow. On your left is to show you how all of this is exactly like your high school physics of electricity, Ohm's law. Again, if you read the paper, you'll know the details of what I mean. This is very simple to concept, and it applies so well to the 1D, 2R. And if you understand that, you understand how the flow navigates. In conclusion, I've shown, I think, in my series, like many other excellent centers, that bypass is here to stay. Direct bypass was feasible in 161 cases out of 162. Only one case I had to do indirect. Long-term patency is excellent. If you measure flow in cc per minute, you will understand a lot more the physiology of the brain. Morbidity, mortality, I think, is very good, 3.7% compared to 15% with costs. Long-term event rate is low. We are helping those properly selected patients. MRS gets better. When bypasses occlude in a delayed manner, it's because they get indirect flow going in. I have not shown you some examples of that. 1D, 2R, I like it. It's quick. It makes sense. It saves the other STA branch in case you need to do something with it in the future. And my regards to Yoko, Kato, and thank you for the invitation.
Thank you, Professor Dr. Jakes Morkos, for your wonderful lecture. We do not have any question in the chat, so anybody in the panel wants to make a question?
I would like to have a comment. If you agree.
Francesco, yes.
Yeah. I congratulate you, Jacques, for this very, very nice presentation. This is a single institution, a single surgeon experience, and you show that was a very rigorous study with the correct methodology and multiple tools. I saw new concepts. I already knew these concepts really from you, but I would like to have your comment on this. You know that the COS study could demonstrate a benefit from bypass if the morbidity and mortality was lower. And if I show the survey of the procedures in the United States, and there is for steno-occlusive disease an increase of complications and mortality. You showed us very, very nice results, morbidity and mortality, and also for the follow-up results. How can you comment about this problem of an increase of morbidity and mortality in steno-occlusive disease is a problem of an incorrect indication, or we need to have more skill in performing these procedures? This is my question.
Thank Francesco. You know, when, I don't know if you remember, when Bob Grubb, the co-PI of the cost study with Dr. Power, presented the surgical paper that's less quoted than the initial cost, he had a very interesting number. He said, if the morbidity and mortality during the cost trial of the surgeons, you know, there are many, mostly very experienced surgeons, but if you look at the list of surgeons, and of course, I'm not going to say who they are, there are some that are not very experienced at bypass. There were the Spätzlers, and there were the non-Spätzlers. You know, we're not going to say anymore.
I agree with you.
The average occlusion time was 45 minutes for the group that did not have a stroke, and 55 minutes for the group that did have a stroke. My fellow, talking about speed, my fellow does an anastomosis in 30 minutes, my fellow. So again, I am not saying that the length of temporary occlusion is the cause. I think selection is, I am extremely meticulous because everybody's looking at, you know, any bypass we do, insurance companies look at them. I am so meticulous about choosing the right patient. And in retrospect, I think I was good at choosing the patients. It's really only people who need it. If you start doing it on people who don't need it, you're going to have hemorrhage. I'm sorry, I forgot to finish my point. Bob Grubb said, if the morbidity was 8% instead of 15% in the cost, surgery would have been superior. So 8% is not that low. I mean, mine is, you know, now you might say mine is retrospective. Maybe I missed a few. It's not as good as a prospective randomized study, but still 8% is completely tenable in most hands. And that's why it is here to say, again, two more things. In the costs, the average time to randomization was 72 days. It means the so-called hot patient was excluded. I have patients all the time, they cannot sit up. The neurologists call me every time they sit up, their blood pressure falls, they have a TIA. Those patients never made it into costs. And these are the patients you can help. And I was going to make one other point, but I forgot now, but that's okay. Thanks.
We will speak about this next time, Jack.
We will, in Bogota.
In Bogota, yes.
Thank you, Professor Jakes Morcos. Now, we are going to present the next speaker, our friend Mahmoud Qureshi. He's going to speak about the essence of neurovascular development. Thank you, Dr. Mahmoud.
A small comment, Victor, sorry to interrupt. Dr. Mahmoud, he will be shared a presentation with Dr. Amir, who is an interventional radiologist. I'm pleased that he could make it, and they will give this presentation from the two aspects.
Okay, sir.
Thank you very much. Just a correction, Dr. Amir Qureshi is actually a hybrid neurosurgeon. It's his younger brother who's the neurointerventional radiologist.
Oh, okay.
Thank you very much, Imad and Vlad. It's an absolute honor to join this webinar in tribute to my friend and colleague, Dr. Yoko Kato. It is equally an honor, if I may say so, to follow Jack Marcos, because at some point in our history, we both met in Southampton during our training. I came south, he went west, and I practice in Africa, he practiced in the USA, and I'm sure the presentations will show the stark differences on our two continents. But it is for that reason that I chose what I think is essence of neurovascular development with regard to what Yoko does. I will deal with the global perspective of this in regards to Yoko's long-standing passion for LMIC countries, and Amir will then go to the more anatomical side of development. So if I may, Yoko is actually a legend in my eyes and in the eyes of many people. I first met Yoko while queuing alongside her. And if people remember the Marrakesh Congress, it gave us a lot of time queuing there and become and know each other. And she has been a passionate and sincere supporter ever since. She came to Africa, Nairobi, during a World Federation Foundation course in 2011, and this cemented our friendship. She developed a deep passion after that for conducting teaching courses in sub-Saharan Africa, ensuring that her own foundation and her contacts brought cutting-edge technology to our continent. She has been instrumental in developing the many courses in sub-Saharan Africa, starting with 2011, then in Dar es Salaam in 2013, Mombasa 2017, in Nyeri near the foothills of Mount Kenya in 2019. I'm bringing this to attention because of the involvement of these courses that led to what I refer to as the essence of neurovascular development in our continent. Neurovascular development in sub-Saharan Africa has been going on for some time, but really took an impetus and got a boost when Yoko would come and teach firsthand using technology that she would ship or use her influence to ship using Pontero microscopes to show and teach clipping of aneurysms. This is one going on in 2013, the first aneurysm to be clipped in Tanzania in 2013. And then inviting and exciting young neurosurgeons. This is a lady who became the first Africa 100 neurosurgeon trained in Algeria following that enthusiasm she got as a young doctor in training. And the young man next is a man who will speak after me, getting excited about my microvascular training. And then these resulted in vascular surgery to be developed in outreach hospitals. Every time I met Yoko in any of these conferences, she'd hand me many clips or several clips that she would bring only for sub-Saharan Africa. And these clips were used to clip an aneurysm for the first time in a city outside of the main city in Uganda by the first trainee, amongst the first trainees of the WFNS reference site program, Dr. Kitia, now Professor Kitia at the Mbarara Teaching Hospital with the Pico microscope, which through her donations to the WFNS has been a key microscope used for aneurysm clipping in Mbarara, Uganda, in Nyeri by Dr. Andrew Nyaoncha in the town that we held a course together, if you all remember, and by Dr. Ben Okanga, who then used this microscope to clip his first aneurysm in the coast city of Mombasa. So the essence of neurovascular development is very closely tied to the passion that Yoko has. And having inspired residents in training to take up neurovascular specialization, these young neurosurgeons from this part of the world then went off to then receive unrivaled teaching by another continental icon of hybrid neurovascular surgery, Professor Alan Taylor in South Africa. And as a result of that impetus and that training, we now have two very well-trained hybrid neurovascular specialists in Africa. One of them was a trainee in Dar es Salaam, but came back as faculty to teach. So we shall be hearing from them. And so the journey began for microvascular neurosurgery in this part of the globe, in the continent of Africa, in sub-Saharan Africa, in Kenya, with the first microsurgical clipping in Kenya, following training by, I might say, our mentor, Jack Marcus, Sir John Garfield in Southampton, who clipped the first aneurysm using a Scoville clip and a mosquito forceps as an applicator. Now, as a result of the inspiration received by these young neurosurgeons, we are now able to use current techniques to clip aneurysms in our region. So neurovascular intervention is now available in its microsurgical form and the endovascular form. And we have, as I said, in Kenya, 2 international interventional neurosurgeons, hybrid neurosurgeons trained by Professor Alan Taylor. That's Dr. Edwin Mogere, who works with me at the Aga Khan University, and Dr. Amir Qureshi, who will be talking to us a little later. Enthusiasm for Yoko's passion for teaching is world-renowned. We are privileged to be in this webinar, the first one of IANA, to pay tribute to her. Here she is, where I've visited during a meeting in Karachi, and she's been all over the globe doing what she loves best, that is teaching young neurosurgeons. So Yoko's activities, instead of slowing down during the pandemic, have actually accelerated, and she has been having a huge number of webinars through the ACNS to inspire young neurosurgeons globally through her lectures on cerebrovascular surgery. So she's been in the forefront of encouraging global collaboration. Here she is again in a lecture where Jack was speaking about current and future directions in neurosurgery. There was Yoko helping us develop our scene in our continent. So the world of neurosurgery is immensely grateful for your selfless efforts, Yoko, and we thank you and applaud you and all the people who joined her in helping us all in this part of sub-Saharan Africa. We see very familiar faces, but they're all in the forefront, and it is no surprise that we are having this immensely valuable platform of IANA developed by the very people who came and helped us. Keki, Vladimir, Imad, Pablo, Jose, that's Aipe there, Ramesh, and so many others. Thank you all so much. And because of the essence of time, I shall now leave it to Amir to talk about the development of neurovascular the essence of neurovascular development from an anatomical point of view. Thank you again. Thank you so much for giving me the privilege and the platform to enable me to thank Yoko Kato personally. Thank you again.
Thank you, Dr. Mahmoud Qureshi. There is no doubt that you are doing a great job in Africa. Thanks to be with us. So, Ahmad, please.
And Kazadi, it is always a pleasure that when we come to operate in Africa. So the conditions, the operations, and the infrastructure may not be the best. Doing there, both of you, Kazadi and Mahmoud, what you're doing there is truly remarkable, and we have enjoyed each of our time. What you guys are doing is really truly remarkable with what you have right now, and I'm sure conditions.
Amir, yeah, Amir,
Okay.
are you ready for your presentation?
Yes, thank you very much, Professor Imad
Welcome.
Kanan.
Yeah, welcome.
And thank you. And I, just hope that you're all able, to hear me. What I had done is made a video presentation of the neurovascular development, and I just hope that it will play. Please tell me if you can hear that.
We see the announcement of it.
Work?
We can't hear it. We can't see it now.
Oh, sorry, is it not playing?
Tamir, it was there on the first.
It was there, it started playing.
It was there.
Okay, sorry, I just stopped it there. Was it playing? Please just let me know if this plays now. Let me share that. And is it?
Yeah.
Yep.
Yes.
It goes off.
Not there anymore. Amir, can you share a screen again and play the video on like full screen?
Sorry. There seems there's a slight issue here. Let me just try and share the video again.
Maybe you can share your screen, your desktop, and
yes. Let me try that. Correct. Let me just share the desktop. I will play this, and
now can you play the video?
Yeah.
Yeah, it's there.
It's working, yeah.
Can't hear you.
is there's no volume.
No, we cannot hear the video.
Sorry, my sincere apologies. Let me just change sort of gears here. What I'm going to now do is see if I can just get the actual presentation and go through it. Stop share that. Share screen. I'm sorry about this. I'm having slight issues.
Yeah, no problem. Let's move to the next speaker and try to fix it at ease. And you will follow the next speaker from the second session. Okay.
Oh, it's already gone. All right.
Oh, let's see. You are on.
Okay.
Yes.
Shall we go ahead?
Do you want to speak us? You want to talk us through it rather than?
Okay. So yeah, sorry. Are you actually not able to hear me?
No, we're just seeing the scan, the images.
Okay. Fine. Sorry, I'm just going to need to set this up again. Do we want to go to the next presentation and come back?
Yes, please. I mean, it will be the best probably. Imad.
Thank you. Sorry.
Okay. Imad?
You are mute, Imad.
Yeah, I think since we are going to the next sessions, we can, if you can carry over with the moderators for the next sessions, and then the second speaker following Professor Kasadi will be Amir. We'll give him a second chance for that. Okay. Yeah, Giovanni, you are chairing the second session.
Yes, thank you. Hello again to everybody. So we started the second section of this wonderful program in honor of Yoko Kato, and it's my pleasure to introduce Igor Maldonado. That is, I'm sorry, our friend Kazaki Karangu, that was trained in Italy, and he will talk about the supraorbital approach and its utility. So please, Kazadi.
Okay, thank you very much. Let me put my presentation on the screen. Can you see it?
Yes.
Excellent. So let me put in more presentation mode. Here we are. Slideshow. Okay. Can you see my presentation?
Yeah.
Yes. Sorry, go ahead.
Thank you very much. Thanks for the invitation. for this International Academy of Neurosurgical Anatomy. And I'm very privileged to be part of this first presentation. And also it is an honor to be part of those lectures. And they are directed to our friend and colleague, Yoko Kato. She's a very respected colleague, a fantastic friend. We've known each other for many years. As you say in English, donkey years, you know, plenty, okay. She's really a role model for many young and adult neurosurgeons. Very intelligent, very determined, very generous, and well-traveled. Yoko, you should write a book about your traveling, because sometimes you are like an external observer. It could be very, very nice, you know, to see your experience of discovering the world. So may you be healthy for 100 more years. Thank you very much, Yoko. So the supraorbital approach. Now you see I've written pituitary tumors. That's how we developed this approach because of the pituitary tumors with supracell extension. And in the process, we started to use this approach for other pathologies as well. But I will also show you the limitations we have. It's a very simple approach, very affordable, very simple. It needs, however, some magnification, like a microscope. But I've done some operations with magnifying glasses in countries where we didn't have microscopes. The history is well known to you. And more recently, Jane and Delachaux described the supraorbital craniotomy for the approach of orbital tumors. And there were other variants, you know, proposed by Professor Al-Mefti and other colleagues. The study we did, in fact, was actually on pituitary tumors, and we didn't have any data in Zimbabwe, so we had to review a bit our experience. And we saw a number of patients. They were quite, for our experience, you know, we had a 37 for 2 patient cases note were retrieved, and the general symptoms are well known. Yeah, headache, blurred vision, and people feeling very tired. As you can realize that our patient didn't come very early with simple side. They came because they had a severe headache, or most of the time because they had actually blurred vision. And of course, decreased libido, galactorrhea, and so on. Those were specific symptoms we find out by asking questions. And you see that the delay before they came, when you look at the presentation, you see that the average years, you know, before they get to us is 4 years. And usually they come in 85% of the cases because they have a serious visual impairment. A type of tumors, of course, the majority was prolactinomas and others non-secreting tumors. We had also a few cases of acromegaly. Just to give you a bit what we, and all people had CT scan and MRI. This is a good evolution in our neurosurgical practice in Zimbabwe. And all those cases, we couldn't see them before because we didn't have the CT scan or MRI. The moment we had CT scan and MRI, we started now to see them. We used to do carotid angiograms, but those were showing huge tumors, and then we didn't have microscopes either to operate those patients. And the operations, as you can see, total debulking is 67% of the patients. Partial debulking is 37%. Fortunately, we didn't have any death, and some people improved, 83%. But of course, those who were blind didn't improve. We had few complications of morbidity, like diabetes insipidus and people whose vision didn't change after the operation, and hemorrhage in the nostril, and some people had epilepsy. This is the time we're doing it by transsphenoidal approach. Now, within 15 months, patients initially with macroadenoma with supracell extension, we saw that the recurrence rate was actually 10% within 15 months. And after 5 years, the recurrence rate was 18%. So this was not only due to the tumor factor, but we thought that, I think, our operation wasn't extensive enough to remove all the tumors. Can you still hear me?
Yes.
Thank you. The classification is standard. Everybody knows it. Grade 0, grade 1, 2, 3, and 4. We know that. Now, the goal of the anterior skull-based surgery, ideally, is curative surgery. So we know that by curative surgery, we imply that we remove totally the tumor. And now, it helps to reduce brain and nerve retraction, minimizing stress on the optic chiasmatic complex and the frontal lobe. And of course, it helps to improve the visual field. And it can preserve both, at least one of olfactory nerve, which is very, very important, and it can prevent CSF leak. Those are advantages for this approach. And of course, a lot of approaches were designed and like traditional craniotomy approach, like pterigonal, bifrontal, transbasal, orbitozygomatic. And we wanted to choose a technique which was easy, simple, without too many problems. So we thought about keyhole craniotomy approach. And we thought that lateral supraorbital was actually, or mini pterional approach was the most appropriate, because we had the microscope, and by positioning very well the head, we could actually have access very easily to the anterior fossa area. You see here the diagram. You can see this approach, which is showing a huge opening here, which we were using actually when we had actually meningiomas of the anterior fossa, huge meningiomas. Then you find out that by using this technique, which is very simple and cosmetically very acceptable, we could actually do quite a lot of surgery on the anterior fossa there. Now, usually what we do an incision, and when we arrive here, we actually go around this nerve, which is embedded into the muscle, and we go around, and so that we can increase. It gives more room, so you can see also the other side. But recently, we found out that a few cases we did, following the remarks of some colleagues when I presented that by doing just an incision, which doesn't go beyond the nerve, we actually do the same. We have access to many pathologies without any problem. Now, of course, the primary criticism people are saying, those minimally invasive approach, is that there should be a limited field of view, which is untrue. In fact, when you have this magnification, you can see very well how this operation can be done. And you can see here on my left-hand side of the screen, publications which are done, and they are fantastic. Now, of course, before one embarks in this kind of surgery, there is some work to be done on cadavers, and it's very, very simple. As you can see, there are many variants: supraorbital craniotomy, transpalpebral craniotomy, transconjunctival craniectomy. We found those are complicated, and we use a simple supraorbital craniotomy. And we found that by doing that, actually, we have access to most of the pathologies. This is a patient who is positioned. As you can see, the head is in hyperextension. You see the angle here is going really towards, the head of the patient. Why? Because the moment we open and we drain some CSF, the brain will actually fall on the back. And what we do with the retractor is not really to retract, it's just to keep the brain on the position so that we can operate easily. You see here the incision, and what you see here is the line which is showing where the nerve is. It means when we cut, we get here, we go around here, and then we go, not on the skin, of course the skin is open like this, and when you cut the muscles, we go around here, and so that we don't cut the nerve, so that we keep that function intact. Here again, the positioning, which is very important part of the operation. Dura, the dura is tense, okay? And then we open here the dura, and you can see here, the moment we start now to drain the CSF, we start to see now the anterior fossa. And here you see that it's well opened without actually any retractor. It's actually the brain which is actually falling on the back. That's the size of the flap, the bone flap. And once you open the system, you see what you see. You see the optic nerve very well. You can see here the tumor in case of course, the pituitary tumors. And you can start your microsurgical resection without any problem. You have the retractor here, but the retractor is not really retracting the brain, just keeping the brain in position. You remove the retractor, you see that the brain will actually stay on it, on the position. But because of patient is breathing and the pulsation of this, of course, the brain tends to come and make an obstruction of the surgical field. You see after that, when you close, cosmetically it's very acceptable. It's very good. And the patients are happy, and they have difficulties to convince their relatives and the friends that they had an operation. So you see that in 35 patients we operated as 12 meningiomas. We operated 23 pituitary macro adenoma. And by doing that, by the way you see here, for example, that's a patient. Here I put that for the students, to show them the carotids. This is the tumor with suprachial extension after the operation. And you see here, there is quite a huge tumor. And this tumor was removed without any problem. You see here, we have a tuberculum cellular meningioma, and this tuberculum cellular was removed without really any problem. It's a simple, very friendly approach. You can see here the tumor, and you can see here after the operation, post-operative MRI of tuberculum cellular meningioma. Now, in conclusion, this is a simple and affordable technique. By the way, we didn't try to do other things because in the previous lectures I gave, people asked if we could do aneurysm and things like that. Aneurysm, you can see very well the vessels. The only problem is you don't have any control on the distal and distal part of the vessels. So you cannot control that. So it's a big risk to do the aneurysm. If things go well, that's fine, you are a hero. But if there is a complication, then you are what you call in French a zero. Okay. It allows this technique large space for microsurgery. You have many surgical options, of course. You consider the tumor extension, reconstruction, and so on. Frontolateral approach, we think that it is preferable. Okay. And actually, you can see both sides very well. You can see both optic nerves, both carotids very easily. And actually, if you want, you can combine with endoscope. We've used it, and it's fantastic because then you can see, particularly posteriorly and far laterally. If you have the endoscope, it's a very good adjuvant. You can use it as well. It allows visual function to be preserved. That's very, very important, particularly for tumors which are compressing laterally the optic nerve. And also from tumors which are invading the optic canal. By that approach, you can go and remove those tumors without any problem. I thank you very much for your attention. And thank you again for inviting me for this webinar.
Thank you, Kazadi. It was a wonderful presentation. There is any question to this presentation?
Giovanni?
Yes, please, Francesco.
Kazadi, I congratulate you for this presentation. You really illustrated very well the advantages of this approach. I agree with you that this approach may be suitable for some meningiomas, as for example, tuberculum cell meningiomas. But I wonder whether we can advocate this approach for pituitary macroadenomas in the era of endoscopic endonasal approach to pituitary gland. So this is my doubt, but I would like to hear your comments on this.
Yeah, we use this approach only on macroadenoma, of course, with suprasellar extension, particularly when they extend even laterally.
Okay.
Yes. And if you don't have an endoscope and you have a microscope, you can do the operation without any problem. Now, of course, we have used endoscope as well, because we can go on the far lateral aspect, and we've had a lot of joy, to see pathologies on the far lateral aspect of the anterior fossa. What you say is true, of course, and but we found that it's simple, and you can do it anywhere. I've done it in countries where they don't have much technology, and it goes very well.
Thank you. There is any other question or comments? If not, I would like to make one compliments for this, for presenting again this approach. I did in a previous webinar a lecture on that. I think that you can go till when the brain is going down till the other side, to the other optic nerve, to the other carotid artery. So I think that, of course, you need a little bit of space. The space is not so much, but it is enough to work there. And also, I did some aneurysm. Of course, it's better if it's A1 aneurysm or so. You cannot do contralateral aneurysm. But Reish did it also contralateral aneurysm. So please. Compliments again for that, and thank you. So now we would like to come back, stay in the vascular, and ask to Amir Querishis if he is ready to present his contribution. Are you ready? No voice, no voice, voice.
Okay, Professor, are you able to see my screen here? Okay, let's...
Please go ahead.
Sure, let me try and open it up. And okay, thank you very, very much. Let me proceed, and I'll try and keep it quick. My sort of introduction into cerebrovascular work was really when I first met Professor Yoko Kato in 2013, and it's actually Professor Kato that inspired me to try and walk, down this path of cerebrovascular work, and that then led on to the University of Cape Town, and I spent time with Professor Alan Tate. This presentation is really an inspiration that I first received from Professor Yoko Kato, and it's trying to understand how these vessels now grow and how they develop. And once that understanding comes on, our understanding of the vascular anatomy and how we have variations and anomalies sort of now starts flowing. So this is a video. This is a story that I would like to essentially tell. Our central nervous, central neural systems initially start off just as a very simple tube. It's a simple plate that folds and forms this very early neural tube in the embryo. And when it's less than 200 microns, it's simple diffusion of oxygen and nutrients that now enters this tube and helps it now grow. But as that tube grows, it now needs a dedicated blood supply. And that initially comes from 3 sets of paired vessels that form ventral to it. Closest to that neural tube, we have a longitudinal neural system, which will form in us the vertebrobasilar system. Ventral to that, we have paired dorsal aortas, and ventral to that still, we have paired ventral aortas. Now, for purposes of developing the internal, carotid system, it's really the first 3 of the 6 pharyngeal arches that are the most important. What's also important to now know is that very early on, there are very important primitive links that form.
The voice is gone.
It's frozen.
It's frozen.
I think it's the internet connectivity there.
Non posso.
Johnny, we probably should go ahead and ask Amir to
okay.
try that.
Okay, so we will be back. Sorry, because this neuroanatomical development was very, very interesting. So it's a pleasure to introduce now and give the podium to our General Secretary, Pablo Gonzalez Lopez. Are you there? Yes. Endoscopy assisted microsurgery in the posterior fossa. Please.
Thank you, Giovanni, and let me thank Imad and Vladimir for this tremendous effort of putting this idea together, and all the members and everyone who is behind the screen watching us now for 3 hours. So first of all, I need to thank Professor Yoko Kato from for her exhausting effort to promote neurosurgical education worldwide. I have been very lucky to meet her in many hands-on courses and meetings, and we need her to continue keeping this fantastic effort. So my talk is about how we can implement the endoscope 0, 30, and 45 degrees into the posterior fossa microsurgical procedures, and how we can make use of it in order to take advantage of watching hidden corners and dealing with benign pathologies. So we have been talking about minimally invasive in the previous lectures, and this is a concept that has many different meanings. For myself, minimally invasive means, first of all, solving our patient's problem, second, in a maximally efficient way, and finally, avoiding post-operative complications. So indeed, this is what means our specialty, neurosurgery, should be a minimally invasive procedure, considering these 3 important concepts. Well, going to the posterior fossa, it's interesting to be aware that the full intracranial volume is 1.5 liters, supratentorial 1.2, while the infratentorial volume, it represents 350 milliliters. So in such a small volume or area, we have very important structures of the bones, canals, foramina, the dural layers. The most important, probably, venous sinuses, in which all the sinuses of the brain are getting together. Neural tissue, extremely important, arachnoid, cisterns, vascular system, cranial nerve. So in such a small volume, we have highly relevant structures that we should deal with. And depending on the orientation of the microscope and the focus, we can see different structures in a different perspective. So in this example, we can see how the fifth and the lower cranial nerves are seen in a very different way if we focus deeply or superficially. So this is something important that we must be aware of. And this is one of the important things about the microscope, which will give us a 3D view of all these structures. So, which are the most important and common approaches to the posterior fossa? We have the anterolateral, the pterional pretemporal FOC, the lateral subtemporal transpetrosal, posterolateral, mainly retrosigmoid, and the far lateral or enough lateral, and the posterior midline approaches with the medial suboccipital and even the supra-infratentorial. These are the four more important routes through which we can reach the posterior fossa and deal with this pathology. So simple retrosigmoid microscopically seen approach will give us a limited view as we are getting deep into the surgical field. But if we use the endoscope, we will have a much more panoramic view, and even we can move our eyes to hidden corners. So this is a simple exam, MRI exam in which we can see a normal CP angle. This is what we are watching here. And once we open the dura with the microscope, this is the general view we will have. So we can see the 7 and 8 nerves right there, and the lower coronary nerves a little bit lower to our view. But if we introduce our endoscope, we can see perfectly a panoramic view of all these structures. We can move up to see the trigeminal nerve. We can move down to see the lower coronary nerves and many different things that we cannot see directly and without retraction with the microscope. So this is the first value of the endoscope. So this is how we can make use of the endoscope in order to see how the superior cerebellar artery is compressing the anteromedial aspect of the trigeminal nerve. It's something that we cannot see directly with the microscope. So thanks to this view, we can implement and maximize our surgical perspective. So this is how we place our patients. So obviously, we need the microscope in front of us in order to have a direct control of the controls of the microscope. And we always try to place the endoscope trolley just in front of the main surgeon so he can have a direct view of the screen without the need of moving the neck. So this is a case of a trigeminal neuralgia in which we can see a compression of a vessel. But once we open the dura and release some CSF, we are exploring with the microscope the root of the trigeminal nerve, and we were surprised that the superior cerebellar artery was superior to the nerve, and we couldn't see any vascular compression. So in this kind of cases, especially when we have a quite volume of the suprameatal tubercle, it's good to introduce the 0 or the 30 degrees endoscope, and we can see a hidden corner to the microscope, which is this pontine vessel, which is compressing the entry point of the trigeminal nerve into the Meckel's cave. So now with the microscope, we can drill this bone, this suprameatal tubercle, and we have access directly to this pontine vein. And with the endoscope again, we can understand much more the kind of compression we are having. And the advantage of the microscope is obviously that we are having free maneuvers with our both hands. So we are placing the Teflon, and in these cases, we are assisting our microsurgical maneuvers with the endoscope. And finally, we can check that the decompression is quite good. Another example, what we can do, and this is what we are doing nowadays, as Giovanni was showing us, we can take advantage of technology in order to deal with tumors and to train ourselves and our residents perioperatively. So this is a trigeminal schwannoma with a middle fossa and posterior fossa components. So generally in this case, we usually go through a subtemporal approach. This is the view we will have, and this is what we want to see. But we must not forget that this part, this final part, could be hidden to our maneuvers. So this is what we are doing. We train with our 3D printed models. We are expanding our view through the middle fossa. So this should be the third nerve, the third branch of the fifth nerve, sorry. So we are moving to the Meckel's cave. So this is the location of the Casserian ganglion, where we have the part of the tumor invading the Meckel's cave. And now, in order to train ourselves with the use of the endoscope, we can go to the posterior fossa through this subtemporal approach. We see the Casserian ganglion and how the tumor is hidden behind this trigeminal nerve. So this is the part that we are not able to see. And this is how the use of the endoscope, we are working with 4 hands right now, and we are drilling the petrous apex in order to gain access to this hidden part of this tumor. And I can tell you this is really useful in order to practice in the lab before going to surgery. So we are acquiring the skills before going to the OR, just in case we find some troubles during the resection. This CTA epidermoid tumor, and we can see that the tumor is quite hidden, just anterior to the 7th nerve. So it's just growing in front of the Luschka foramen, which is a relatively hidden area. This is a point in which generally we have also compressions in cases of hemifascial spasm. So let's see how we can take advantage again of our endoscope. We start releasing CSF with the microscope. These are the lower cranial nerves. So now we are trying to open the arachnoid. So it's clear this is the 8th nerve. We couldn't see the 7th nerve. We were expecting to have the 7th nerve behind. But look at what happens if we move our eyes inside. Here we do have the fascial nerve in a quite aberrant position. So in this case, it was quite helpful to attack the tumor from the upper part of itself. So once we think the tumor is completely removed, we introduce a 30 degrees endoscope, and we realize that there is still some tumor remaining behind the 7th nerve. So this is how we can implement the 30 degrees endoscope in order to achieve or maximize our resection. So this is the hidden corner that it's quite difficult to manage with a microscope without a big retraction. So finally, we can check that the resection is good. And this is what we are doing. We are maximizing and implementing, moving our eyes to the hidden parts. This is one of the first cases I did in 2013 or 14, if I remember well. This is a vestibular schwannoma, which was completely destroying the petrous bone, the internal acoustic meatus. So here we have the CT scan. The patient was experiencing a quite fast progressive hearing loss. And this is the kind of defect that we had in that internal acoustic meatus. So with the translabyrinthine approach, we will obviously completely damage the hearing function. So that's why we decided to go retrosigmoid in this case, and to try to drill as much as we could the lateral wall of the remnant of the internal acoustic meatus. So this is the work we are doing with the microscope, 2 hands, microsurgical maneuvers, opening the arachnoid. And once the cisternal compartment is removed, we introduce again the 30 degrees endoscope in order to see this hidden area, because we didn't want to drill as much as to damage the labyrinth. So this is the final part of the tumor, which was in a hidden angle, completely hidden with the microscope, and the use of the endoscope was really, really fantastic. So another case, and I had the privilege to discuss this case with Professor Schroeder before going to surgery. This is a very, very special case. He was a 12 years old boy who had a problem since he was a baby in the left hearing function, but then he started to have a progressively hearing loss in the right side. So we decided to go for surgery for this small intrameatal vestibular schwannoma. We started with the microsurgical maneuvers, releasing CSF again, opening the dura with the cerebellum quite relaxed. And now we decided to start opening the lateral wall of internal acoustic meatus. At this point, the patient was already improving his hearing function, which was something very, very unique. And this is the superior and inferior vestibular nerves. This is the vestibular schwannoma, which is completely intrameatal in this case. So we opened the dura at that part, and with the microscope, we had enough to take out most of the volume of the tumor. But then we introduced, and this is what Professor Schroeder recommended me, to go to check with the 45 degrees endoscope the fundus, and we found some remnant of the tumor. And this was a fantastic case in which the patient indeed improved his hearing function, and we are really happy about the result. And this is something that could only be done in a safe way with the endoscope. This is an hemifascial, classic hemifascial spasm in which a superior loop of the pica is compressing the ventral aspect of the 7th nerve. So this is a clear spasm. This is how we are planning to work in between the lower cranial nerves and the 7th nerve. And always, we are always introducing the endoscope before going further to the anterolateral aspect. So this is the 7th nerve, 5th nerve, and this is the superior loop of the pica, clearly compressing the root of the trigem of the 7th nerve. So we check it. And at this maneuver, at this point, we had a complete disappear of the lateral spread reflex, which is a clear sign that the surgery is going to be successful. So this is how we can check again with the endoscope that the pica is completely now decompressed. So another case, we can use an approach to the posterior fossa in order to reach the supratentorial space. This is a parahippocampal tumor. We are releasing CSF from the cisterna magna, placing this cotonoid in order to check the point where we want to open our tent. This is the V-shaped incision in the tentorium. And in this case, it's especially important to use the endoscope because sometimes when we want to reach this anterior part, which is hidden behind the petrous bone, we really need to push this part of the temporal lobe up, or even to use the 30 degrees endoscope. And this is what we did indeed in this case. We were working with 2 hands with the endoscope and the CUSA, so we were able, in order to reach, even to reach the superior part with the fornix, crus fornicis, and the most anterior part in the temporal horn with the use of the endoscope. And this is the last case I want to share with you. This is a purely midline posterior fossa approach, medial suboccipital, in order to reach the 4th ventricle. This tumor is a epidermoid tumor, which is quite attached to the floor of the 4th ventricle. And one of the difficult areas in this case is if we don't have a favorable anatomy and the patient is in a sitting position, which is something that I consider really important in this kind of cases, is to reach this superior and posterior part. And again, with the endoscope, we can make sure that the hidden corners of the 4th ventricle are free of tumor. But even if we see some remnant there, we can even work with the endoscope or with the micromirror, which is something also extremely useful in order to deal with these cases. So this is the last case, and this is the an arachnoid cyst, the CPA with severe progressive dysfunction of the lower cranial nerves and the vestibular nerve. So here we are dealing with the neuroendoscope. So we are working with 4 hands, and we are working through the working channel. So that's going to give us a good chance in order to minimize the craniotomy and to maximize our surgical view. Only we use this kind of approach when we are planning to do very, very simple maneuvers as opening or creating these fenestrations. So this is the nice anatomy we can see with the endoscope, all the cranial nerves completely decompressed and the fenestration done around the posterior fossa. So here we can have a nice view of the whole brainstem with all the cranial nerves. And indeed, just to summarize, as we have seen, we can use the endoscope or endoscopic assisted microneurosurgery in order to see hidden corners with 2 hands. We can use the so-called endoscopic controlled microneurosurgery with 4 hands in order to directly resect a tumor or perform some maneuvers with the endoscope. And we can use even full endoscopic surgery with 2 or much better with 4 hands. So again, I thank you so much for your attention and this innovative idea of creating this Neurosurgical Anatomy Academy. Thank you so much.
Thank you, Pablo. Wonderful presentation, just in time. And that is a really step forward for all the cranial nerve surgery, also for the supratentorial, as you show, for the posterior hippocampal area. There is any question or comments, please?
Yeah, I'm very happy that he likes the endoscope for vestibular schwannomas.
You teach it me.
Yeah, I think it's really beneficial if you have hearing preservation and you cannot drill far laterally. And that is really a nice addition to the microscope. And I think the combination of microscope and endoscope in most cases is the best option. Of course, you can do anything from the beginning with the endoscope, but is it really an advantage? I don't think so.
Thank you.
Sorry, I have a question.
Another question?
Yeah. Thank you very much, Pablo. Fantastic presentation. Of course, you use, endoscope 30 degrees. If somebody doesn't have an endoscope, do you think you can use a mirror? You remember when we were doing pituitary tumors in a long time ago, we're using a mirror to see on the opposite side. Do you think there is room for that?
Thank you, Casadi. Indeed, I'm using the mirror a lot. In many of the glioma cases in which my deep corridor is quite narrow, what I do is I check the walls with the endoscope, and finally I work with the mirror, the suction tube under the microscope view. So I complement both of them.
Okay. Thank you very much.
Any other comments? If not, I would like to make a small comment that the last comments about the gliomas is very, very important about the mirror. And I think that you show that 4 hands and 2 hands and more 4 hands is much better than any older are working with endoscope. I think that is a lesson that you teach us. Thank you. Okay. Can we move forwards? Sebastian Frodi, Sebastian, are you there?
Absolutely.
Okay. So I'm a privilege to introduce you to TBA. Please give us the title of your lecture.
So
sorry, it was replaced. TPA was before, but he sent the title.
Yeah.
So
I made some progress.
I was making joke.
It was updated.
So, thank you very much first for inviting me, Imad, Vladimir, Pablo. The group of people you have built is absolutely great. And for the young people all over the world, it's a fantastic opportunity. So thank you for including me and to this new academy, which I will be happy to help on to do whatever you want me to do. Thank you also to Yoko Kato, who is one of the heroes of neurosurgery. We have met few times only, but the amount of work, of energy expend to help, to support young people is absolutely amazing. I am one of them, one of the people that Yoko Kato helped or supported, and I am extremely grateful for that. So thank you for including me into this special session. The thing I wanted to talk about today is extended endoscopic approach, and mainly what I am trying to do since I started about 15, 20 years ago with my first cases of endoscopic endonasal. And as many of us, I have followed the steps of big names, big group that really open a new road for us. But meanwhile, quite rapidly, I thought that the morbidity caused by this approach, even if it seems to be minimally invasive, was not zero by far, depending on the extension of the approach. Still, it's a revolution in skull-base surgery. I am a big advocate of this corridor for many diseases, especially those located on the midline. And we can go almost everywhere deep in the skull base now with an endoscope through the nose. There is limitation, obviously. One of the main limitations to me is that it's definitely an approach that is based most often on the resection of tissue rather than mobilization. When we do a transcranial approach, open approach, we mobilize structure, we mobilize the tympanis muscle, we mobilize the skin, we create a corridor by mobilizing structure. With endoscopic endonasal approach, extended, it's a lot of resection of normal tissue. And this started to be an issue for me, and we try to improve or to find new ways to preserve those structures. Definitely, with endoscopic endonasal approach, the more you go laterally, the more you resect tissue. It makes a lot of sense. It's common sense. The higher is the risk for the cranial nerve, for the vessels, but also just for the general morbidity of the approach, because you resect normal tissue. And this has a cost. Even if a lot of people, teams are thinking that it has no cost for the patient, if the question is asked to the patient, there is a cost. So according to the location of the lesion and where you go with your endoscope, the morbidity is different. Classic exposure of an extended endoscopic approach, midline sphenoid sinus. Well, if you resect a lot of normal tissue, you have crusting and nasal discharge. All this can be worse with the radiation therapies that may follow. At the level of the craniocervical junction, you have the issues related to velopharyngeal insufficiency. And for those who have done big tumors in this area, especially chordoma, it's definitely true. Patients complain of nasal speech, nasal regurgitation, hearing impairment every time you go around the eustachian tube because of otitis media. When you go up around the cribriform plate, you start to have issue with anosmia, and it gets worse if you get more anteriorly. Crusting nasal discharge, it looks irrelevant, but when I do octagonal approach, my patients are not complaining of crusting and nasal discharge for months. The cause of it is mucosal removal, mucosal injury, bone exposure, coagulation, all of this that we do in the endonasal skin. The mucosa is nothing more than the endonasal skin. It takes a much longer time to heal from periphery to the center, and it takes months. So for months, patients are complaining. They may not complain to the surgeon, who sometimes saves their life, but they are complaining. It's present from morning to the midnight. Prevention of it is mainly treatment, in fact, and there is a very little about prevention in the literature. And most often, we advise the patient to clean his nose 3 to 6 times per day for a few months, depending on the extension of the approach. But it's not nothing to clean his nose 3 to 6 times per day for months. For chordoma patient, if you put on the top of it proton beam therapy, even again, if they are not complaining of it, they feel it, and they feel it for a very long time. This was one of the first cases of big craniocervical junction tumors I did here in Paris. Chordoma, craniocervical junction, big tumor, extensive approach. Surgery was very nice because it was challenging and we made it, but the cost was significant, cutting a eustachian tube on both sides, part of the inferior turbinate, septectomy, nasoseptal flap, and go on and go on. Removal of posterior pharyngeal mucosa and muscle. Resection was fine, patient was controlled for his chordoma, but the next day we had to go back because of instability. So it was about 24 hours of surgery for this patient, or general anesthesia in 2 days. And this was the cost for her. She had all those considered minor complications: bad smell, nasal discharge, chronic sinusitis, nasal speech, nasal regurgitation, nose washing forever. She's still washing her nose. It's 8 years from now. Loss of smell, hearing loss. So I think we have to do something to improve the morbidity of the approach. Some of us, I am watching Henry Schroeder, who is, I think, in favor of this from the beginning. But for those who went into extensive approach to treat extensive tumor, we can do better with less aggressive approach, with a better approach selection, and also improvement of dural closure, because CSF leak, as you know, remain a big issue. In this process of trying to be better, we still have to be careful that for some tumors, it's better to be maximally efficient considering the tumor biology than trying to be minimally invasive and remove only a bit of the tumor. For chordoma, for example, the priority, even if we try to do better in terms of morbidity, the priority remain complete tumor resection. What is the goal of endoscopy? To take advantage of the natural cavity. This is why we use an endoscope. We use endoscope to benefit of this air cavity into the nose. We want to see deep structure without creating a big opening. And we want to look around the corner. This is what Pernesky was telling. You use a 30-degree scope because you want to look behind the corner. But with the techniques we have been promoting over the year, in fact, we create behind the nose sometimes a big cavity, which doesn't make much sense with the use of the endoscope. So we have been trying to use this technique, the chopsticks technique. In fact, the concept is simple. We carry the endoscope on the left hand with a rotative malleable suction also on the left hand. And on the other hand, we use a working instrument. The advantage is that we are not using holder. So the smallest is the space in which we work, the easiest it is, because the endonasal structure are the holder, in fact, are supporting the endoscope and the instruments. And the endoscope and the suction cannot go anywhere else than just in front of the surgeon. We have published this work. It's more than 10, 15 years now that I work with this technique, because I worked with a rhinologist at the beginning. He was using it, and I worked with what he was using. And it became extremely natural to me to use this technique. You can be very precise because the tip of your endoscope is really close to the tip of the instruments. I had very, very few vascular injury. I don't believe it's because I have a special ability. I just believe that it's because the tip of my endoscope is very close to the tip of my instrument. And we know from the literature that most of the injury to the carotid artery comes because the endoscope is too far and because of the 2D view. So I am using malleable endoscope, malleable suction, sorry, not yet for the malleable endoscope, curve instruments, angle instruments. On most of those instruments, I have found it in the ENT set. There is a huge amount of instruments in ENT set, which can go about everywhere into the skull base through a very small corridor. So I advise you to look at ENT set to find what makes you happy and to reach deep area of the skull base. I just saw recently this drill. It comes from China, and you saw that the tip can be oriented. I remember 10 years ago that Storz developed a malleable drill, but because it was not so much used, they are not producing it anymore, but it was absolutely fantastic. What we are also trying to do is to consider the mucosa as a skin. The skin is very thick at the level of the rostrum of the sphenoid. This is where the mucosa is thick and where it can be eventually sutured at the end of the surgery. So what we do is that we expose the rostrum, we incise the mucosa, we drill completely the rostrum of the sphenoid, which is a great volume, and then we use the space of the sphenoid, the space of the rostrum to work with angle instruments, angle scope. At the end, we take the mucosa out and we put fat and we stitch this rostral mucosa. So again, we use the volume of the rostrum, one nostril, and at the end, we put a big piece of fat and we cranialize the sphenoid sinus just like we cranialize the frontal sinus when we do a bilateral frontal approach. We remove the mucosa and we cranialize it. I think it's an excellent way to close, combined with the 3F technique, taking into account the position of the patient. This came from the Napoli team. It was very clever. The combination of stitching the mucosa with upright position very early for the patient. I was in my last 10, 15 cases quite satisfied with it, with only one CSF leakage for a big case. So this is an example of it. This is a chordoma. It's not a big tumor, but it's a perfect case for this technique. We make an incision here of the rostral mucosa, and because we are using the chopsticks technique, we can use a diamond drill. There is curved diamond drill now, very safe. Risk of injury to critical structure is very limited. We increase progressively the volume of work, and we use this volume as a natural cavity to use the endoscope and associated instruments. So this is a peeling of the mucosa from the rostrum of the sphenoid. You have a window in front of you of bone. This bone can be removed. It makes it easier to stitch at the end to approximate this mucosa. So here in this case, as you know, the chordoma is a soft tumor. Once it's exposed, it's only a question of time and a question of visualizing the tumor and having the instrument to catch it. It's not a difficult dissection to perform. It's just sucking and taking the tumor out with Ranger or whatever instruments you need. Here we went below the sphenoid sinus, below the mucosa of the sphenoid sinus. We had no need to go through the sphenoid sinus. We are using the same landmark. Neuronavigation became more important because it's not as easy as before to find the landmarks. Here it was the median nerve to get to lacerum segment. I am moving a little bit forward. This is the tumor through this tunnel of bone. Again, I am never using the 0 degree scope. For me, it doesn't make sense to use an endoscope and to have a 0 degree, because what you want to do with an endoscope is to open your space to see widely around the corner. So the minimum is 30 degrees, but quite often I use 40, and quite often I use 75 degree scope. At the end, the closure of the mucosa, I changed my technique over the years. Now I am using a more simple technique than this one. I am making a running stitch. First node is made out of the nose. I bring down the nodes, 2 nodes. I bring it down quite easily. And at the end, instead of doing a node deep, I cross the mucosa of the rostrum, come back in the surface, go through the septum again, and I make my node here just in the vestibule of the nose with a resorbable stitch. I show you here another case. So this was a cartoon showing the principle of this technique. I show you another case here of a craniocervical junction chordoma in a young lady. Tumor is extensive, but same principles than for foramen magnum meningioma. The biggest is the tumor, the easiest it is, because you have space to work. And the structure are already retracted. Here it's the same. The tumor is big, I have space to work. So we did exactly the same thing. Small incision in the rostral mucosa, tumor is bulging a little bit, peeling the mucosa from the rostrum, drilling of what's remaining of bone, and then just a question of time with angle suction, malleable suction. My rotative suction can be bent 90 degrees, even more, if I want to look behind the paraclival ICA. The difficulty sometimes is to take all the mucosa of the sphenoid sinus, which is sometimes, as you know, very pneumatized. And this has to be done because you have a risk of mucocell, just like it is the case when you cranialize a frontal sinus. You have really to take all the mucosa out. This is with a 70-degree scope. You see the posterior aspect of the petrous ICA. Resection looks complete. You have to drill as much as bone as possible. And at the end, you put fat into it and unstitch this opening of mucosa the same way I showed you before. Again, I changed a little bit my technique in the recent time. Until now, I cross finger. I had no infection of this fat. It could be definitely an issue. I am quite careful with washing the nose before, washing the nose at the end. I am not using antibiotics, except if I have a big opening of the dura. Until now, I have to say I was quite satisfied without infection, but most likely it will come soon as any complication. So here is a running stitch, and at the end, I close outside. I have few other cases, but I am going to go fast on those. I just want you to show you the film of these ladies that I saw last week in office. So this is a post-operative MRI. It's 2 or 3 years from the surgery. You see that the endonasal cavity is absolutely intact. It's nice for the MRI, but it's nice for her because she has a normal nose. She's breathing, she's using her nose exactly the same way than us. So it has definitely some value, in my opinion, for the patient. Other case, same principle. I skipped the video. You see here, closure is the same with fat and the normal anatomy of the nasal cavity. This is, yes, I should conclude. Yes?
You're out of time. Try to conclude.
I go directly to my conclusion. So what I think is important for the next steps of extended endoscopic endonasal approach is really to come back to the true concept of endoscopy. We have to reduce the surgical footprint of our approach. We have to preserve the anatomy. The mucosa is just like the skin. Definitely, we are lacking still instruments and technology, but I have no doubt that in 10 years from now, what we have done 10, 15 years ago will be considered as history. Thank you very much.
Thank you, Sebastian, for this wonderful presentation. Sorry to interrupt you. But,
no, that's okay. I'm sorry to be too long.
It's okay. No, there was a lot of cases, very interesting. And I think that the lecture that you give is very important. The mucosa is like the skin. And that is the first step. All the others you explained very well. There is any comments?
May I just ask Sebastian a question? Sebastian?
Yes.
That was wonderful, Sebastian. I loved your idea. I think the concept is very elegant. And the concept of considering mucosa as the skin, I think is very important. So that means that you're trying to reduce the use of the nasoseptal flap. So you're using it less and less, is that right?
I have not used the nasoseptal flap for at least 2 or 3 years. And I have done quite a lot of clival chordoma. I have to say I'm not using it anymore, or very rarely. Never is not true, because there is still indication for which you need an extensive approach. For chordoma, the priority remains complete resection. So if I don't feel comfortable with this strategy, I come back to the classic strategy.
Okay, even if you have to resect a lot of dura, will you still not try to use it?
No, because I think the nasoseptal flap is not used to do a watertight closure. It's just used to colonize tissue that you put on the defect. So I do the same. It's a vascularized closure also, but it's watertight because I stitch. And I am extremely satisfied with fat when I do transcranial approach. I'm sure you are also. Fat is a fantastic sealant. So here, fat plus this suture of the mucosa, until now, I am quite satisfied.
Thanks.
Just one quick comment. I completely agree with Sebastian. In fact, we also almost completely stopped using the flap. And it's essentially the place you have to find where the durotomy is, if it is a small one or a large one, and keep the correct size fat in the right place, and then do a lead reconstruction like that. So it is the correct size of the fat graft in the correct place that makes the biggest difference, I think. And
the position also, the position then. Having a patient in an upright position immediately after the case. The idea of the Napoli team was extremely clever. And it's funny because we did this for 20 years and we didn't thought about it, that putting our patient upright rapidly was extremely important to control intracranial pressure. And the best way to do it.
And also avoiding a lot of other substitutes, to all the dural substitutes, all the kind of things. Recently, I saw even bone cement invented for this, but I think it's a bad idea to put anything which is not autologous.
Thank you. Any other comments? If not, I ask Pablo to take over to the chairmanship and present the next speakers. Pablo?
Thank you, Giovanni. I'm ready. And let me quickly introduce Mr. Cysternostomy. There is no one better than him to explain us some anatomical nuances about this fantastic technique. Ipe, all yours. You should, yeah. Now.
My good friend, Pleasure to see all of you. Ramesh, Roy, Pablo, Giovanni,
Allô,
Kazadi.
Peggy, oui. Excuse-moi, j'ai tardé à te répondre. J'étais
That was so. Meeting was in the honor of Professor Kato. She was my teacher. I remember learning vascular and skull-based neurosurgery in Fujita. Well, after that, she was more of a mentor, and it's a real honor to be talking about the surgery that started. So today, I'm not going to talk about cystonostomy. I'm just going to show a case again, as usual. And that should tell you a little bit about the anatomy of cystonostomy. I have three of my consultants here, Dr. Nargisa, and now I'm so proud, and after 50 of cystonostomy, guys have taken over, and all over the world I have these people who have taken over, and it's very rare I go to cystonostomy these days.
I just want to warn you, there is some connection problem. We are not hearing you continuously. The sound got interrupted every 2 words. We don't hear.
There is a lag in the.
Okay, now is it okay?
Yeah, it's better now. I think the volume is better.
Okay. Now, what I was saying, I'm proud of all who've taken over in the last 4 or 5 years, and I'm not have to go to theater for cystonostomies these days, and these guys do it much less complicated than me and better probably than. So I'm just going to show you a case, a recent case, but consultants did, and this will outline about some things about the anatomy of cystonostomy. So as usual, this is a tense brain, and have the frontal lobe and the frontal lobe to this side and this side. The suction side is a temporal.
Are you going to share anything, Aip? Or it's not sharing now?
I'm sorry. Right. Yeah. So can you see my screen now?
Yes.
We can.
Okay. Sorry. So we have this is a left acute sub with a temporal lobe contusion. I'll show you first. So you can see the CT. This is a temporal lobe, severe temporal lobe contusion. And the most important thing here is that you see the CP angle system is much. So that the temporal lobe is herniated. System everywhere. It's so widened, you see. And this indicates temporal lobe herniation. And you can see that the temporal lobe is here, the uncus is here. Okay, so, and you can see the hematoma here. This would generally, and this is a burst lobe, frontal and temporal burst lobe. So it's pretty tight brain. This patient is having a very high ICP. So here we are going ahead, and after the left-sided craniotomy, it's very important to remove off, as I call the sagittal axial unlocking. So we have to remove off in this, have to remove off the sphenoid ridge as well as the anterior clinoid. Well, unlike an aneurysm, we don't have to spend time on the anterior clinoid. We can just remove it as fast as possible. So once that bone is removed, we are now drilling orbital fissure, and I remove off the anterior clinoid, the sphenoid ridge, there's a lot of compression taken off from the dura. I mean, in fact, there's a large, that much bone when it's removed itself a bit more lax, you see, and then after that, after this, you're able to open. Once you do these unlocking procedures, you're able to get access into the base of the brain. And that's very important. And, you know, this, you must understand that 5/6 of the world has in common. So it's not you put your tumors together, all your aneurysms together, you still have a lot of trauma, much more trauma. So this is one, the young, and see that what we're doing here, I mean, what my consultants and they're doing, what they're doing is pure microsurgery. So here we have the temporal lobe, the frontal lobe there, and that's anterior. You've cut the anterior, I mean, orbitomeningeal band. The anterior clinoid process is uncovered here. So unlike in aneurysm surgery, here there's no need to worry about the anterior clinoid receptor. You can, once you, there's no middle clinoid problem, move it off. Punch. Once you open up, so the more thing would be, so that you mean you have to take the orbitomeningeal band and completely open it up. And once you open it, you can sinus roof with the third nerve, you can displace it down, and then doing it with a needle hole. And I'm going between the roof of the cavernous sinus, the clinoid. So the roof of the cavernous sinus is where my patty is, and I am displacing that away, and I am biting off the clinoid process. The clinoid process has been completely opened out. Well, in paraclinoid aneurysms, I do the drilling extradurally, but here we don't need all that because we don't have time. It's a very tough and bulging brain. So we go ahead till the optic nerve. Once you go medially, you can find out the optic nerve. So here, as fast as possible, you remove that and then after that, you open the dura. We're opening the dura. We are starting to do with the exoscope right now. The Escalab exoscope is excellent. So we started doing, in the lab, we started doing aneurysm, I mean, with the scope and endoscope combined, but right now in theater, we're starting to do it with the exoscope. We will plan to do cystinostomies with the exoscope. So this, you see, the brain we have opened, we've opened and let out the blood in the base. So now the brain is a bit more lax, but then it's still very tense. You can see the amount of damage that there is. Once I open the dura, you will see that the burst lobe, the temporal lobe, usually we hear it, the third nerve. Here, I can show you it's just not about the third nerve, it's about the carotid. It's going after the optic nerve. You will see that right now. So open, you see so much of damage, and this brain is non-pulsative, and the temporal lobe is bulging out. So there's acute subdural everywhere. And it is not as, as surgery and middle of the night. So most of the senior guys wouldn't want to go about it. So this is the shape at which you get it. And you get into the system. First thing you do is get into the system. Temporal lobe. What I'm pointing is the temporal lobe was above the carotid. This is the carotid. So the temporal lobe had herniated all the way up to the opticocarotid system. So we have small temporal lobe away from the carotid. So that is the window that we're looking at. So now we're going into the opticocarotid window and then opening it up, and you can see the A1 there, and you can see that window. The third nerve is there, And then now we're going to slowly open up this window now. Now, the problem is, once you're opening up, there's a lot of blood everywhere. So that's the optic. So that's a superior hypophyseal artery, and that's carotid. And then you have the basilar there. So this is the endpoint of the surgery here. You see the basilar, you see the superior cerebellar, lateral third. Now you will see that now. So that's a superior cerebellar artery on this side, contralateral superior cerebellar. You will see the third nerve here. Above the superior cerebellar is the third nerve. Third nerve, ipsilateral. We had already seen that, and the contralateral third nerve you will see here. That is here. Here it will see that, and that's the basilar there. And once you open up all that, and between the optic-carotid window, then you kind of done here. So you can put, after this, you can put a drain space and put a drain into the prepontine cistern, because if you put a drain anywhere else, but prepontine between the clivus and the brainstem, it's never going to close up, and there's always going to be CSF draining from there. So out all this, continuously open this up and keep watching, and the brain swelling, whatever brain swelling there was, it disappears. So you will see that. So in the beginning, the brain was so tense to start with. Now we put in tubes. We put in an EVD. Earlier we used to put in a feeding tube. Now we put in an EVD tube into the prepontine cistern, and after that you see how the brain is now. So what we do is we just ask people to touch the brain. I mean, this is one of the best ways to assess how the brain is. So it's completely lax. Okay, it's lax, and keep out the bone flap or anything. Okay, so there's no need for any decompressive hemic. So after this is as bad as you can see. I mean, it is burst slow, everything. So after this, you keep back, and then you close it. That's it. And the difference is, this patient is supposed to pretty day. Okay. So my friends are here. These are the guys who are doing it right now. Decompressive hemiclinic. Believe me, this patient will be on the vent 6 more months, or maybe. Okay, I can assure you that. And you'll be ending up trying to close it with you have to stand up on the flap to close it, believe me. So we've done enough decompressives. So one of the things that we as developers look at is that the impact of trauma is very, very, very high. And I mean, it is on us. The onus is on us to teach these people, the youngsters, how to go and open the cisterns in a very tough scenario. It's not like a basilar tip or an unruptured aneurysm. This is a real war. So it is a tense brain aneurysm which is ruptured, for a grade 5 aneurysm which is ruptured. So go ahead, open and get a life, and results is what we should be teaching. Thank you very much. Any questions? I'd be glad to take it.
Thank you, Aib. Your voice sometimes was cut, but we could get the message perfectly. I don't know if there is any question from the panel or the audience. We don't have.
May I ask something?
Yes.
If I remember, you were not putting drains before in the past for these sort of cases, and now you started putting drains. Is that right?
See, actually, for 2 not putting drains because I was having infections. So, but then after the first 2 years, I am putting back drains. For the last 6 to 7, putting drains.
Okay, the putting a drain in the preponderant cistern, is it something which is a sort of a risk? Is there a risk which you have seen, or do you think it's fairly safe?
It is very safe. We used to use problem with that. Now we drain, and the feeding tubes sterility may not be good, so that is why we're using an EVD tube right now. But we've never seen a problem with that.
Okay.
Okay. Any other question?
Well, just one quick comment, Pablo. For the question of the drain, I think the most important thing is to put the drain. Doing the cisternostomy is one thing, but putting in a drain is equally important. And we have been doing it for the last 7 years now. And we're draining at least 200 ml per day for close to 5 or 6 days. And we have not had any problems. And I think an early recovery, and this contributes particularly well to an early recovery and early discharge from the intensive care unit. So drainage is extremely important and should be put in all patients.
Thank you, Roy. Thank you. So we were dealing with vascular, skull base, and now we are moving to the brain, which is one of my favorite topics. And for that, we have the privilege to have Professor Igor Maldonado from Tours University. And he is going to talk us about inferior parietal lobule, anatomy, function, and surgery. Igor, thank you.
Thank you. Do you see my screen?
Yes, perfectly.
Thanks. So good afternoon, everybody. So first of all, I'd like to thank Zimad, Vladimir, and the whole group for this initiative. This is our first IENA webinar. I'm sure it's just the first of a long series of interesting meetings and fruitful experiences. It's an honor for me to participate to these recognitions. Professor Kato, we thank her for her passion for teaching, for her dedication, for being an example for us. I'd like to tell a short story. I think some of you will remember. I will never forget when I was visiting IPE's department at the Nobel Neurological Institute in Nepal. So IPE sharing was organized an event for medical students, so young audience. And I remember Sanjeeva was there, and the meeting was going on, and suddenly the entire audience stood up, dozens of young medical students. Initially, I didn't understand, but then we all saw that all the students were looking at the door and smiling. That was Professor Kato, who had just arrived from the airport. She still had her bags with her. It was really touching to see her dedication to those young students, even the younger ones, and to see how that dedication was recognized with great affection. That's the word. So we all saw this kind of demonstrations again and again around the world. So the results of many years of dedication. So thanks to Professor Kato for the example. So in the announcing of this meeting, it was mentioned the importance of anatomical knowledge for neurosurgical interventions. So in this short lecture, I will illustrate this powerful association. Why to study the inferior parietal lobule? The inferior parietal lobule is a unique location in the brain. It's a carrefour between the parietal and temporal lobes. It's close to numerous eloquent areas in the brain, in both the cortex and deep parenchyma. It comprises supramarginal and angular gyrus. Is limited superiorly by the intraparietal sulcus that's separated from the superior parietal lobule. So classically, the inferior parietal lobule is associated with visual spatial integration, body image, language. The lesion is usually associated with M neglect, especially in the right hemisphere, and Gerstmann syndrome, which may happen with the lesion of the left hemisphere, with a combination of dysgraphia, calculation difficulties, finger agnosia, and left-right confusion. So being surrounded by highly functional areas, this region is for excellence an associative region. It means that it integrates information from other centers, even distant ones, which makes the study of this region even more important. And imaging, the location of the inferior parietal lobule starts with the identification of basic landmarks, such as central lateral sulcus. If I see with the central, where the central and lateral sulcus are, I can start navigating in the anatomy more easily and know where everything was. So the peculiarities of the central sulcus will help us to identify it. I will only cite the main ones. First of all, of course, is the location and the orientation. In those axial slices, it will have a slight posterior location. It will be oriented obliquely, anteriorly, lateral, and inferiorly. And I can start looking for the central region, which is a combination of parallel structures, such as parallel structures, which are the precentral sulcus, postcentral sulcus, precentral sulcus, central sulcus, and postcentral sulcus, and two gyra, the precentral and postcentral sulcus. So there are 5 parallel structures. The precentral gyra is often thicker than the postcentral gyra, so I know where a motor strip is, where sensory strip is, and I have already the anterior limit of the supramarginal gyrus, the anterior limit of the inferior parietal lobule. Other tricks are the presence of those links with the frontal gyri, which is always present with the superior frontal gyrus and often present with the middle frontal gyrus also called the pli de passage, and the omega shape area of the hand, that they're saying here, which marks for us the somatotopical regions of the hand. And I would acknowledge that it's easier to find for all those characteristics and localize the superior and anterior limits of the inferior parietal lobule. Coming from up to down would be much more easier than starting from the bottom, from the lateral fissure. And then we can follow those limits, identify the intraparietal sulcus, and then you have delimited your region. You see again the intraparietal sulcus here, the inferior parietal lobule, nicely in this parasagittal slice, the supramarginal gyrus, and part of the angular. So here an example, it was a small ganglioma in a 41-year-old man. We presented the seizures. He didn't have access to functional and MRI, but we see this is a relatively high slice. We see we're above the ventricles, the semoval center is there. First thing we notice is the location of the central sulcus. Same thing we saw. So we apprehend immediately the location of the eloquent area, sensory, motor, and language would be below, and what matter structures would be in the depth. So in this specific case, the lesion is the anterolateral portion of this left dominant inferior parietal lobule. So we are in the supramarginal gyrus. This patient was operated awake. We see immediately the trolar vein just anterior to the tumor, and just behind the sensory strip, so the postcentral gyrus, exactly where it was expected to be when you look at this superficial venous anatomy, which is also very important for navigation. So this is kind of the exercise we should always do, not only for diagnostic purposes, but this is for the roadmap. This is part of individual anatomy, which is really important. This is another example, left side. So this is anterior, this is posterior. You have a richer sensory map and evident superficial sylvian vein. So I know this is superior temporal gyrus, and the trolar vein is the frontal lobe in this case, but we have a smaller one, which also can be used for navigation as well. So this area is subjected to very frequent anatomical variations. The general scheme we see in the books is this 2 horse-shaped gyri. The anterior one is supramarginal around the posterior end of the lateral sulcus, and the posterior one, and also more inferior, is the angular gyrus around the posterior end of the supratemporal sulcus. So they are separated by the sulcus intermedius primus, or sulcus of Jensen, which separates supramarginal and angular. These sulcus may be absent it's not uncommon for the supramarginal gyrus to be merged with the angular gyrus, or to find a small, narrow, squeezed gyrus between supramarginal and the postcentral gyrus, or between supramarginal and the angular gyrus, what's called the pre-SM and the pre-AG variant. I took a look at the literature for that, and roughly 40% only of this typical configuration has been found in real-world MRIs. Just a small anecdote to illustrate the power for functional anatomy. And this last year, 2021, a century passed since this young enthusiast Wider Penfield refused a lucrative position because it did not offer him the possibility of doing some brain research. He then accepted his position somewhere else in the US, and then you know the story, Canada and Montreal, etc. This is registered in some biographic documents and letters, and we know how this was just the beginning of a very beautiful story that definitively changed how we surgeons see the functional anatomy of the brain. So many concepts of pencil are still relevant today, and that's why we decided to revisit this anatomy in a paper we did some years ago, using those anatomical landmarks to put together the findings in a small series of 14 patients that were very similar to each other, operated from the IPR. And that's what we got. And this is upside down to simulate surgical position, of course. So when operating the inferior parietal lobe, so the area of infiltration will be there. And then we can use this anatomy to mentally anticipate what the boundaries of the resection may be. If you were, of course, decided to respect functional boundaries to achieve minimal permanent neurological deficit, and functional boundaries that will not obligatorily respect sulcogyral anatomy. So the superior limit will be often morphological. This map is not very rich in this region in our experience. So this limit can be determined by the limit of tumor itself, an oncological security margin, or be purely anatomical, such as the intraparietal sulcus. The inferior limit will be notably recurrence of language disturbances and not anomia in most cases, or semantic disturbances, say during a naming task and in awake surgery. And this, of course, to the presence of Wernicke's area. The anterior limit is sensory, depending on how anterior the tumor extends. And the posterior limit, we can see very variable language disturbances, and sometimes, but most of them, the map is negative here. It was negative in that series. That's for the cortex. But if you go back to the MRI and you look at what what we will be dealing with during the deep stage of the section, we will ask ourselves what the deep limits could be. And of course, if you have DTI interactography, those techniques can show you that. There is a lot of green stuff there, so it means that there are a lot of anteroposterior fibers. But the objective here is to know the anatomy and to be able to anticipate it, which is fundamental in surgery. Even more if you think about the brain shift issues, and that these imaging techniques and neuronavigation are not available everywhere in the world. So this is a postoperative MRI from that same tumor I showed you. I like this one very much because it shows very well the contour of the arcuate fasciculus around the insula. So we see the superior limited sulcus of the insula and part of the posterior inferior one. So you see how close, even a little bit inside our arcuate fasciculus we were, and we stopped because we had phonological disturbances. So these are classical dissections we do in the lab with a Klinger technique or any variant of it, showing how after some work in the lab, the pieces that you prepare are almost a photography that you see of what you see in your real cases, and vice versa. So it relates to the deep limits of resection. We did, as we did for the cortex, we put similar cases together, and you see how those disturbances were distributed. The phonological paraphasias were present in the depth, so the medial deep aspect of the cavity. When you see more superficial white matter, we did have some speech disturbances, but they were of articulatory type, like dysarthria, I'm sorry. And they were concentrated in this anterior-inferior region of the resection, and we didn't observe any semantic disorders. So let's then again use anatomy to interpret what is happening. The white matter structures are in the depth of the resection areas, and in the portion of the same oval center, as everything is hidden there, is interposed between the cortex, the approach, and the ventricle. And when the very superficial white matter is removed, then the white matter that approaches, it belongs to this associative system, which is the one of the superior longitudinal fasciculus and arcuate fasciculus. There are multiple subcomponents with different nomenclatures, classifications that are still evolving. But two elements of particular interest here. One is the arcuate fasciculus I showed you, and the other is this horizontal opercular portion, which is also called the SLF3. So those are structures associated with language networks, because they are providing connections between frontal and temporal language areas, so Broca and Wernicke, connections that can be direct or indirect, but they always pass in the depth of the inferior parietal lobe. Another case, and the corresponding anatomy, so the specimens are always in the operative position, and we stimulate in contact with the arcuate fasciculi, temporary phonological disturbance. Here we have a residue that was intentionally left, and no DTI, but we see lab dissection, anatomy, arcuate fasciculus. Then, if you are more superficial, we're not in contact with the arcuate fasciculus, we are there, but we are really in the lateral most superficial portion of the semoval center, in which horizontal fibers are found, and some lab work will demonstrate this for you very promptly. So we can discuss this inferior parietal lobe anatomy in the context of the debate of location cerebral functions. As you know, in the 19th, 20th century, we developed a lot this locality system model. We all learned the anatomy like this, talking about somatotopy, retinotopy, tonotopy. There is, however, a growing second debate reinforced in this century, is the fact that if you understand the existence of those specialized organs in the cortex, in order to function, they must be interconnected. So regardless the importance of one area, it will always be useless if it's not connected to the other. So this principle is very simple, but it changes a lot the way we look to anatomy. So this is an aspect that some of you know, it hasn't attracted me for some years now. Language is among the findings in mapping and the rate disorders that shows this evolution of functional anatomy very well. So today is not surprising, but this topic was used to be treated in a very simplistic way in the past. We all learned in medical school, for example, that Broca's and Wernicke areas were connected by arcuate fasciculus. But as you saw in this series, there was no semantic disturbance. So how is possible? So it means that the network actually is more complex than that, and there is still a lot to be done, and a lot that we don't understand. This is an example of this. These are dysgraphias. They were noticed in one patient.
Over, Igor, sorry.
Okay, 30 seconds?
Please, 1 minute.
30 seconds. And these dysgraphias were surprising in the beginning because it's not writing is not really part of the testings we do. So that's what I wanted to show. Here's some take-home message. So go beyond classical anatomy, think individual anatomy. Go beyond topography, think functional. Go beyond the cortex, think about the connection. This is the history of anatomy is very beautiful. we're leaving this. Explore all limits of the cavity. Mapping can increase our volume resection, and keep in mind, of course, the technical limits and our limits of exploring this. So thank you very much.
Thank you, Igor, for this fantastic overview of this such an important area of the human brain. I don't know if there is any question from the panel. I would like to ask you something, Igor. There are two different schools when dealing with gliomas in this region, especially when we are reaching the subcortical areas. Some surgeons prefer to attack directly the most close part of the glioma to the functional area, because the patient could be tired at the end. But different surgeons prefer to go from posterior to anterior, leaving the most functional areas at the end of the surgery. What's your strategy? What's your thinking about that?
I think it's important to know where crucial eloquent areas are since very early in your procedure. So since your patient is well awakened and the result of testing can be really trustable, with often is not really in the very beginning of awake phase. In the very beginning of awake phase, you may still have some residue of anesthesia, and some is lowering, and even dysarthria. There is not really result of your testing. So this you can keep in testing, for example, motor cortex or ventral motor cortex, and asking patients to count and everything. And when you feel your patient is really collaborative and awake, this is a crucial moment to understand your map. I think that something that for me at least is very stressful is when you have a negative map and you think I should know where things are, they should be here, but I don't know what they are. So I think that this timing window is really important. And then my strategy would be even for the deep limit to know where things are and finish with less eloquent areas. Yeah.
Thank you, Igor.
I think tell me what you think if it makes sense. I think it is.
Thank you. So if there is no other question, we will move to the next talk. We have been talking about preserving the white matter, but Professor Roy Daniel is going to show us how we can take advantage of cutting the white matter. So Roy, pleasure to have you on board.
Thank you, Pablo. Thank you, Igor, Imad and Vladimir, for giving me this opportunity. And it's a great honor to dedicate this conference to Professor Yoko Kato. The topic I was asked to talk about is the anatomy of the human brain disconnections, and just would like to acknowledge the contribution of several labs in the work that you're going to see in this presentation. So why would you want to disconnect the human brain? Now, obviously it is for epilepsy surgery. And in children, if you control the epilepsy and stop epilepsy, you allow the brain to develop. And at the same time, we should make sure we are not increasing the neurological deficits. Now, in pediatric epilepsy, it allows the rehabilitation and the integration of these children. So basically, the worst case scenario is an entire hemisphere which is bad, and you want to completely disconnect this hemisphere so that the good hemisphere can attain functions in these children and they have a near normal development. So this talk is based on the 5 techniques that we have described in the last 20 years, and I'm not going to details of that. These are all published literature. You could go and refer to it, but just to list them out, we started with the hemispherotomy, which is disconnection of an entire hemisphere. And we went on to half a hemisphere, which is the posterior quadrantotomy. And then, of course, the anterior quadrantotomy in one procedure for the prefrontal lobotomy. And then an interhemispheric disconnection, which is the total commissurotomy. So I'm not going to a lot of surgical details. This presentation is essentially for neuroanatomy. So in the hemispherotomy, you should view it as a radical hemispheric tractotomy. So what you do is you cut the entire internal capsule to reach the ventricle. Then inside the ventricle, you do a total callosotomy and you disconnect the fornix, so to remove the output of the mesial temporal lobe. And then in the frontal lobe at the base, you do a fronto-basal disconnection. So that can be done through multiple windows and not a very large craniotomy, a small one, which will allow you to disconnect one entire hemisphere. Now, if you look at the posterior quadrantic epilepsy, which is the epilepsy of the parietal lobe, the occipital and the temporal lobe behind the sensory motor strip, which is the central lobe actually. And so this entire half a hemisphere can be disconnected in this fashion to deal with epileptogenic lesions in this area. The anterior peri-insular quadrantotomy is again a similar technique for the anterior quadrant. And if you look at the anatomy in detail, it'll show you where the disconnection is. And there you see the three gyri, the opercular frontal gyri, which is the pars orbitalis, opercularis, and triangularis here. And so just anterior, the disconnection is just anterior to the central sulcus. So that is the posterior, that is the limit of the disconnection. If you look at it from the medial side, this is what you disconnect. You have the anterior part of the corpus callosum, which is disconnected, and you go across onto the basal part. Now, if you look at the basal part of the hemisphere, you disconnect it as at the posterior limit of the fronto-orbital gyri. So let's look at the disconnections in more detail. Now, these are dissections all done. You come and remove the gray matter, you see the U fibers, and then as you start removing these U fibers, you'll start seeing the SLF. As you start removing them, you come to the extreme capsule and the external capsule. As you keep going, you'll see more and more details. You'll see as you do the inferior part of the frontal lobe, you'll see the IFOF starting and the uncinate fasciculus, as you see here, and you remove these structures, you will see the parts of the internal capsule here, the frontopontine fibers, and as you keep removing them, you'll see the putamen, and then finally, as you remove these structures, you'll see the clear ependyma, and that's where you enter into the ventricle. So this is an interesting, from medial to lateral, you'll see the disconnection as it goes down. You see the components of the anterior limb of the internal capsule, the frontopontine, frontostriatal, and the thalamocortical parts of the internal capsule. And there you need to go a little bit around there so that you don't enter into the basal ganglia. And as you go inferiorly, you will, of course, interrupt the IFOF and the uncinate fasciculus. If you were to look at it medially, you will have this kind of incision. This is what I was talking about. You'll have to go around it so that you don't enter into the basal ganglia. So the part of the corpus callosum, this entire corpus callosum is disconnected, anterior part of the corpus callosum. So the almost entire, the body, the genu, and the rostrum. So a little more dissection will show you the anatomy of the anterior and the posterior limbs of the internal capsule, which are also disconnected in the process when you go inferiorly. Now, this is an interesting specimen I just wanted to show you. There's a basal view, and it shows you from below the parts of the ventricle at the base, and shows you the anatomy of the uncinate fasciculus, the internal caps, the anterior commissure. So it shows you, these are the view that you would get when you go through the frontobasal disconnection at the base of the brain. Now, if you go to the prefrontal lobotomy, it's slightly different from the anterior quadrantotomy. Here, the incision, the convexity cortical incision is made between the pars orbitalis and the triangularis. There, you can see that there. And at the basal side, you have the posterior incision here, which allows the basal disconnection of the frontal lobe. And from the mesial side, you can see that only the anterior part, very anterior part of the corpus callosum is cut. As you go deeper, there's some repetition here, so I'll skip this slide because it was shown earlier. and that shows you from the medial hemisphere exactly the same anatomy, the cingulate fasciculus here, and that's your disconnection, and that takes you to the body of the ventricle and the frontal horn of the ventricle. So what happens when you have epilepsy of both hemispheres? Obviously, you cannot do a curative epilepsy surgery. So then that opens up the possibility of a palliative procedure, which is an interhemispheric disconnection. So this is an interesting anatomical image, which shows a view from inside the ventricle looking forward. So you have the foramen Monro here on both sides, you have the fornix here, and that's your anterior commissure, that's lamina terminalis infundibulum. And then this is the diametrically opposite. You're standing in the third ventricle and you're looking posterior. You have the posterior commissure, the aqueduct of Sylvius, and the habenular commissure. So, and from the basal side, again, this is an anatomy that shows you the anatomy of that's a mammillary body. You have the optic chiasma, optic tracts, and there's the anterior and posterior limbs of the internal capsule. Now, this specimen shows you an oblique view of the third ventricle that shows you looking posteriorly. That's the posterior commissure, that's your anterior commissure and aqueduct of Sylvius. So these are the structures that you would like to see during this procedure. A quick video, I think I may have the time for that. So it is done by both flexible and rigid scope. For the entry, you will use the rigid scope, and as you go in, the flexible scope is used to angulate and show you that's foramen Monro on the contralateral side, and that's the anterior commissure that is being sectioned. Once that is done, you turn your flexible endoscope posteriorly to have a view of the posterior commissure, and then you will see the aqueduct here. That gives you an orientation to see the posterior commissure. It's not easy manipulating this, and very often we get people who are interested, who have great experience in flexible scopy to help us do it. So that's the posterior commissure, which is again sectioned in that way. Once these two structures are sectioned, you would come back into the lateral ventricle. You come back in the lateral ventricle using the rigid scope, and then you would do a chelosotomy. So that's your first opening to look at where the chelosotomy is, and then a kind of monopolar or bipolar cautery will allow you to trace the entire corpus callosum from anterior all the way posterior. So that is a quick video to show you the interhemispheric disconnection. Now, what I wanted to focus on in this talk is the central quadrant, and that's what we have been exploring in the last 2 years. And I'm glad that Igor spoke a little bit about the cortical anatomy of the inferior parietal lobule. Now, the central quadrant is a fascinating quadrant because it is at the junction of the entire brain. So it's right in the middle. And we did these dissections to help us better understand the central quadrant, because you do have epilepsies arising from this quadrant, and you also frequently operate tumors in this region. So if you were to dissect this region, you will see a lot of interesting structures. So that's part of the cortex there, and then as you go deeper, you will see the SLF 2 here, SLF 3 here, and then you start seeing more interesting structures, and that's the arcuate fasciculus, as Igor showed you before, the tract that goes around the insula and goes anteriorly, linking the frontal lobe with the temporal lobe. I'll quickly go through these. The most interesting part here is the identification of the arcuate fasciculus, and that's your anatomy that shows the SLF. Then you have the ventral tracts that come here that will be seen shortly, and this is a cut transverse which shows you the anatomy of the arcuate fasciculus. Now we looked at all these fibers, identified all of them in these disconnections. It's listed out here. I'm not going to read them out to you, but basically the idea to better understand it is to understand their shape. And so you have longitudinal fibers and you have curved fibers, and that a lot of it depends on what their connections are. So what we did is to look at it from an embryological point of view, and just to give you a revision of the embryology of the white matter tracts around the telencephalic flexure. Now, as you know, at 4 weeks, you start seeing the flexures that develop, and then the cephalic and the pontine flexures, and then as we go along, the telencephalic flexure starts developing. So you can see this outpouchings, and then as you go along, the brain gets transformed into a C-shaped structure. Now, what happens in animals? Now, this is a mouse brain, and there you see there is no flexure. So you have the entire olfactory system ventrally placed here, and then the brain is one longitudinal structure. Now, when you come to cats, you start seeing the flexure develop, and in monkeys, much more, and it becomes maximal. And so there is a phylogenetic component which really recapitulates ontogeny. So our own human development, you can look for features of how it developed in animals, and it usually recapitulates the phylogeny. So what we did is we studied it in detail, the embryology, and we got two passionate medical students from Prague to pull out all the data on the embryology in humans and the embryology in across species dedicated to the telencephalic flexure. Now, what's interesting of the development of the flexure is that if you see, this is anterior and this is posterior here. Now here you have, that's your temporal lobe. So from the dorsal part of the neural tube, you get most of the cortex evolving, and this is actually your occipital lobe, which was originally anterior to the temporal lobe. And from the ventral part of the neural tube, you have the insula developing. And then slowly, as the flexure started developing, you see that the temporal lobe is pushed anteriorly, and then you have firmly, as it really develops, you see the occipital lobe firmly anchored posteriorly, and the temporal lobe becomes just behind the eye. So for a structure which was completely posterior, has become almost completely anterior. So this is the beauty of the telencephalic flexure, and that you can see in these images from human embryos. At 9 weeks, there's hardly any flexure, and then 14 weeks, you can see that it starts. 18 weeks, much more. And this is at 32 weeks. And essentially, there is even development of the flexure. The final development is in the first year of life. So the Sylvian fissure completely fuses only towards the end of the first year, which is actually an incredible thing. So what we did is we drew out all the fasciculi, that all the tracks that we identified during our dissection, and put color codes for them. So basically looking at what were curved tracks and what were longitudinal tracks. So because that is essentially the key, and it's the same color code that is given here. So if you were to cut the brain across, you'll find interesting things. So here the blue, just to give you an orientation, the blue represents the projection fibers, the red, which is the corticospinal tract, if you wish. And then you have the red, which represents the commissural fibers, the corpus callosum, for instance. All the rest are the association fibers. And those are the fibers that are very, very much modified by the development of the flexure. So what's in green here are all the fibers that remain longitudinal to a large degree. And the yellow here that you see here are the fibers that are curved, or which have been impacted by the development of the telencephalic flexure. So, and if you look at it across species, you find that in the older CNS, of course, all of them were longitudinal because there was no flexure. And then as primates came along, you find several curved tracks. Essentially, in the current situation in humans, longitudinal tracks are mostly found in the frontal, or they're always found when they connect adjacent cortices, which is all listed out in the table which I showed you before. So when you have short tracks which are connecting adjacent cortex, they tend to be longitudinal. Now the curved ones are predominantly tracks that connect the posterior and basal lobes, which is the occipital, parietal occipital, and the temporal lobe. especially when they are connecting distant cortices. So when they're connecting distant cortices, they are modified to a large degree by the development of the telencephalic flexure. So just to name them, it is essentially two streams. So you have a ventral stream here, which is modified by the telencephalic flexure, which includes the IFOF, as you see here, the uncinate fasciculus, and the anterior commissure. And these were pushed anteriorly or a little bit ventrally by the development of the fissure and the development of the insula. And then you have the dorsal stream, which represents the MLF, the vertical part of the SLF, and the arcuate fasciculus. So they were pushed behind the behind the insula and achieved this form. So you have two streams, a ventral stream and a dorsal stream. Now, all what we have discussed so far is well described in this article, which has just come out, which shows the white matter anatomy of this region, with a huge emphasis on the embryology in humans and across species to better understand the disconnective surgery of this region. But it's not just for disconnective surgery. As Igor already said, tumors in this region, you really need to understand the white matter of the region. And for 90 years, we have been studying the cortex, and people, it's fantastic that Penfield put this out and everybody learned it, and we still continue to study it. But the white matter is equally important. And the last 15, 20 years, more and more studies are coming out by even new tracks are being described because people are persisting with studying the white matter and dissecting it out. And of course, the development of the DTI has also helped us to do it, and development of awake surgery techniques and stimulation has helped us to identify these structures. So the white matter of this region is fascinating, and this article describes it quite well. So just as a recapitulative of the techniques that we have quickly reviewed. So you have the peri-insular hemispherotomy, you have the prefrontal lobotomy, anterior peri-insular quadrantotomy, posterior peri-insular quadrantotomy, and the latest one, which is central quadrantotomy. Now, all these 5 techniques are curative epilepsy surgical techniques. And then you have a palliative, which is a total commissurotomy. I thank you very much for listening to me, and I'm very happy that Imad and Vladimir and the rest of the team has gone ahead with making this new academy, and you could look at this publication that has just come out as proof of what can be studied and better understood if we all talk to each other and work together on these lines to improve the knowledge of neuroanatomy. Thank you.
Thank you, Roy. Thank you. It was fantastic. I am too biased to comment on any of the topics you have introduced. So I ask our colleagues in the panel to make any comment on this, any question.
It's really a proof for a very good collaboration by 2 centers from this IANA. I am glad, and this is not the first collaboration to see such a publication. And it's wonderful. It's not only technical, but paved the way for the introduction of good anatomy and give an insight as bridging the gap, as we said, one of the mandate of this society to bridge the gap to a clinical application. Congratulations.
Roy, Pablo, it must have been fun that you have been together. It was during the COVID era.
Yeah, actually, Vladimir, we were doing discussions online between Alicante and here, and we were discussing very often. It was a strange experience, but it was very, very useful at the end.
Great job, students.
Great, Roy. Pablo, I read the paper for sure. You know, about this phylogeny stuff, something that may be interesting, let me see, witness of this is the thalamic radiations. You see how they are being dragged by the growing of temporal lobe and frontal and everything. Very nice.
Thank you, Igor. And Roy, you were going to comment on anything?
No. We are already quite late. Let's go on.
So Igor, it's your turn. I give you the moderation.
Okay, so it's my great pleasure to introduce our colleague and friend Salman Sharif, to always give splendid lectures. So please, Salman, go ahead.
Thank you, Igor. And thank you once again, Imad and Vlad. Congratulations that you guys came up with this wonderful idea. And then on top of it, it's an honor to be part of something that Yoko is part of. It's amazing to be here and to be part of this history in making. Yoko, as you can see, has done so much for so many people. This is a picture from 2014 in Karachi. And you can see all the people who got together just because of Yoko. And her efforts all along have been really towering. And it's our pleasure to have worked with her and really taken guidance from her all the time. Well, guys, after all those brain and vascular talks, which were some of them are mind-boggling, what amazing talks. I'm just going to go to a simple spine talk. Going to be talking about the introduction about dorsal spine, the osseous structures, ligaments, neural structures, vascular, and just touch on surgical approaches. Sorry, I don't have enough time, so I'm just going to skip through some of the essentials, but touch the most important bits. As we know that thoracic and lumbar spine, there's a gradual transformation of structures rostral to caudal, and this is because of progressively increasing load caudally. So as you can see, the vertebrae keep on increasing in size, the transverse process stick out, and the transverse process is up in cervical spine really small. You can also see that there's a complete change in the way the curvature changes our pedicles, and those are important for people who are putting screws or operating on the spine. Well, if we stand upright, the important thing is that if there is load bearing happening in the caudal direction, so there is increase in robustness of the bodies as we had seen before, and this is to stabilize the structures. So spinal curvature increases load bearing capacity. Variation in intervertebral disc and vertebral body morphology actually makes the spinal curvature. We know that C7 vertebral body line, which is in line of the L5S1 pivot point, which is McLeod's point, which is dorsally behind the L5S1 disc, is in one line. So that's one line going all the way down. And that's a normal curvature. Deviation from normal mechanically is unfavorable, and it produces additional stress on musculature, pain, and accelerates the degenerative process. So if you're going to be bending down, you're going to be causing loads of pressure on the posterior elements. If you're going to be going back, then obviously you'll cause problems with your knees, your hip, your SI joints, and obviously lumbar spine. What about vertebral body cross section? So we know that thoracic spine has a heart, and that's why the inside of it is heart-shaped. And so the cross section itself is heart shape, and then we have lumbar spine, a kidney shape, and there's a concavity along the dorsal aspects with ventral wall of the spinal canal. On the left side, we know there is a shallow depression for the aorta. On the sagittal morphology, it is wedge shaped. The important thing is to remember is that dorsal height is more than the ventral height. And the reason being that that creates the thoracic kyphosis, which is actually reversed in lumbar spine. So as long as you know that, then you know that obviously thoracic spine is going to be kyphotic, whereas lumbar spine is going to be lordotic. What about the disc and the end plate? So the functions of the disc obviously is to accommodate compressive loads. Basically, nucleus pulposus does that. It resists tensile and torsional stresses. And so that's the annulus fibrosus. The nucleus itself is semi-fluid, gel-like substance embedded in the meshwork of fibrous tissue. And then we have the annulus, which, as you can see outside, made up of Sharpie fibers. And they are on the cortical outside, penetrates the cortical bone of the outer ridge of the end plate. And outermost fibers blend with the periosteum and anterior longitudinal ligament and the posterior longitudinal ligament. And that's how we know that these fibers are very important in causing degeneration when we run into various problems. So rostral to caudal, we know that dorsal spine nucleus is centrally located. whereas in lumbar spine, the nucleus is dorsally located. What about degeneration? Because of all this traction on the Sharpie's fibers, which we saw in the previous slide, there's stress on these fibers greatest on the concave side of the spinal canal. And that's why in front of the thoracic bodies, we see all these osteophytes developing. What about the pedicle? The thoracic spine pedicle is different from the lumbar spine, and it's important to know when you're putting in pedicle screws. The upper surface of the pedicle is in line with the epiphysis of the upper end plate. When we come into the upper and mid-thoracic spine, the lower surface of the pedicle is at the mid-body. Whereas when you come onto the lower thoracic spine, then there's relative increase in the size of the pedicle as we come down. And the lower surface of the pedicle is at the lower 1/3 of the body itself. So you can see that the notch itself keeps going down as the pedicle comes down, starting from above and coming its way down. The sagittal angulation, pedicle angles caudally and inferiorly to meet the body. I'm not going to talk about the lumbar spine. I'm going to leave that. We are short of time. What about the transverse pedicle width? Well, the limits of size of the pedicle can be very small and difficult to put in pedicle screws. And in that particular case, maybe from D4 to D6, there is minimal increase till thoracolumbar junction. In that particular area, you could use the rib pedicle complex to put in your screws if your pedicle is really small. And then this unit itself allows you to come in laterally even for your approaches, as well as putting in screws for stabilization. This is an important slide, that the transverse pedicle angle, which is very important for us when we are putting in these screws, because this is the angle we use to put in screws all the way into the body, is more relevant than the sagittal angle in screw placement. And its medial to lateral breaches can be because of this if we do not take care of it. So this angle declines as we go from above down until D12. And it becomes really straight trajectory at thoracolumbar junction. And then again, this increases. And we know at S1, we are putting about 30-degree screws at that angle. This is important from the clinical point of view. The difference between the lumbar and thoracic spine, the distance to the neural structure is important. So the medial pedicle wall and thecal sac is 5 millimeter versus the dorsal spine is contagious right next to it. In the upper pedicle wall, that we know that upper pedicle and nerve root are between 5 millimeter versus 2 to 4 millimeter. So it's much less in dorsal spine. And lower pedicle wall, obviously next to the nerve root, is between 1.5 to 2.3 millimeter. And these are important landmarks that we know, so that we are careful when you're putting in this screw. So there's not enough margin for error in dorsal spine. We know this. What about the morphology? So it is thoracic spine is flat, it's monotonous, it's shingle-like. The facet complex is in trough between lamina and transverse process. There is a mammillary process, which is a bone at the junction of the superior facet and the transverse process. This is the attachment for deep paraspinal muscles, and this is actually the landmark for your pedicle screw placement. So there are different types of pedicle screws that you can put in, but this is generally a straightforward way of putting in screws. The rib articulation can be seen as well. This is also important. The first rib articulates with the first thoracic vertebra. The 2 to 9 rib articulate with same vertebra and one level below, so the rib overlaps. Whereas between T10 and 12, you can see that the articulation is single, and it is on the lateral surface of the pedicle and not on the body itself. Lamina and spinous process are interesting as well in dorsal spine. Lamina arranged in shingle shape. We talked about it. Lamina usually overlap each other. Pars interarticularis is lateralmost part of the lamina. So if you follow, then the pars interarticularis is all the way lateral, and it stabilizes effect of lower facet joint is lost without the pars. So we divide this into upper dorsal spine and the lower, and in upper dorsal spine, we have from D1 to 4. And here we can see the lamina is horizontally oriented and relatively short sagittal height. Spinous process is moderately inferiorly angulated, about 40 degrees. And you can have very small spaces, interlaminar spaces are non-existent at this level. So it's okay to use your Bowie and be more confident when you're going on to stripping the muscles. Whereas the mid-thoracic spine, it changes considerably because what happens, the V-shaped caudally angled lamina. So you can see the angle of the lamina is completely changed. The spinous process further goes down and very small or no space at all at this level. So, we are pretty okay at this level. What about D11 and 12? This is important to know that the space here is huge. So if you go in either Bowie and you're not careful, you can cause serious problems with the cords. Even with the heat, you can cause serious problems because it's coming to the level of conus. So it is important for us to understand clinically. Spinal canal width is important. So if you look at the width at cervical spine, you've got huge space developing starting from C1, huge space all the way to C7. It keeps reducing. And then dorsal spine, you can see that it's much smaller canal. And that's why even if you have a breach of any instrumentation, then you can cause serious problems. Whereas lower down, then it opens up further again. The ligaments important are ALL and PLL. And obviously we have read a lot about that in cervical and lumbar spine. So I'm just going to skip this. Ligament inflamum is important for us to understand. Just like lumbar spine, it's a thick ligament starting from C2 down to sacrum and has got increased ratio of elastin and collagen. It discontinues, it originates from the superior surface of the lamina below and then inserts on the anterior surface of the lamina above. And so when you are using your Bowie to strip the muscle, you need to be careful. And whenever we are opening up the ligament, then we know that that you can glide your hook underneath, and there's been into the midline cleavage point, which is usually the entry point for surgeon to avoid dural violation because there's fat underneath as well, and that is open there for you, so you don't have to cut anything. Interspinous, supraspinous ligaments are important from the aspect of MIS surgery, because if you save them, and then chances of adjacent segment disease goes down dramatically. The neural anatomy from our aspect is very important, that vertebral segments are discordant with the cord segment. For example, if you have a fracture of mid or upper dorsal spine, the spinal injury would be at the same level or one level below. So the sensory level or motor level will be the same. Whereas if you come down to the lower dorsal spine, the cord injury usually is 2 levels lower than the vertebral injury. So if anytime you're seeing a patient clinically and you see that, so if it's a lower dorsal spine, it's your level goes down by 2 levels of the vertebral injury. The spinal cord, we all know about these tracts. I'm just going to quickly skip that. There is nothing new that we are going to discuss here. This is, again, important, that the neural foramen and the intraforaminal root. So when the root comes out, there is downward angulation of intradural root. So this is the intradural part. Once it goes through, and then it angles up after the sleeve. And once it is out on the neural foramen, it is left, and it again goes back down. So the root plays a very interesting kind of a dance coming out of here. The other important thing is here that C8 and above pedicle, you've got a mismatch. The reason being that you've got an extra C8 nerve, and that's why T1 and below, the whatever root is coming out underneath is the same level of the pedicle nerve that comes out. Whereas above, it's a different story, and just because of extra C8, that has changed. The relationship between the existing nerve, root, and bony injury, bony structures is important. We have just seen this. So at thoracolumbar spine, the nerve root exits below the numbered pedicle. We talked about it. Exiting root is above at the intervertebral disc. So you can see that root is actually in the plane of disc only after exiting the foramen. So the disc is lower down. So once it's exited the foramen, then only the disc is at that level. The vascular anatomy, the upper thoracic spine, you're talking about C6 to D2, is costocervical branches of the subclavian, and then is anastomosis with superior vasculature, and there's vertebral and deep cervical also contributing. There's a watershed area between D4 to D8. Having said that, it's not always there, so you need to be careful. There's one major radiculomedullary artery. There's low caliber anterior spinal artery. There's dearth of anastomosis, so it is susceptible to ischemia in quite a large number of patients.
You reached 15 minutes. I'm sorry to interrupt you.
Okay, so I'd come to my conclusions very soon. So artery of Adamkiewicz, we already know about this, and it is important, usually from 9 to 2nd lumbar vertebra, mostly on the left side, and it determines, actually, it pierces the dura on the dorsal root ganglia with the foramen. I'm going to skip these surgical approaches just to say that, you know, the posterior approach, the midline laminectomy, posterior lateral gutter, transpedicular construct transectomy, transfacet pedicle sparing, anterolateral transthoracic, and lateral extracavitary. And just come directly to my conclusions. So, sorry, I did not show you those approaches, but you know, the dorsal approaches for pathology are available. You can go anterior or posterior. Nowadays, we are doing more and more posterior because of our momentum, that we have much better anterior cages that we can put in from behind. Our approaches are better, our anesthetists are very good. So in majority of the cases, we do not need to come from front. Having said that, if there is anterior pathology, obviously you may need to go in some cases. So, but now that has become a rare, not a routine, to do an anterior thoracotomy in majority of these patients. So it was really my pleasure to be part of this, and thank you very much.
Thanks, Salman. It was so great and so clear and useful. I don't see any questions from the audience. Maybe one of the short questions.
Igor,
yeah.
I don't have a question. I just need to leave. So I would like to thank everyone and say goodbye. And I shall miss Ramesh Dragoon. I wanted to see that, definitely. So sometimes in private, probably Ramesh. Yeah. Future. And I shall not be aware of what Keke is going to talk about. So Keke, see you later. So thanks everyone and goodbye. Imad, sorry, but I really must leave. No. Bye-bye, everyone.
Bye-bye, Vlad.
Thanks, Vladimir. Bye. Bye. So let me just ask you a short question, very short one. I was thinking about the reduction of the angle of the pedicle you described in the thoracolumbar transition, which is something very important, not only for screwing, but also for percutaneous procedures with this. So sometimes it's more difficult to do with this because patient is awake. For thinking, for example, about vertebroplasty in old patients. So you want to get a good position in the body, but the pedicle is bringing you to outside the body. So what are your advice?
I think the main problem with pedicle screws either breaking the pedicle or are taking you out is when we haven't had proper anatomy aligned. So as long as when you're starting out and you know where exactly your entry point is, that is better. The young people who make mistakes generally make mistakes because the patient is slightly tilted and they haven't seen the spinous process in the middle. They haven't seen where the pedicle is. And that generally causes a problem in majority of the time. Generally speaking, pedicle screws, if you're starting out little out and then coming in medially, is not big of a problem as long as you're starting, your entry point is right. Sometimes what happens is that you've got slippage when you're doing MI surgery and you've got a slant and it slips down because of osteophyte or whatever. Then you can run into trouble. In that particular case, you need to be careful. Once you have gone in, you see where exactly it's going. You can always change the type of screw you put in. So you can put in a transfacet screw, you can put in a pedicle screw, you can change and maybe put in a cortical screw. So there are various armamentum that we have that we can change accordingly if we run into trouble. But generally speaking, the problem is nearly always that we haven't got the alignment right when you're looking at fluoroscope or image guidance or whatever, or our images are not properly aligned with the patient itself, or patient has moved as well if you're doing image guided surgery. So I think that is really the problem. Yes, Himad.
Yeah, I'm not the best spine surgeon, but I always have these questions. That line, or where the weight line from the C7 down to the L5S1 or the sacrum, and elderly, we know they have become unsteady, and this is an important, I think, component of the evaluation if you are planning to do any extended fixation for them. And in many of the occasions, you will find that this is posteriorly located or anteriorly located. How much you depend on this one, and what is the critical value of it?
Okay, the most important thing that we have learned in last 5 years is that all this is garbage for senior citizens. Nearly always, if we try to overcorrect, we can cause serious problems in senior people. In senior people, generally, it's our consensus everywhere that you try to do. For example, if somebody's got a disc prolapse and at the same time have got some kind of degenerative deformity, we just take care of the disc prolapse, which is there in people who are elderly.
No sound?
Your sound is good.
Yeah, all of a sudden, so maybe.
Better now. No.
I think I can do without it now.
I need the best example. I just want to go from clinical practice. Somebody who has a fusion in the lumbar area, and he start getting progressive kyphosis with age. And now somebody will come, I know our orthopedic colleague, immediately they will do the extensive fixation. And they will base these lines again that you said all garbage. They make it a justification for doing extensive fixation.
I think we have learned that, when we were correcting, we realized that, for adult, it's a completely different figures compared to young people. And then we realized that, when we're operating on these old people, we're giving 30% of them some kind of morbidity, and 20% are having reoperations. And then thus we realized that, the important thing is to make sure whatever the problem is, you sort that out MIS. You don't give them any chance of having further deformity or problems, and you build their muscles, and then you can have the best possible results. But trying to do too much with these people, because obviously with age everybody kyphos. With age we are going to go degenerate and get fixed. So we cannot correct whatever somebody's nature is fixing. If you're trying to undo that, half of them will come back with some kind of a problem, either a breakage of a screw or your rod or something, but you don't want to be doing that to those old people at all.
We agree. Thank you.
You're welcome.
Ego is frozen. So we are
frozen first time.
Then I will invite meantime when Ego is there. I think who is the next moderator?
It's me, I think.
Yeah, you can. You don't need an introduction. Ramesh is accepted to be the international liaison for our IANA, and he has done already a great job because we have on the attendance now more than 1.5 thousand, I think, registered, which is a great number. I was just received a message from Pablo. So go ahead, Ramesh, and please go with the presentation.
Thank you, Imad. Great to see everyone here. And also, it's as like everyone else, I'm also very sort of honored to be part of here and looking forward to this new venture of us with this Neurosurgical Society, Anatomy Society. I'll start sharing, and also I'm very pleased to know that we are honoring my teacher, Professor Yoko Kato, who I know for 20 years because I did the fellowship with the Professor Kato a long time ago now. She said she doesn't feel old, but seeing me, she felt old because I was her student. But if you look at the pictures from 20 years ago, I don't think like she has grown old. Anyway, this talk is not a heavy talk. It is something which I thought will, because we are into training and honoring Prof. Cato, it is a good time for me to reflect my own viewpoints on training and how best to inspire the younger generation. And it's great to hear that more than thousands of trainees listening to these talks. And also I'm very surprised to see Professor Takashi Kon, who was still listening to the lecture, because it must be about 2 or 3 o'clock in Japan. So it is incredible. I think that's exactly what you need as a neurosurgeon to have persistence all the time. And so I looked at my background when I got inspired by Prof. Sambashiva, many of you know, who was an honorary WFNS president, and my teacher here as well, Prof. Marthandapula. He's still very active in his private hospital. So that is what differentiates somebody who is a master, who is still very active. There's no, I wish, Prof. Suresh Nair also, and they're all very active all these years. And I wish I had at least half or at least 1/3 of their energy to go on like this. And Fujita, where I did the fellowship for a year there, and looking at the previous pictures, and I see some of my colleagues there and my friends who were with me at that time. Prof. Kano, we were in that lounge outside the intensive care unit. My good friend Emisu, who is still, I have a great contact with them. So why do we have to excel in this neurosurgery? Why? I mean, that is true for every specialty, but neurosurgery in particularly, why do you have to excel? Why do you have to offer the best treatment for a patient? Primarily because I think this is a patient trusts you, and they trust you with their brain. And I remember a story when I was doing a fellowship, Professor Sano narrated about Professor Yarsegal. One day, a father brought his son, who was operated by Professor Yarsegal for some condition, and the father wanted him to pay respect to Professor Yarsegal, but the child wasn't that much keen. He was a bit defiant and stood there and wasn't really saying anything. And then the father scolded him. But the then the boy said, it is him who must be paying respect to me, because he opened my head and looked into my brain. So I let him do that. So Professor Yarsegal apparently said that is exactly true, and he paid respect to the boy. But I don't know whether it's the story or this is actually happened. But it is absolutely true, because somebody who trusts you with their brain, that is the highest form of respect. That's even greater than love. And when you look at the neurosurgery, you got to be the best. Nothing less is, you can't be a mediocre surgeon. That is a disservice. And I remember Enrico Fermi, I believe, is who said there are 2 types of physicists there. One group are geniuses, and the others are who shouldn't be there. But our intention, even if you're not a genius, our intention to be the best, because that comes from what you cultivate through your training life. You have to make a habit of having successful habits, and that makes you that makes your destiny. That makes your character, and character is your destiny. And this is what Aristotle said. You are repeatedly what you repeatedly do. Excellence is not an event, but it's a habit. And we all know that it's not an easy life. When you enter into neurosurgery, it's a hard life. It's not for everyone. Long hours of operation, and you don't know what is the outcome from it. You don't know how you may have to compromise on many things, family life and social life, everything. But I know that in many countries these days, people, especially youngsters, would like to go into a different specialty or less intensive specialty, which is fine. It's all a person's viewpoint. But also, I'm so heartwarming. It is so heartwarming to see youngsters who are so ambitious, so intelligent, so bright, would want to take up neurosurgery. And that we see in all the countries. And it's so heartening to see after 5 or 6 hours of this webinar, there's still a lot of people listening to these talks. But things have changed from the previous decades when we started neurosurgical training. Early it was pneumoencephalogram and all sort of investigation, which we now think is primitive. But things have changed so much. The advance in the last few decades are so drastic, because we have now got all the advanced technology and all the new technologies coming directly into neurosurgery. So you just cannot sit down and then carry on. You just have to run with it. As someone said, you have to keep on pedaling the cycle just to stay in balance. Otherwise, you will fall. You just have to run. And we talked about, I think for Giovanni and others spoke about augmented reality and artificial reality, and these are coming, and these are the things in future to stimulate and to educate the younger generation, and also to practice. The chance of cadaver lab, everything is coming down. But the one thing that will remain constant, which is the anatomy. Anatomy will always remain constant unless we're not going to evolve in another millions of years. So anatomy is going to be the same for everyone. So that is your basic. That is the terrain which you're going to work on. That's the terrain which you're going to play on. So that is going to remain. So this is the basis. Everything else will be added on top of it. So having a good base in anatomy will stand you in good stead. But it is important to understand that things have changed all these years. You know, the working time, there is a limitation to it, how much you can work. It's not like the old times where you being on call for days and days. There is a limit to it. It's coming into most countries, especially Europe. You cannot have that much of hands-on experience as the previous masters used to get. And there is more reliance on gadgets. Because there is, I understand that the more less knowledge you have to rely on the gadgets. Sometimes if they don't work, it will not be a good scenario. And obviously the last few years been difficult with the pandemic and less number of operations going on and less number of training going on. And also the patient's expectations have changed. They don't want a mediocre outcome. They want the best outcome in the world. And you cannot rely on the fact that you cannot just make an excuse saying that we don't have much experience. You just have to deliver the same outcome as the best, wherever in the best in the world. And especially in many countries, especially in the UK, it is going towards consultant-led service. Nobody would want any more trainee-delivered service. It's going to be a consultant-delivered service. So that will also put added pressure onto the trainees. They will have reduced opportunities and they will have self-doubt and lack of knowledge. Everything will compound. So essentially, this will lead to having a difficult time. But what will be the best approach to this? Just have to persist and have an ambition, so that aim for the stars, and then eventually things will work out. And it is a rule in life. And as Spetler said, train hard. That's the only word I can say in this thing. You don't have to have skill hands, and you don't have everything. The only thing you need is to have persistence and ambition, and everything will work out. And I remember reading Abdul Gawande's book on complication. He said, learning is stolen. This is something which we don't discuss that often, because when a trainee consult a patient about an operation, if the patient asks, who's going to operate on me, doctor? Sometimes he might say, I'm going to operate with you, my boss, or my teacher or professor. But exactly, he might be operating on the patient, but it is not explicitly said in that context. And nobody won't want nobody, I think, willingly, unlikely to say that, okay, I would want my case to be done as a trainee case. Nobody's going to say that, but it's often, this training is done behind the anesthesia and behind the curtains, and it is a stealth technique. You gain this knowledge from your teacher, and by the glances you put across the patient on table. This is how it is done. So, but the intention is to develop absolute confidence. When you take a patient to theater, you got to feel like that there's nobody else who can do this better. You'll be having scrutinizing eyes of your theater nurse. You'll be having very critical eyes of your anesthetist looking at you, being a resident or someone. But you got to have absolute confidence. And this is a way, the only way you can get the confidence to have knowledge. And also you got to know your limitations. Because once you know this, you know that there's nothing else you can have to worry about. And experience is something which you acquire over the years. So you're not going to get it from the first year or second year, but you have to understand, you have to make every opportunity to get that experience. I remember when I was a urology trainee, as a surgical trainee about 25 years ago, I was doing a ward round with my urology professor, and in the corridor we were going around, and one of the staff member came and asked him to have a look at one of the scans. So I was just standing aside and I was not really looking into it. So they were discussing it. And after the discussion, he came and asked me, why didn't you listen to it? This is an opportunity for you to look into things. So make every opportunity, corridor knowledge and getting involved with cases and complications. This is an opportunity to gain that experience, and that you should not miss it. Someone jokingly said, to avoid mistake, you have to get experience, but then you get experience by making mistake. Even though it's a joke, but it is important. And we fear about complications as juniors and trainees, and when you have less experience, you fear about complications. And you have to know the way to avoid complication is that you have to know that there is a danger. You know that it is looking at you, and you've got to be vigilant. It's like a tiger. When you go for a trekking to see a tiger, you may not see it, but it always sees you. That's what they say. It always sees you. You've got to be vigilant. You've got to understand that it's like driving. When you drive, you know that it's in a straight road without any vehicle. It may not have a collision, but then there will always be a possibility of something going wrong. That you've got to be aware of that small potential. Not necessarily that it happens during a complex operation. It can happen during a simpler operation as well. So it's always having that vigilance and thinking about the complication will help to avoid that complication. And it's often a fear that really paralyzes you. Fear is good. I think a little bit of fear is not unusual, and it's actually good for you. That means you're cautious and you're trying to be safe. But when you walk in that dark alleyway, we don't know what is across that bend, which is dark. What can help you? A partner or somebody who's senior to you, or somebody like a teacher. When you go through an operation, someone like a senior or a teacher can help you. Equally, when you put light, you see everything. That lies in the knowledge in anatomy. So this is what you have to cultivate. So this is if you know things, if you know what is the normal structure there, then you can definitely avoid it. But in pathology, the anatomy is distorted. I remember Prof. Ali Kister mentioning about cavernous sinus surgery. You got to know the anatomy like palm of your hand. You got to know the anatomy like furniture in your room. Somebody comes and messes it up, you will immediately recognize it. This is how you should be thorough with the anatomy. And it also behoves on us a great responsibility as a teacher. And we got to be, we take seniors and we take everyone who is a master as a role model. So that also brings down a more important role of having an ideal person. And as Gandhiji said, public life must be an echo of private life. It is difficult. There cannot be a divorce between two, but it is difficult to practice. But this is what we have to aspire or to strive as a trainer and teacher. And there is always a dilemma in a trainer's mind when taking somebody through operation, even a minor operation or major operation, a spinal operation. A small mistake in these sort of operations can be a life-changing thing for a patient. And when a trainer, when a teacher feel that the surgery is not actually optimal or it's not the best quality of surgery, there will always be an anguish in surgeon's mind, the trainer's mind, to take over. And often will be done, because if you feel that the patient's quality of care is affected by letting the trainee carry on, it's always a hard decision to whether to take over or not, because by taking over, sometimes you feel that you are robbing that person of their confidence. But I think from a trainee's perspective, it should not be like that. It should be, they should feel that they have an opportunity to step into the teacher's shoes. And like as parents tell their the trainee will not feel what you feel, and they only get that when you become a teacher. They have to, even they're assisting, I think it should be important to that they have to step in the teacher's shoe and then think about what the next step and anticipate everything. Then they get involved, and that they get the gain experience. And by just listening or when observing cases, it's an experience as well. So nothing goes to waste. And on this, on your observation and assisting everything, you build up a big base. And your actual procedure and performance should be like a tip of an iceberg. And remember, Picasso once was approached by a lady in a restaurant who then went to Picasso and asked him to draw a small picture on a napkin. She said, "I'll pay anything for you. I'll pay us handsomely." Then he was a bit reluctant. He drew a picture, and he said that would be $10,000. And she was astonished, and she said, "Why? It's only 30 seconds you took it to draw this picture." He said, "No, it took me 40 years to do this." So this is how, what you see when you see a master doing the operation, making it simple and making it elegant. You have to understand there's a lifetime work behind it. I remember all this teacher. You can see Prof. Cato, as I mentioned, I'm here 20 years ago, I think 20 years ago, with Prof. Kano and Cato, where we're honoring Prof. Shaisang from China. And this is, since then, she's been a great support and guide to me all these years, helping me. and I have other teachers with me. And I think it's important that every day you take an opportunity to learn. It's a continuous improvement. That's the Kaizen principle. Learn from the masters. These days is easy. You watch webinar. You don't have to even go to other places to learn from it. You can interact with them online. You can interact with through the webinars. You have to understand everything adds up. Nothing goes to waste. It doesn't matter whether you are a non-trainee, because in some countries there is a division between trainees and non-trainees, but there's only a label. Everything will add up at the end. It doesn't matter which grade you are. Everything will be adding up. Ultimately, I think a common sense and with an excellent knowledge in anatomy is what you need. And finally, the picture, you can see how joyful she is and still look the same. She's holding my son, who is now a young doctor, is taller than me now. So things have changed. I'm standing behind Proscano, and my wife is there. She threw a dinner party when they came to visit me in Japan. And thank you very much. I'm going to stop sharing, and hope I finished in time.
Thank you very much.
Thank you very much. I'm sorry.
No, go ahead.
No, it was very inspiring. Thank you very much.
Thank you. That's all I want to hear. It should be inspiring, because there'll be a lot of trainees watching this.
Very sad that I lost part of your presentation, but my connection was unstable. But the part I saw,
I can concur. I attended all this presentation. It was a wonderful presentation up to the point, and there's a lot of recommendation and inspiration for young trainees and practicing neurosurgery. Thanks, Ramesh.
Thank you.
Thank you.
And Professor Takashi, thank you for staying. It must be 3 o'clock there.
Yeah, thank you very much. Dr. Imizu, I know Dr. Imizu very well, and we are good friends.
And my regards. Please still keep in touch.
Yeah.
Okay. Any other comments? Okay.
Excellent presentation. It should be available really for all young students. How can we get in touch? How can we have this presentation so that we can show?
Sorry to interrupt, Kasadi. We have this recorded, so it's available at the IANA International Academy of Neurosurgical Anatomy. So all these presentations are recorded, and we will continue to have our own video library available for free for anybody.
Fantastic. Thank you.
Thank you very much, Ramesh.
Thank you.
So let's move to the next presentation. So
may I also say that Iger, after Keiki, Amir is, I think, back online. So he.
Sorry, no, I have sent him a message because of the time. It's too late now. I think we will invite Amir. I'm apologize for him again and in front of everybody. I sent him the message. Unfortunately, I didn't have your email myself handy, but I sent it to Moody. Yeah. So we apologize because of the time. And you will be on our listing for the future, okay?
Bye, Danke. Thank you.
So will be the finale of today for Keki.
Keki, you're muted.
Keki, you have to unmute. We can't hear you, Keki. I think you're still.
You see your screen where you're.
Can you hear me? Can you see my slides?
Now we hear you, but not the screen.
Put the screen back. Yeah, you were on the screen, but not talking.
Can you see the slides? You can see the slides now?
Okay, yes.
Yes.
No, not anymore.
Now you okay?
No, when you clicked, the slides disappeared.
Disappeared.
Put it on and put it on the presentation mode.
Oh, this is Keynote, right?
Oh, I see.
You can try to unshare your screen. You launch the presentation and then you share your screen. Okay, we see it. We see it. Namaste.
Thank you. Namaste. So we are at the last lap after some 6 hours. It's like a petroclavian meningioma surgery. So thank you, Imad and Vladimir, for this excellent, first of all, for this establishing this great academy, and also for giving me this opportunity. to be there to honor Professor Yoko Kato for her really very great life achievements. And I have such wonderful memories of Yoko. You know that she comes from Fujita, where the department was founded by Dr. Kano in 1972. And so Sano and Dr. Kato have really blossomed under the vast canopy of Professor Kano. And Yoko, of course, still continues to remain the torchbearer of this philosophy of this and an undisputed current president of ACNS. So here she is with Sano, her second mentor after Kano. And you know that she visited almost all over the world. And here she is at the Bangladesh Society meeting with Kano and with Dr. Maurice Shooks. And there's hardly any part of the world which Yoko has not visited. And I've been a part of her accompaniment and many of the WFNS and training and education committee meetings. And you can see how Yoko is traveling. All those suitcases belong to her, but not carrying clothes. They're carrying reading material, teaching material, which is meant for distribution, especially to the low income countries and developing countries. So she's been a wonderful ambassador of education and training. And here, this is Moody's meeting in Nayari just a while ago in 2019. Again, I was a part of that. And this was in Malaga with Dr. Miguel Araiz, in Kazakhstan, in Astana, with Ashrunikov. We are in the operating room now. And of course, we can't just be studying. We also have a lot of jokes and humor. Salman is, of course, always up to his tricks. And Yoko always, in most photographs, she's right next to me. We have a very, very deep bond and a great friendship, as you can see over here one more time. So Yoko Kato, I would say, is an epitome of charity and education. She has her own foundation, which is through WFNS Foundation, distributing equipment and instruments to all parts of the world, to all the needy people. And as you know, she has been at the forefront of education all around the world. And I just give my great salam, my great respect to her for her non-stop, relentless efforts at developing these education around the world. I come to my talk now, situational awareness. That means being aware and its importance in safety and quality assurance in neurosurgery. Very, very important for young neurosurgeons. Unfortunately, many of them seem to have left, but I hope they will access this lecture a little later. So what is this situational awareness, or SA? It's defined as a person's three components: perception, comprehension, and projection. So perception of the elements in the environment within a volume of space and time, comprehension of their meaning, and projection of their status in the near future. Again, to repeat in simple words, it is to have an understanding of what's going on, perception. Comprehension means what is likely to happen next, and projection, what steps can be taken having understood the situation. So these are the same fundamentals: perception, comprehension, projection, and then the making a decision, and then performing the action appropriate to the awareness or appropriate to the situation or the state of the environment system. So it's a critical concept in any field that involves complex dynamic systems where safety is a priority, such as in aviation. Similar to pilots, surgeons also make very complicated clinical decisions with available information while facing demands and distractions from the environment. Distractions is a word. So neurosurgery is no particularly different from aviation in terms of safety and in terms of situational awareness. Unfortunately, in surgery, great deal of emphasis has been always placed on executing technical skills, as you see in vast number of conference papers, and even today, a lot of emphasis on technical skills. Don't forget soft skills, such as situational awareness, which remain neglected, and no methodical training nor structured evaluation of situational awareness exists up to date. The consequence of turning a blind eye to SA could be catastrophic, and that would fail our patients who warrant highest levels of safety standards, similar to fields such as in nuclear power station or aviation, where SA training is a norm. So I'm once again saying that this should be a norm in surgery. The ACE factor was, now situational awareness was known as early as World War I days, where it was being seen and used by Douglas Aircraft Company during research to reduce mental workload and fatigue. This concept became very widespread in the 1990s by USAF crew returning from during Korean War and the Vietnam Wars. Having been engaged in innumerable intense dogfights, good SA was identified as a decisive factor in air combat engagements and what they call as the SA, as the ACE factor. Since then, SA has been recognized as an extremely important concept with far-reaching applications where the stakes are high, where time is limited, and where error of negligence is not permitted, is negligible, such as in air traffic control, nuclear power plants, and of course, neurosurgery or any kind of surgery. For a pilot, SA means having a mental picture of the existing interrelationships of location, flight conditions, configuration, and energy state of the aircraft. Now, maintaining all those in adverse scenarios, such as loss of control, wake vortex turbulence, strong headwinds. So therefore, for a pilot, it's very, very important to have those mental picture of location, flight condition, configuration. Similarly, for a surgeon, it means maintaining a clear and complete mental picture of patient's preoperative and intraoperative data, physiological and pathological parameters, existing state of men, existing state of materials. Existing of men means self, patient, rest of medical, non-medical staff in the OR. Material means technology in the OR, and ability to maintain this equilibrium in an adverse event, such as catastrophic blood loss or severe brain swelling and so on. I'll present to you two case scenarios, two clinical examples in neurosurgery which will illustrate the concept of situational awareness, what we call as catastrophe. Scenario 1, 74-year-old patient brought to emergency comatose condition with a large chronic subdural hematoma, something that we see every day or very often. History, examination, relevant medical details are noted by casualty medical officer, passed on to the resident on duty. Promptly, the patient is taken up for an emergency surgery. He's got a chronic subdural. But when burrow is being made, the power drill malfunctions. Anesthetist notices momentary bradycardia and immediately informs the chief resident. At that instance, the junior surgeon realizes that the patient has been on aspirin for a while. Now imagine number of information that he is receiving. Having found himself in catch-22 situation, sensing the so-called urgency, he decides, in view of the power drill not functioning, he decides to use a handheld Hudson brace. Now, mind you, he has never used this before. He has been pampered with all the modern trajectory. So the standalone mechanism drill, which he was used to, is unsterile. Now what does he do? He tries the Hudson brace, which he has never used. And lo and behold, the drill plunges, injuring the brain. So that's the Hudson's burrow, which he is using. And he plunges into the brain. He doesn't know when to stop. And there's a huge hematoma. The post-scan shows a large intracerebral hemorrhage leading to a poor outcome. Okay, so that was scenario 1. Keep that in mind. We'll come back to it. Scenario 2 is a very senior surgeon, accomplished technical skills, operating on a large plenum sphenoidal meningioma. You are seeing that in the picture. It is late in the afternoon. It is his third case of the day. In order to have a very quick lunch, he asks his resident and OR technician to put skull clamps and position the patient. He has a quick confirmation with the position visually and proceeds with surgery after lunch. As he is nearing the anterior communicating artery complex and the plane of the tumor, the patient violently coughs, thereby causing slippage of the head. There is damage to ACOM complex, and as you know, what can happen? A very unfavorable outcome. Now, just prior to this, the anesthetist has been texting and coordinating a CME meet, which is due that late evening. Imagine the number of situations that are arising here. Two scenarios, two surgeons of varying experience, both of them having one common outcome: catastrophe. Let's go back. The question is, Are these just unfortunate incidents or a work of destiny? Could this have been predicted and prevented? The errors happen despite the level of experience, knowledge, and skill of the surgeon. However, if you notice carefully, the common thing that was missing was situational awareness. Having gone through both the clinical scenarios, let's have a basic understanding of the SA model. Then we would analyze both the scenarios through the eye of this model and try to reason out where did the things go wrong. We have this analysis model called the Ainsley situation model, which mentions the same three models, the same C levels: perception, comprehension, projection. What is perception? Facts, history, physical investigations, etc., which is in your left-hand column. What is comprehension of the situation? Interpretation, stories, retains what's going on. And then come to level 3. What is most likely to happen and what exactly should I do? So Ainsley has given this situational model which proposes these 3 levels of situational awareness. So level 1 is perception. Perception involves perception of information and cues from the environment. No interpretation of data occurs at this stage. Just translating to medicine what SA means. What are the current facts relevant to the case? In medicine, it is primarily the process of getting information via the history, via the physical examination which the resident is conducting, via the diagnostic tests prior to any intervention. Level 2 is comprehension. Comprehension of the situation and the way an individual combines, interprets, stores, and retains this information. It leads to development of accurate picture of, hey, what's going on? And the ability to make judgments about the patient after comprehending. And then comes level 3, ability to forecast future events. Now, what is most likely to happen under this situation? McGuinness and Foy have proposed a 4th level to this model, which says exactly what shall I do now, having had these 3 levels in my mind. What exactly? What am I going to go ahead with? So let's go back and analyze scenario 1 in this framework. Not being aware of the fact that the elderly patient was already on aspirin, not being aware of how to handle the Hudson brace, led to basic error level 1 of perception, not having the facts correctly. Additionally, the distraction provided by the possible false alarm raised by junior anesthetist compounded this issue that led to failure in comprehension of the entire situation, which is level 2 error. And subsequently, having chosen wrong instrument, which is level 3 level projection, wrong decision. Additionally, in the so-called and perceived urgent scenario, looking at the broader picture, the resident could have used unsterilized drill. The primary objective of safely releasing the hematoma could have been achieved. I'm talking about the subdural, not the intracerebral. Infections, if occurred, could have been dealt with later on. So information overload which this poor resident had can lead to paralysis of mind, as you saw in this case. In hindsight, a good history taking, revealing his inexperience in handling Hudson's race, noticing but not reacting abruptly when alarmed, calling for help, simulated drill training on cadavers and models, he could have either deferred or minimized the impact of damage. Analysis of situation 2 in this model. In this case, an experienced surgeon landed up with terrible complication, not due to lack, rather due to system and methodology flaw. The resident, without being aware of the importance of skin bunching around the pin site, remained blind, leading to level 1 error, as explained before. The chief surgeon, also probably distracted by the need to finish the case soon, failed to comprehend impending problem, hence losing level 2 awareness. The anesthetist, in addition to being blind to the fact that pins were not put properly, was distracted too by her own problems. Failed to notice early warning signs. This is level 3 situation loss of level 3. The OR technician, though unaware of the anomaly, did not pass this information to the surgeon due to strict hierarchical structure. He knew that something was wrong. He was afraid of getting rebuked by the senior surgeon. He had the facts. He knew this could be a problem, but he failed to realize the most likely scenario that could happen possibly in a worse way. Now, this is also error of level 3. Additionally, he had a choice to disclose or not to disclose. He made the wrong choice. So that's in the inset, the OR technician demonstrating level 4 error. That is not knowing which best option to take. All these are cognitive factors of individuals. However, environmental methodological factors such as keeping a complex case in the end of an unusually busy day, a mentally distracted surgeon due to overload of cases, a preoccupied anesthetist, and the technician who, despite noticing an anomaly, chose to remain quiet, probably also played that role. So you see, the bad outcome was directly related to situational blindness, more so with the team rather than one person, the surgeon alone. SA incorporates the cognitive approach and the systems approach that an excellent opportunity to address surgical errors and improve patient safety. In other words, SA could be lost due to any adverse event that could disturb equilibrium between 3 M's, the men, the materials, and the method. Here, method signifies both static and dynamic information subsets shared between the men and material. So, we have formed a complex interaction of OR, men, material, methods. So we have formed this model where statistic data is patient, and the surgeon is obtaining the dynamic data from material and from other staff. So surgeon is the center of information input from patient, from other staff, and the hardware being used. This data can be static, example, patient's pre-morbidity, limitations of equipment, or it can be dynamic, like the blood pressure, communication with scrub nurse, assistant, etc. Now, this is a data overload, and this causes inattention blindness. As seen in this case, it was a catastrophic failure of the team, and it shows the importance of being aware by just not a single person, but all concerned individuals in a complex dynamic environment, such as a neuro-operation theater. Now, how do you improve this essay? So I'll go very quickly to the next 7 steps of how to improve. Taking examples from aviation sector, it is possible that this soft skill can be trained and taught just as pure technical skill. Even in medicine, it's been shown that in fields such as emergency medicine, anesthesiology, intensive care unit, that proper addressal to essay and its utilization indeed raise the safety standards. Taking inspirational model from this, there are a few ways by which essay can be improved. So we have method 1, impart essay training to all. Surgery is a complex teamwork, and hence it is vital that each member in OR is aware at all levels what role to play in routine, crisis, and never been there situation. Everybody should know what to do in both routine and in crisis events. Surgical crisis code and drills are the way to move forward in this regard. So we propose an algorithmic loop that can be utilized during an occurrence of any adverse event during surgery, which would help declutter the information. Declutter information is the word, and reveal a broader picture so that appropriate action can be taken in short time to negate complications. To re-emphasize, preparation starts preoperatively. So this is the adverse event model that we have formed along with my colleagues Sarkar and me. And be prepared, communicate, evaluate, act, react, but don't react. Anticipate the problem. In other words, be prepared. Methods to improve essay. Simulation-based training. Simulation-based training can be provided to the residents to hone the surgical skills before even trying on patients. Even accomplished surgeons can use this technology. It raises essay by replicating real-time scenario and possibly worst-case scenarios to predict the disaster preparedness. Third, avoid distractions. Significant distraction can occur due to vast array of alarms and data sets. Simulation training should include how to avoid distractions such as alarms, comments, telephone conversations, mobile phones ringing, repeated door opening and closing in the operation theater. Item 4, or let us say method 4 to improve, teamwork and communication. Measures should be taken to build team spirit where every individual develops a sense of belonging and he or she subconsciously becomes aware of the process. Things like time in, time out, universal surgical safety checklists, confidence building measures, and mock drills can all be very useful. Creating a strong hierarchical structure creates barriers, as you saw, to effective communication within a team, as witnessed in this clinical scenario of this OR technician. Instead of blame game, any wrongdoing should be dealt with in a humane, fact-finding method rather than witch hunting. So, again, how do you improve essay? The fifth thing, the critical analysis of the so-called near-miss events as well. In addition to mortality and morbidity meetings, there should be critical analysis of the so-called near-miss events as well. Near-miss events are those in which adverse events did occur. However, they were managed and the worst outcome averted without resulting in morbidity or mortality. So the methods to improve essay today, I choose to stay calm. Remaining calm, be calm. It should be emphasized particularly to junior colleagues to remain calm in crisis and to call out, not shout out or pass out. Calling for help from another colleague can be of immense value. Stay calm, take help. And finally, knowledge update. It is just impossible for a single surgeon to experience all adverse events in his lifetime. Therefore, to enhance this awareness, sharing experience on platforms like our ICCN International Conference on Complications in Neurosurgery, local body meetings, journals, relevant social media handle, all can definitely improve one's awareness and raise patient safety standards to which we are all committed. So please do attend these meetings of ICCN International Conference and the webinars that we are holding regularly on complications. I would conclude by saying, in addition to pure surgical skill, surgical awareness is an extremely important behavioral, non-technical, soft skill that must be learned, acquired, trained, and shared to minimize surgical errors and crisis mitigation. Structured teaching framework directed to improve situational awareness is the need of the hour. Awareness of safe to do, as we have proposed over here, in addition to the universal surgical checklist, will further help surgeons to counter adverse events during surgical procedures, however major or minor they may be, and raise standards for preventing patient safety. Remember, major complications occur with minor procedures, and that we have been continuously repeating in our recent webinars. Thank you very much. Dhanyavad.
Thank you. Well, Igor?
Yeah, thank you, Keki. Also very inspiring lecture. I was really impressed for the efforts you have done with ICCN, and the participation of neurosurgeons all around the world is increasing and increasing. We see the numbers. Any question from the panelists, Ramesh?
Okay, that was brilliant. I think it is the need of the hour. Overall, I think in the last few years, you have changed the paradigm. People are coming out their complications and presenting it, and such a great learning tool for everyone to see others' mistakes and then learn from it, which is, that is what is needed. You got to. This is what is about building up the experience. You don't have to build up your own. You don't have to rely on your own experience. You have to rely on everybody's experience. Whereas, if you combine all the experience from everyone, it's a massive treasure, and that's how you gain experience. Thank you for analyzing it and then doing it in a very structured manner, and that was brilliant. Thanks.
Thank you,
Professor.
Keiki compliments. And I think one of the major points that you said is that surgery is similar to aviation. And today, before I was just implementing this one. Pilots are trained, but they have a flight simulator and they have to go every single year to go there. And I think that surgery has to do the same things in the future, in the today's situation for the resident, but also not only for the resident, for experienced surgeon. Thank you again.
Yeah, there is something also about the same point as pilots. Even though nobody can be really trained for a specific crisis, you are training for the crisis possibility. All the time a plane is going to take off, there is a lot of checking and simulation and thinking. So you're in another spirit. So you cannot improvise in situation of crisis. So this is the spirit. I find this analogy very, very clever. Other comments?
Eka, I think Eka wants to say.
Eka.
Yeah, Keke, I think again, beautiful presentation, and especially your term of situational awareness, I think is not just unique, but it's really such an important concept because it changes the way we do things and make it a team sport with one goal, which is patient-centric, and it's all best outcome-oriented, and it doesn't matter how we get there, everybody has a role to play, which is a change in paradigm where, we used to be the most important person in the operating room, but in fact, the patient is the most important in the operating room, and everybody else is there just to serve a single goal, to get them through it and do the best thing. And I think you've put this together in a beautiful way. Once again, congratulations.
Thank you.
Excellent. Can I say a word?
Sure.
Fantastic, Keki. Excellent presentation. And as others have said, the analogy with the aviation industry is fantastic. So everything must be ordered, and that you don't assume that the other person has understood. There should be some repetition. I know I've been working sometimes in different countries because you have to move a bit around. And I think there is another concept we should introduce to say that medicine is like in the army. The junior cannot take on his own some decisions without informing the superior. It has to be like an army. And because sometimes you have some young people who do not actually know the consequences of taking an action. They think they know when they don't know. They don't even know what they don't know, So that aspect, I always repeat them. You know what? I'm the general, and you need to report to me before you do anything, even something you think you know. Thank you again, Keki.
Yes. I think the rate at which complications are still happening in our field, if those kind of complications have to occur in the aviation industry, the airlines would close down completely. So you can imagine the amount of care taken by the aviation experts. And
yes.
You know that we had such kind of people in our ICCN meetings also.
Absolutely, yes.
To advise us and to inspire us. Our first person who inaugurated our first ICCN was our ISRO chairman, space scientist.
Yes.
And during our second ICCN, we had a Air India pilot who managed a great crisis with carrying a Boeing plane of 350 passengers.
Yes.
When he ran short of all kinds of things, landing instruments were not working, fuel was not there anymore. So they had, and bad weather. So all three, now they say the simulation, they are prepared for simulation, but they have never prepared for this kind of a simulation, where you have all these conditions put together. So after that particular event, they have installed a new kind of a simulation technique. So I think this is what we have to keep learning from ours. We tend to brush aside complications. Oh, maybe it can happen. We should not happen next time. But we never go into the details of analyzing every step. Actually, you should, if you realize your own operations which you are doing from skin to skin, you realize that every single operation, I'm still learning from each operation. And I know that I can still make a single step or 2 or 3 steps in the operation a little better than what so you keep learning from yourself all the time. And you keep, of course, learning from others. And that is why our errors become less. Minimize errors by learning and by repeatedly doing something. The people are blind to their errors. And that is why we are going on shouting from rooftops. Please learn from mistakes, of our mistakes and mistakes of others. And simple procedures, I've shown you simple operations. Chronic subdural hematoma. So many complications. Ventricular peritoneal shunts. Endless complications. We cannot stop conferencing on these subjects. And this is all, I think, is all because of a lack of situational awareness. And it needs to be brought in for every operation. And I think, I cannot re-emphasize this, but I'm sure the point has been taken.
Yeah, thanks, Keke. Very useful considerations. I ask Professor Kanan to take over for final discussion. Comments.
Thanks, Igor. First of all, I'd like to thank all the panelists, all the members for having the stamina to stay that long, 6.5 hours of presentation and discussion. This reflects for me the commitment of the group, and that's what we'd like to see. And this is the recipe of success of this educational webinar. And I hope that the attendee, I'm sure they benefit from the different type of lectures that focus on education on top of anatomy, because these are essential lectures like the one from Keke, from Ramesh, and many of you, they gave a very nice educational presentation for the future learning of these young people. Now, two things I'd like to draw your attention. I hope most of you, or I'm aware that many of you will be coming to Bogota. So the pre-conference course is going on, and we got the approval for that. And there are some of the lectures that you have communicated with is scattered in the program. But the meeting in Rio de Janeiro is going on as well. I received a correspondence. Unfortunately, I cannot come as I have to meet my daughters, but Vladimir is going to take care of that, and the conference and the meetings and the lectures are as before. If somebody wants to change, please don't do this last minute changes, because it will affect the program for them. And Dr. Burba and Landero, they were kind enough to fit your lectures in this program. All right, so, and for the meeting in Bogota, on the day we are doing the pre-conference course, we were thinking of giving a 15 minutes or 20 minutes short meeting together to discuss about the future of the IANA and how we can improve it, and how we can, what other things we can add to the bylaws. There are many other factors you might like to give your input on it. And that's a venue available, hopefully in a democratic way. We don't want to impose on anybody, but it would be nice that everybody, if he is there, to attend that short meeting. And actually, that's all what I want to say. The presentation, as you heard, is recorded. Pablo, you might give them again. This is the IANA or international. Would you give them the address? They can open the link and see the recording and share it with their younger staff. Pablo?
Yeah, I'm going to copy it on the chat right now.
Okay. Well, and thanks to Pablo and other colleague, they have made this activities available on Twitter and Instagram as well, and the YouTube. So we have a wider range of attendees, and we are reaching to everybody. And I hope this year we will come with at least 5 to 6 webinars, if not more, because we want to alternate it with the hands-on courses. Colleagues that they have their own lab, they have their own meeting, hand-on, they can collaborate with the IANA. Of course, we give them the credit for the institution, and they should, but they can announce it through this venue, so we can have hands-on courses back in our mission. That's all what I have. If somebody wants to add something, please feel free. If not,
I would suggest just Pablo to add the program of the meetings in the platform, in the website, so the attendees can easily find content instead, of looking inside the video.
We'll see. We'll see how we are going to do it.
No, it's very easy.
Yeah. Okay. Right. And we are trying to distribute some of the work on the members, because I don't want to have this functionality only myself and Pablo. Pablo has been doing a great job, actually, and he is always available. But all of you and he himself and myself, we have works, and we should give some tasks. That's why I divided some of the director at large for some subspecialty like a vascular epilepsy, so they can come with some ideas that we can introduce a one-day session on some subject on top of the webinars. This is something that we can work it out among ourselves. I think we can discuss and talk, and I'm happy to see you all, but I think it's time. I see Dr. Takashi is ready for the blanket and turn off the light, and I wish you all a nice, good evening and good night.
Can I take my last class?
Yes, please.
As a photographer today? Can I get a...
Smile, hand up.
Thank you.
Take care. Bye-bye.
Thank you. Thank you, Imad.
Thank you. Thank you very much.
Good
to see you all.
Good night. See you.
Good to see you. Good to see our Hakuna Matata again.
Maybe you will be with us.
Yes, Keki.
Thank you very much, Professor Kana. Thank you.
Next time you come all to Zimbabwe.
Next time, Amir, next time. So we'll see you.
Thank you very much, Ramesh. I'm sorry it didn't work out today.
No, it's difficult.
Hey, Amir. Hi. I want to say hi to Amir.
Hey, Keki. Hi. It's been a
How are
long
you,
time.
Amir? Oh,
good, thank you.
That's a
Good,
good
thank you. I've
thing.
missed all of you, I must say.
No problem at all.
Hey, you're there still.
I had this problem just in this neurosurgical anatomy webinar, not of the International Academy, but Imad remembers that I had the same problem. I was unable to present my contribution. The next time you will be successful.
Thank you.
This is the message he received from me. He is not the first and not the last, and this is not the only opportunities. And we all look into the same problems.
Okay. Bye.
Thank you.
Francesco, come stai?
Come stai? God bless you.
Bene. Nonostante questo virus.
Namaste, Keki.
Namaste.
Ciao, ciao.
Ciao. Bye bye, Keki, Casadi.
Ciao, Giovanni.